by giving you the overview about the upper limb. See, in the upper limb, how we are going to do? We are going to begin with the axilla. Axilla is the gateway from where the neurovascular structures enter into the upper limb. Then we will have, after we are done with the axilla, the boundaries, content, and the clinical application. After that, we will be looking at the pectoral region, right? Then the deltoid region and the scapular region. So pectoral, deltoid, and the scapular region. After we are done with this around shoulder, then we will see the arm, cubital fossa, forearm, and palm. So this is how we are going to proceed. Clear? Now let us begin with the axilla. First topic that I am going to take is the axilla, and axilla will start with the boundaries of the axilla. So let us start with the first topic, axilla. This is the frontal aspect, and we can see this is pectoralis major muscle. We will talk about this muscle later, but right now we are only looking at it as a boundary of axilla. So this muscle is making the anterior wall of the axilla here, and deep to pectoralis major. As we understand, we have pectoralis minor. Is that fine? Yes. Now if you have understood this, let me add beta. Venous development will be taken along with the abdomen. Venous development will be taken along with the development of like abdominal structure. Then we will take the remaining part of the venous development, and today we are going to begin with the new topic, fresh topic, that is upper limb. Okay, all right, okay. All right, just a moment. Fine. Now anterior wall of the axilla is formed by the pectoralis major, whereas posterior wall of the axilla is formed by the three muscles together. Three muscles are what? Let me explain one by one. See, this is first muscle, very huge muscle coming from below, the latissimus dorsi. The second muscle is this one, that is teres. What is this muscle? Teres major muscle. Okay, teres major muscle. And now we can see a gap here. Do you appreciate this gap here? Yes. Now what muscle will be present here? Right? See, before talking about this, that which muscle is present here, let me give you one very important conceptual understanding of the scapula. Suppose this is the scapula, and this scapula is a thin blade, right? Thin blade. It has got one ventral aspect and the dorsal aspect. Yes, but scapula in the quadripods is like this. So it has got one lower surface and upper surface, right? Lower surface and upper surface. We don't have ventral and dorsal surface. I mean, we don't have anterior and posterior surface, right? We don't have anterior and posterior surface. Rather, we have lower surface and upper surface, which is called as ventral and dorsal. Ventral is towards the earth, and dorsal is away from the earth, right? Now see, because the position of the scapula is like this in the animals, the muscles present below the scapula are called as subscapularis. But in humans, we have now erect scapula like this. Because of the erect posture, scapula is like this. But still the muscle is called as subscapularis, as if below the scapula. Are you understanding this? Yes. So which nerve will be supplying here? Subscapular nerve. And which nerve will be supplying above the scapula? Suprascapular nerve. So subscapular nerve below the scapula, suprascapular nerve above the scapula. Is that fine? Is that fine? Clear hai? Right? Clear, no? Yes. So I have told you scapular nerve, subscapular nerve in front for us, for humans, क्योंकि we हमने क्या किया है, इरेक्ट पोस्चर ले लिया है. एनिमल्स में ऐसा था तो सबस्कैपुलर नर्व यहाँ और सुप्रास्कैपुलर नर्व अबव. अब ह्यूमंस के केस में anteriorly subscapular nerve, posteriorly suprascapular nerve, and there is one more nerve with the name scapular called as dorsal scapular. Dorsal scapular is medially present. It is medially present. Is that clear? Now there is this muscle which is coming from front of the scapula and filling the gap here. What is this muscle? This is subscapularis muscle. Do you understand this? So what we have learned the boundaries of the axilla. We have learned the boundaries of the axilla, and in the boundaries of the axilla, we have seen that we have anterior boundary made by the pectoralis major. We have beneath the pectoralis major, we have pectoralis minor, right? And posterior boundary is made by the latissimus dorsi, the this one teres major, and this one that is subscapularis, right? Let us take the notes for the axilla boundary, but just before that, let me show you this section. This section is actually passing through the axilla, and this image is very important for image based questions, right? Now what we have learned here is this: pectoralis major, deep to it is the pectoralis minor, making the anterior wall of axilla. What is making the posterior wall of axilla? Subscapularis. We can see the scapular blade here. We can see the teres major and the latissimus dorsi. These three muscles are making the posterior wall. Clear? What is making the medial wall? Ribs. And on the ribs, which muscle is there? This muscle is serratus anterior. This muscle is serratus anterior. Is that fine? Yes. What is making the lateral wall? The humerus. Which part of the humerus? The intertubercular sulcus region. Intertubercular sulcus region. Yes. And on the intertubercular sulcus region, we can see this sulcus is presenting with the lateral lip and with the medial lip. The lateral lip is where pectoralis major is attached. Medial lip is where the teres major is attached. Are you understanding? So this area presents three important muscles that can be remembered as lady between two majors. What is lady? Latissimus dorsi. So latissimus dorsi is present in the floor. Lady on the floor. Okay. So latissimus dorsi in the floor, and the two lips are taken by two majors. What are two majors? Pectoralis major laterally and the teres major medially. Clear? Is that clear? Yes, we have seen the boundaries medial, lateral, anterior and posterior for the axilla, and I have also described the intertubercular sulcus region where we have three important muscles attached. Along with that, we can see the contents. Here. Contents can be seen in this sheath. This sheath is called as axillary sheath. Right? And in the axillary sheath, we have the content that is axillary artery, axillary vein, and the cords of brachial plexus. Is that clear? So you have understood now what are the boundaries of the axilla, what are the contents of the axilla. Let us take the notes for the axilla and let us start discussing the contents of the axilla. Is that fine? Yes. Let us start with that. First topic of upper limb is axilla. First topic. Axilla, right? Now, what are the boundaries for the axilla? Anterior wall is formed by pectoralis major and pectoralis minor. Posterior wall is formed by three muscles together, that is subscapularis, teres major, right? Teres major, pectoralis major, pectoralis minor are making the anterior wall. Posteriorly, it is made by subscapularis, teres major, and latissimus dorsi. Latissimus dorsi. Fine. What makes the medial wall? What makes the medial wall? Medial wall is made by upper 4-5 ribs. What makes the medial wall? It is formed by upper 4 or 5 ribs, upper 4 to 5 ribs, and along with that serratus anterior muscle. Along with that serratus anterior muscle, and lateral is formed by intertubercular sulcus region of humerus, right? These are the boundaries for axilla. Clear? Now what are the contents? What are the contents? Before coming to the contents proper, let me give you one diagram, and that diagram will also give you the orientation and interrelationship of the upper limb, thorax, and head and neck region. Okay, let me give you that diagram. See, if we are looking at the sternum, this is sternum. Okay, what is this? Is the manubrium part and the body part. Behind we have vertebrae. These are vertebrae with the transfer processes. These are the vertebrae. These are the vertebrae. Now, which vertebrae are these? These are cervical vertebra. These are cervical vertebra. Okay. Suppose this vertebra is T1. Suppose this vertebra is T1. Above that, there will be cervical vertebra. Suppose this vertebra is T1. If this is T1, there will be this rib coming, because thoracic vertebra will present the rib. Are you understanding? On the thoracic 1 vertebra, first thoracic vertebra, which rib is attached? First rib is attached. Are you following this? Are you following this? So what we are looking in front, try to understand this in 3D. In front we are looking at the manubrium part and the body of the sternum part. Behind we have the T1 vertebra, and on the side we have the rib. On the side we have the rib. That means this is what? This is thoracic cavity. What is this? Is the thoracic cavity. Is that clear? Yes. Are you guys understanding this? Now, if this is the manubrium and this is the first rib, there along with the sternum, there is another bone attached here, that is clavicle. What is this bone? Clavicle. And behind we have superior border of the scapula. With the scapula, what is attached? With the scapula, what is attached? That is humerus. Okay, this is humerus. This is superior border of scapula. What is this? Is superior border of scapula. Now, do you understand that these three structures, okay, this, and this, they are making the boundaries for the inlet of the axilla, from where the structures will enter into it. These are nothing but inlet boundaries. Inlet. Okay, this is inlet of the axilla. What is this? Is inlet. So inlet is bounded by outer border of the first rib, clavicle, and the superior border of scapula. Is that fine? Yes. Now let me add something here, that from the cervical vertebrae, we have this muscle this muscle which is coming from the cervical vertebrae, and it is attached on the first rib. What is this muscle? Can you tell? Can you tell what is the name of this muscle? Scalenus medius. Scalenus medius. There is one more muscle coming which is attached also on the first rib. From the cervical vertebrae only, this muscle is coming, and this is what? Scalenus anterior. So what are the labeling? This muscle is scalenus medius, the posterior one which it looks like posterior. This is scalenus medius, and this muscle is scalenus anterior. Yes. Now we have this artery from inside the thoracic cavity. We have the heart. With the heart we have the ascending aorta. From the ascending aorta, arch of aorta, and from the arch of aorta we have the subclavian arteries coming. Yes, from the arch of aorta we have seen the left subclavian artery directly, and via the brachiocephalic trunk the right subclavian artery. Anyway, we have subclavian arteries coming. The subclavian artery is coming from within the thoracic cavity, and they will pass behind the scalenus anterior muscle. That means between scalenus anterior and scalenus medius, this artery is subclavian artery. Are you understanding this? When this artery is passing behind the scalenus anterior muscle, now we can say the scalenus anterior is dividing the artery into three parts. We can say the scalenus anterior is dividing the subclavian artery into three parts. What are the three parts? First part of the artery is this, which is proximal to the muscle. Third part is this, which is distal to the muscle, and the second part is behind the muscle. Second part is behind the muscle. Are you understanding? Three parts of the artery by the scalenus anterior muscle. Now the artery, as soon as it crosses the outer border of first rib, from within the thorax it is coming, it crosses the first rib. As soon as it crosses the first rib, what will happen? It will enter into the axilla. Now, because it has entered into the axilla, the same artery will be called as axillary artery. Are you understanding? There will be no change, no diameter change, nothing. Okay, blood flow, diameter, most of the aspects of the artery is same, but the region changes. Subclavian artery will continue as axillary artery beyond first rib, beyond outer border of first rib, right? Now the axillary artery is there in the axilla, and we have one muscle which is coming from third, fourth or fifth rib, third, fourth and fifth rib, and this muscle is going for the insertion on the coracoid process. What is this muscle? This is pectoralis minor muscle. What is this muscle? Pectoralis minor muscle. Yes. Now we can see in this diagram, the pectoralis minor muscle is also dividing the artery into three parts. What is the first part? Proximal to muscle. What is third part? Distal to muscle. And the second part is actually behind the muscle. Are you understanding? Here we have seen how subclavian artery has entered into the axilla, and how subclavian artery is divided into three parts, and how axillary artery divided into three parts. Is it clear by which muscle it's happening? Also in the diagram we have learned what is inlet. Also in the diagram we can see the nerves, the brachial plexus nerves, because from this part only, from in between the vertebra, we can see the roots are coming. We can see the cervical roots are coming. On their way they will make the brachial plexus. And finally brachial plexus will also enter into the axilla. Are you understanding? So the green color arrow is showing, the green markings are showing the cervical roots, cervical nerves. They are also coming from the cervical region. They enter into the axilla between scalenus anterior and scalenus medius. So we have seen the scalenus anterior is attached on the first rib. That's true. Scalenus medius is also attached on the first rib. That is again true. In between these two muscles, we have subclavian artery passing, and we have the nerves passing. Which nerves? The brachial plexus. The brachial plexus is passing in between these two muscles, right? But the vein, the subclavian vein, will pass anterior to the muscle. What is this vein? Subclavian vein. Subclavian vein is present anterior to the scalenus. It is present anterior to the scalenus anterior muscle. It is not behind. Okay, are you understanding now? It is present anterior to the muscle. That means the vein is not between the scalenus anterior and scalenus medius. It is anterior to the scalenus anterior. Yes, all the relationship is clear. This is very, very important. And also one important point here, we have three scalene muscles, scalenus anterior, medius and posterior, which is not attached on the first rib. Scalenus posterior is not attached on the first rib. Scalenus posterior is attached on the second rib. It is attached on the second rib. Clear? Anterior and medius are attached on the first rib. This is the important relationship which will give you the, I hope it is clear, and I hope you have understood from where the subclavian artery is coming and it is becoming axillary artery, and from where the brachial plexus is coming, how it is entering into the axilla. Is it clear? Yes? समझ आया बच्चों? ठीक है, यहाँ तक क्लियर हो गया आप लोगों को? अब हम लोग एक्सिलरी आर्टरी को डिस्कस करेंगे, बिकॉज नाउ वी आर गोइंग टू स्टार्ट द कंटेंट ऑफ द एक्सिला, एंड व्हेन यू टॉक अबाउट द कंटेंट ऑफ द एक्सिला, वी आर गोइंग टू स्टार्ट विद द एक्सिलरी आर्टरी. Okay, what is the contents of the axilla? Important contents of the axilla, important contents of the axilla are axillary artery, axillary vein and brachial plexus. So these are important things that we need to discuss. Let us start with the axillary artery. Let us write down the points about the axillary artery. Let us write down the points about the axillary artery. Right, axillary artery, please write down the points. It is continuation of, it is a continuation of subclavian artery. It is continuation of subclavian artery beyond first rib, beyond first rib. Okay, so this is important statement, that it is a continuation of subclavian artery beyond first rib. Second point, it will continue as, it will continue as brachial artery. It will continue as brachial artery. At which point? Beyond teres major. Beyond teres major. As soon as it crosses the teres major, we say it has become the brachial artery. Yes. And now we can say it is divided into three parts. It is divided into three parts by pectoralis minor. Okay, these are important statements and important questions. These are important statements and important questions. Now we have seen the pectoralis minor is dividing the artery into three parts. First part, second part and third part. First part, second part and third part. First part, second part and third part. Okay, what are the branches of these artery? What are the branches from these parts of the artery? We can remember the mnemonic. We can remember the mnemonic for the branches. What is the mnemonic? Salt spa. Salt spa. Okay, salt spa. How to remember the meaning? Let us divide this way. We must understand that first branch will give one, first part of the artery will give one branch. Second part will give two branches. Second part will give two branches. And third part will give three branches. Fine. Now, this T here is thoracic, and this is common. Common means it will be used with the superior, acromio and lateral. Now let me tell you how to remember. S for superior. Add T. Add T means thoracic. So what is the name of the artery? Superior thoracic artery. Then A for acromio. Acromio. Add T. That is thoracic. L for lateral. Add T. That is thoracic. So two branches from the second part: acromiothoracic, lateral thoracic. Is that clear? Superior thoracic, acromiothoracic and lateral thoracic. Now what is S? S is subscapular. What is S? S is subscapular artery. What is P and A? See, subscapular artery is From the third part, yes. Now we are left with P and A. P and A can be remembered as Pacha and Acha. What is Pacha Acha? What is Pacha Acha? Pacha Acha is nothing but posterior and anterior circumflex humeral artery. What is that? Posterior circumflex humeral artery and anterior circumflex humeral artery. Is that okay? Yes. Did you learn the branches of axillary artery? Are you guys done up to this? Are you understanding? Yes. समझ आ गया यहां तक आपको? सुपीरियर थोरेसिक फर्स्ट पार्ट से सिंगल ब्रांच और सेकंड पार्ट से दो ब्रांचेस, थर्ड पार्ट से तीन ब्रांचेस, राइट? सॉल्ट स्पा, सुपीरियर थोरेसिक, एक्रोमियोथोरेसिक, है ना? लेटरल थोरेसिक, देन सबस्कैपुलर, पच्छा एंड अच्छा. ठीक है, डन हो गया यहां तक? ऑलराइट. Now sometimes further branches of acromiothoracic are asked. Sometimes acromiothoracic further branches are asked. What are these branches? Branches can be remembered as A, B, C, D. What is the A, B, C, D? Acromiothoracic will further give A, B, C, D branch. Acromial artery, B for breast or pectoral. That is for the pectoral region. C is clavicular and D is deltoid. मजा आ गया? वेरी गुड. मजे लेते रहो, एंजॉय करो क्लास को. ठीक है, तो ये है हमारी आर्टरीज की कहानी. यहाँ तक हमने आर्टरीज के बारे में पढ़ा. वेरी गुड. अब हम लोग देखते हैं ब्रैकियल प्लेक्सस को, विच इज वेरी इजी अगेन, है ना? दीज थिंग्स आर वेरी वेरी इजी. आई एम ट्राइंग टू गिव यू द कंसेप्चुअल थिंग्स. नाउ ब्रैकियल प्लेक्सस. व्हाट इज ब्रैकियल प्लेक्सस? प्लीज राइट डाउन विद मी. Brachial plexus is formed by the ventral rami. It is formed by the ventral rami of C5 to T1. Ventral rami of C5 to T1. If C4 is involved, suppose by chance C4 is involved, then we say it is prefixed type. And if T2 is involved, then we say it is post-fixed type. Right? Clear? Prefix and post-fixed type. See, after that, we need to mark the formation of brachial plexus. What is the formation? For formation, you need to write root, trunk, division, and chord. Division and chord. What is root, trunk, division, chord? We have C5, C6, C7 and C8 and T1. These are the roots for the brachial plexus. C5 and C6 they come together. C5 and C6 they come together and they make the upper trunk. C8 and T1 they come together to make the lower trunk. So this is lower trunk, this is upper trunk, and C7 runs alone to make the middle trunk. Are you understanding? Yes. Now everything is going to divide into two branches. Anterior divisions. This will make anterior division and posterior division. Anterior division and posterior division. So we have anterior division, posterior division, anterior division, posterior division, anterior and posterior division. Total 3 trunks are dividing into 2 divisions. So in total we have 6 divisions. Out of 6 divisions, 3 are anterior and 3 are posterior. Now it is very interesting to note that all 3 posterior divisions will come together. All 3 posterior divisions will come together to make the posterior chord. Out of 6 divisions, 3 posterior divisions are gone. Now we are left with 3 anterior divisions. What are they going to make? The anterior division of upper and middle, they will come together to make the lateral chord, Whereas the anterior division of lower trunk will continue as the medial chord. So this is how the formation of brachial plexus takes place. This is how the brachial plexus takes place. ओके बेटा, पहले इसको बना लो, फिर दिखा देता हूँ वो पॉइंट्स भी. ये तो बना लो, ये छूट जाएगा फिर, है ना? Write down these points. Whatever is missed, I'll show the brachial artery, the axillary artery. Okay. These are the points. Ventral rami of C5 to T1. If C4 is involved, we say prefixed. If T2 is involved, this is postfixed. These are variations. C4 and T2 is not normally present. What is normally present is C5 to T1. But as a variation, if C4 is present, we say prefixed type. As a variation, if T2 is also involved along with C5 to T1, we say postfixed type. Clear now? Yes? And then I have drawn a diagram and I have explained how the formation of brachial plexus takes place. I hope, is it clear? Is it clear? Yes? Now let me show you the axillary artery 3 points. These were 3 points of the axillary artery. Please quickly note down, and then we will be writing about the branches of brachial plexus. Its continuation of the subclavian artery beyond first rib. I have explained with the diagram, if you have seen. It will continue as brachial artery beyond teres major, and it is divided into 3 parts by pectoralis minor. Yes? ठीक है बेटा? अब स्टार्ट करते हैं ब्रांचेस ऑफ द ब्रैकियल प्लेक्सस. ब्रांचेस ऑफ द ब्रैकियल प्लेक्सस. Branches of the brachial plexus from the roots. What are the branches from the roots? One is dorsal scapular. Dorsal scapular. Dorsal scapular nerve is going to supply which muscle? It is going to supply the, yes, that means now we are looking at which aspect of the scapula. See, the I told you in the beginning of the class that scapula will, with relation to scapula, we have 3 nerves: subscapular, suprascapular, and dorsal scapular. This was the position of the scapula: subscapular anterior, suprascapular behind, and dorsal scapular medially. Now, if it is coming medially, which muscles are going to be supplied? The one which is present on the medial aspect. What is the muscle on the medial aspect? Rhomboideus. So rhomboideus major, rhomboideus minor, and along with these 2 muscles, it also gives twig to levator scapulae. Also, it gives twig to levator scapulae. Okay, clear? Now there is one more branch from the roots. What is the branch from the root? Is long thoracic nerve. Long thoracic nerve. Long thoracic nerve. Long thoracic nerve is also called as nerve of Bell. It is also called as nerve of Bell. And the nerve of Bell is going to supply which muscle? Serratus anterior muscle. Serratus anterior muscle. Okay. In case of any injury to the nerve. But before that, let us also write down the root values. Dorsal scapular is coming from C5 and the long thoracic is coming from C5, 6 and 7. Now in case of any injury to the long thoracic nerve, there will be paralysis of the serratus anterior. there will be paralysis of the serratus anterior and the patient will present to you with winging. In case of injury, there will be winging of scapula. Such winging is called as winging in action. What is the winging in action? इसका मतलब है जब आप पेशेंट को कुछ एक्शन करने के लिए बोलते हो तब विंगिंग डेवलप होती है. When you ask the patient to do some action, then only the winging will develop. The patient is not presenting to you with the winging itself. Are you understanding? So this winging will only develop after doing some action. So that is why it is called as winging of scapula in action. Usually this is the winging that is described clinically. So they don't write in action. They don't write in action. So in case the question is given to you and they have not specified which winging, then you consider it as in winging in action, and it is because of serratus anterior, which is commonly seen because of serratus anterior. Why I am emphasizing? Because not related to serratus anterior, but then there is another important point, winging at rest. Sometime question can be given winging at rest. Now if the question is framed on winging at rest, they have to specify. They will specify that winging at rest means the patient is presenting with the winging, then answer should be trapezius. Winging at rest is because of trapezius paralysis, not because of serratus anterior paralysis. But winging in action is because of serratus anterior paralysis. Is that fine? Yes. Now we are done up to the branches from the roots. Now we are going to talk about the branches from the trunks. When you talk about the branches from the trunk, it is only upper trunk which gives branches. There is no branch from the middle trunk or the lower trunk. Upper trunk gives two branches. What are the two branches? Yes, first branch is nerve to subclavius. First branch is nerve to subclavius. Obviously, it is going to supply which muscle? Subclavius. The name itself says subclavius. Second nerve is suprascapular nerve. Suprascapular nerve. Now again the suprascapular word has come. Where should be the suprascapular nerve present? Anterior to the scapula or behind? Tell me the answer, beta. It should be anterior to the scapula or behind the scapula? It should be behind the scapula. Now if you look at behind the scapula, we have a spine. Above the spine, supraspinatus. Below the spine, infraspinatus. So both these muscles, supra and infraspinatus, will be supplied by suprascapular nerve. Suprascapular nerve. Is that okay? So we have supraspinatus and infraspinatus. Yes. Are we done? Yes. Now, what about the codes? We have three codes to discuss. That is lateral code, medial code, and posterior code. Lateral, medial, and posterior code. For the lateral code, branches mnemonic is LML. Right? For the medial code, we have the mnemonic M4U. For the posterior code, we have mnemonic ultra. Fine. Lateral code, what should be the root value? Let me take you back to the diagram. And upper trunk, what should be the root value? Let me take you back to the diagram. Upper trunk is formed by C5 and C6. So upper trunk will be having root value C5 and C6. Now this C5, C6 is attached with the C7 fibers coming from here. So the lateral code root value is C5, 6 and 7. The lateral code root value is C5, 6 and 7. C5, 6, 7, okay? C5, 6 and 7. Medial code root value is coming from C8 and T1. So medial code root value is C8 and T1. Posterior is having root value from C5 to T1. Is that clear? These are the root values of the codes. I'm not telling that is a root value of the branches. We have to see the root value of the branches individually. Upper trunk is having C5, C6. Both the branches are having the same root value C5, C6. Clear? Now lateral code is having this root value C5, 6, 7. medial chord C8T1 and posterior chord C5 to T1. These are the root values of the chords. Now what are the branches from here? L is lateral pectoral nerve. Lateral pectoral nerve. This L is lateral root of median. Lateral root of median. And this M is musculocutaneous nerve. Musculocutaneous nerve. Okay. And root value of everyone here is C5, 6 and 7. There is no like confusion. Lateral chord gives C5, 6, 7 to all the branches. Now what about the medial chord? When you talk about the medial chord, we have these two L. Their counterpart will be seen in the medial chord. That means lateral pectoral in the lateral chord, medial pectoral in the medial chord. Medial pectoral in the medial chord. Lateral root of median in the lateral chord, medial root of median, medial root of median in the medial chord. After that we are left with 2M. These two are cutaneous nerves. What is the meaning? Medial cutaneous nerve of arm and medial cutaneous nerve of forearm. Okay, medial cutaneous nerve of arm and medial cutaneous nerve of forearm, and U is ulnar nerve. Ulnar nerve. Fine. What is the root value? What is the root value for these branches? Root value is the C8 and T1, but for ulnar nerve C7, C8 and T1. How come? See, C8 and T1 is justified because this is coming from the code, but additional C7 fibers, these are handed over by median nerve. Median nerve hands over C7 fibers to ulnar nerve. So altogether ulnar nerve root value becomes C7, C8 and T1. Is that fine? Yes. Now coming to ultra. What is the meaning of ultra? We have upper subscapular nerve and lower subscapular nerve. T is thoracodorsal nerve. R is radial nerve and A is axillary nerve. Is that fine? Yes. Upper subscapular, lower subscapular, thoracodorsal, radial and axillary. Now upper subscapular is going to supply which muscle? Obviously the name says subscapular, so it must supply subscapularis, and lower subscapular will supply subscapularis plus teres major. Along with the subscapularis, it is going to supply the other muscle is teres major. Thoracodorsal is going to supply latissimus dorsi. Radial nerve is going to supply the extensor aspect. So many muscles are there. Axillary is going to supply deltoid plus teres minor. So we have got two teres muscle, teres major and teres minor. They are actually taking the nerve from, like, sharing the nerve with some other muscle. Lower subscapular will supply the subscapularis plus teres major, and axillary is going to supply the deltoid plus teres minor. Is that clear? Yes. Is that clear? What is the root value? What is the root value? Let me tell you. Upper and lower subscapular, they are having root value C5, C6. They are having the root value of C5 and C6. Axillary is also having root value C5, C6. Thoracodorsal is having root value C6, 7 and 8, and the radial is having the root value from C5 to T1. Okay, so if you write ultra, you can remember that on the sides, ultra, we have subscapular nerve on the side and the axillary nerve on the side. these two nerves which are present on the side are having root value C5 and C6. They are having the root value C5 and C6. Okay, but the thoracodorsal nerve is having root value of C6, 7 and 8, and radial is having all root values. Radial is having all root values. Is that clear? Yes, clear हो गया आप लोगों को? ठीक है बेटा? Yes. Now we are done with the branches. Let us talk about the injuries. Let us talk about the injuries. Let me show you. Well, let us take one question and then let us see how the injury takes place. Take this question. Which among the following is a branch from the trunk of brachial plexus? Which among the following is a branch from trunk of brachial plexus? Can you tell? Yes, when you look at the answer, A is true. Yes, D is also true. These two are not true. But we have to mark one. We have to mark one. Then why this question is there? This question is going to check your knowledge for the update. Answer is D, better than A. Why? When both of them are true, why we are writing D? It is according to Gray's 41st edition. The Gray's 41st edition says that suprascapular nerve may come from root. It may come from root. Sometime it may come from roots. Sometimes, not always, but sometimes. Is that fine? Yes. Now let me as describe the let us take this question. Which of the following nerve carries the fiber from all the roots of brachial plexus? Now we have seen that all the roots were present in the radial nerve. Radial nerve, you remember radial nerve was having C5 to T1? Yes, but radial is not given in the choices. Answer is median because it is having two roots, lateral root and the medial root. Lateral root is having C5 to C7 and this one is having C8 to T1. So altogether median will be having C5 to T1. But let me tell you, if radial and median both are there in the choices, go with the radial. Okay, why not median? Although 5 roots are present in the median, every segment is not dominant. Okay, so that detail is not required. Remember, if radial is not there in the choices, go with median. If it is there in the choices, go with radial. Better answer. Now see what is happening here. This is the mode of injury. This is the mode of injury. What is happening in the mode of injury that during delivery, है ना? क्या कर रहे हैं? ये the baby's head and neck given some pressure so that this is like undue abduction of the neck. So that there is undue abduction of the neck. This can occur during childbirth or during in adults during playing or something sports activity or outdoor activity. What will happen here? There is fall on the neck, the undue abduction of the neck, which will result into the avulsion of upper trunk. ठीक है, upper trunk की injury हो जाएगी Erb's palsy. What palsy is this? Erb's palsy. Okay, Erb's palsy, right? Clear है? Yes, so these are two modes. These are showing only the modes, how the upper trunk injury will take place. How the upper trunk injury will take place. Now, how the lower trunk injury will take place? See, in the lower trunk injury, what is happening? In the lower trunk injury, what is happening? During the childbirth, if the hand of the baby is pulled like this, then it might happen. Or sometimes history is given that a person is falling from, like it is having free fall from the height he is falling. On his way, he saw one branch of the tree. He tried to grab it, and while grabbing, because of the momentum, the undue abduction of the shoulder takes place. Undue abduction of the shoulder takes place, leading to the avulsion of or injury to lower trunk of the brachial plexus. Are you understanding? These are two modes of injury. Now let me tell you कि ये जो मोड ऑफ इंजरी है, दिस मोड ऑफ इंजरी इज ओनली फॉर इलस्ट्रेशन. this is only for illustration. In clinical practice we'll never do such delivery कि hand of the baby is coming out and we pull like this, है ना? ऐसे कभी होता है? कभी सुना है आपने या देखा है कभी, या किसी को करते हुए कि ऐसे हैंड को पकड़ के खींच दिया, है ना? ऐसा तो कभी भी नहीं होगा. इफ द हैंड इज कमिंग आउट, है ना, इसमें तो नॉर्मल डिलीवरी भी नहीं कराते हैं, सीएस कराएंगे या जो भी इसका प्रोटोकॉल है ना, लेकिन ऐसे तो नहीं करेंगे ना कि हाथ को पकड़ के खींच दिया, है ना? दूसरा, ये दिस इज ओनली फॉर इलिस्ट्रेशन कि अगर ऐसे करें तो हो सकता है. दिस इज ओनली शोइंग दैट. ओके. अब ये जो पार्ट है, ये वाला जो पार्ट है, इसमें क्या है? इसमें एक पर्सन था. ये पर्सन ऊपर से गिर रहा था, इज फॉलिंग फ्रॉम द हाइट, है ना? इसने गिरते गिरते देखा कि कोई जैसे गिर रहा है, ट्राई कर रहा है कुछ पकड़ने की. रास्ते में इसको एक ट्री की ब्रांच मिली या कुछ भी एक ऑब्जेक्ट मिला, इसने उसको लपकने की कोशिश की, है ना? लपकने के बाद क्या हुआ कि इसका लपकने के बाद क्या हुआ कि इसका जो है ना इंजरी हो गया लोअर ट्रंक में, है ना? इससे क्या होगा? इसको क्लम्प केस पैल्सी हो जाएगा, क्लम्प केस पैल्सी, है ना? अब सपोज करो इस आदमी को पहले से ये बात पता थी कि भाई अगर ऐसे किया जाए तो क्लम्प केस हो सकता है, तो भी अगर ये आदमी ऊपर से गिर रहा है, पूरा फ्री फॉल हो रहा है, तो और उसको रास्ते में एक ट्री की ब्रांच मिली, तो उसको पकड़ने की कोशिश करेगा ना. ऐसे थोड़ी करेगा कि नहीं नहीं मैं इसको नहीं पकड़ूंगा, क्लम्प केस ना हो जाए, बाकी मेरा जो होता है होता रहे, बचू तो बचू कोई बात नहीं, नहीं तो कोई बात नहीं है, लेकिन क्लम्प केस नहीं होना चाहिए. ऐसे थोड़ी सोचेगा, है कि नहीं? तो बट ये सिर्फ इलिस्ट्रेशन के लिए है कि अगर ऐसा हो तो ये होने के चांसेस हैं. आर यू अंडरस्टैंडिंग? और एनी अदर इंजरी जिसमें लोअर ट्रंक का अनड्यू एबडक्शन हो जाए तो क्लम्प केस होगा. दिस इज ओनली अ वे टू टेल. इज इट क्लियर? समझ आई बात आपको, है ना? यस. चलो अब हम लोग स्टार्ट करते हैं. लेट अस राइट द नोट्स, है ना? लेट अस राइट द नोट्स. इंजरीज क्या क्या होती हैं इसमें? एक होती है अब्स की इंजरी, अपर ट्रंक इंजरी. लेट अस स्टार्ट विद दैट. ओके. अब्स इंजरी, अब्स पेल्सी एंड क्लम्प केस पेल्सी. अब्स पेल्सी में अपर ट्रंक इज इन्वॉल्व. अब्स पेल्सी में अपर ट्रंक इज इन्वॉल्व. क्लम्प केस में लोअर ट्रंक इज इन्वॉल्व. What are the root values? Root value is C5, C6, C5, C6 and C8 and T1. What will be the presentation? Policeman tip deformity. Policeman tip deformity. और यहां पे क्या होगा? क्लो हैंड प्लस हॉर्नर सिंड्रोम, प्लस हॉर्नर सिंड्रोम. ये ठीक है, हमने नोट्स ले लिए कि अपर ट्रंक और लोअर ट्रंक की इंजरी हो रही है, ये रूट वैल्यूज जा रही हैं और ये प्रेजेंटेशन है. बट हमें लर्न करना, हमें अंडरस्टैंड करना चाहिए कि कैसे ये डेवलप हो रही हैं, कैसे ये इंजरीज डेवलप हो रही हैं. लेट मी टेल यू व्हाट इज द मोड ऑफ इंजरी, हाउ policeman tip deformity and how this deformity develop. So let us now go into a little bit of detail. Fine. See, if C5 C6 injury is there, है ना, all the fibers, all the nerves where C5 C6 is involved will be injured, है ना? ऐसा नहीं है कि बाकी nerves injured नहीं होंगी, but clinically what has been observed, the most commonly injured nerve in upper trunk injury is axillary nerve, suprascapular nerve and musculocutaneous nerve. Now, these are quite frequently or commonly involved nerves. I'm not saying other nerves cannot be involved. They can be involved. But these are always involved and these lead to the formation of features. Now, let me explain how. Axillary is going to supply deltoid plus teres minor. Suprascapular is going to supply infraspinatus and supraspinatus. Fine. Musculocutaneous is going to supply three muscles which can be remembered as BBC. What is BBC? Biceps brachialis, biceps brachialis and coracobrachialis and coracobrachialis. ठीक है, ये क्या है, हमारी नर्व्स हैं जिन्होंने डिफरेंट मसल्स को सप्लाई किया है. डेल्टोइड एंड टेरेस माइनर बाय द एक्सिलरी, सुप्रा इंफ्रास्पाइनेटस बाय द सुप्रास्कैपुलर नर्व, बीबीसी supplied by the musculocutaneous nerve. In the BBC we have biceps brachialis and coracobrachialis. These three BBC muscles are actually the muscles of arm, front of the arm. Okay, now what is the normal action of these muscles? What is the normal action of these muscles? Deltoid is involved in the abduction. Supraspinatus is also involved in the abduction. Are you understanding? Deltoid and supraspinatus are involved in the abduction of the arm, right? And teres minor and infraspinatus together, they are medial rotator. Infraspinatus and teres minor are lateral rotator. Okay, infraspinatus and teres minor are lateral rotator. Fine, clear hai? Now what will happen here if abduction is not possible because of injury? Abduction तो हो नहीं रहा, arm की position क्या हो जाएगी? Abduction नहीं हो रहा means arm will become adducted. Lateral rotation नहीं हो रहा means arm will be medially rotated. So adducted, there will be adduction, and because lateral rotation is not taking place, there will be medial rotation. Adduction and medial rotation of arm will be seen. Are you understanding this? Yes. Now biceps जो है, it will do biceps and brachialis together will do flexion. Biceps and brachialis, and now I am focusing on this part. Please follow with me. Try to note down with me. Okay, please take the notes quickly so that we can use the time for explanation. Okay, see, biceps and brachialis both are doing the flexion of the elbow. Biceps alone is powerful supinator. Also there is this muscle, supinator muscle also does the supination. Supinator is also involved here. Supinator is also gone. It is also supplied by C5 C6 fibers. Remember this point. It is not supplied by musculocutaneous, that's fine, but it is also involved because the C5 C6 fibers only supply the supinator. Anyway, the powerful supination is gone because of biceps involvement. Flexion is gone because of biceps and brachialis involvement. These two will not take place. What will happen? Pronation and extension. So the arm will not be flexed, rather extended. Arm will not be supinated, rather pronated. Okay, so this will occur at forearm position. Are you understanding this? Yes, are you understanding this? यहाँ तक समझ आ गया? What about the coracobrachialis? Let me write one very important concept here. See, musculocutaneous root value is C5, C6 and C7. Remember, C5 and C6 segments supply here. That means C5 and C6 supply biceps and brachialis, whereas C7 fibers supply coracobrachialis. Although C5, 6 and 7 are there in the musculocutaneous, but C7 fibers dominantly supply coracobrachialis and 5 and 6 are dominantly supplying biceps and brachialis muscles. Yes. Now in the Erb's palsy, which segment is not involved? C7 is not involved. If C7 is not involved, which muscle will not be paralyzed, or you can say which muscle will be spared? The coracobrachialis will be spared. This is an important question which has already been asked. So which muscle is spared in the Erb's palsy? Answer: coracobrachialis. Why? Because it is supplied by C7 fibers. Is that clear now? Yes. Now we have come to conclusion that arm is adducted and medial rotated, forearm is pronated and extended. These two conditions taken together is called as policeman tip deformity. Policeman tip deformity, as if policeman is asking for the tip, or waiter's tip deformity, as if the waiter is asking for the tip. Okay, so this has been described in the books like this. Okay, is it clear? Now let us go to the lower trunk injuries, clump case palsy. Clump case palsy, आई होप कि आपको समझ आ रहा है अपर ट्रंक की इंजरी कैसे डेवलप हुई है, क्या बना है ना। अब लोअर ट्रंक की इंजरी को समझते हैं कि क्लो हैंड कैसे बनेगा। लोअर trunk injury, what will happen in the lower trunk injury? See, C8 and T1 fibers are gone. C8 and T1 fibers, they supply intrinsic muscles of hand. They supply intrinsic muscles of hand. If intrinsic muscles of hand are paralyzed, there will be difficulty in doing the movements of the hand muscles. जो भी hand muscles के movement हैं, those will be those will be present in such patient. That is true. But what will be the presentation of the patient? What is the presentation of the patient? What is the presentation of the patient in case of intrinsic muscle of the hand injury? क्या होगा इसमें? See, we have lumbrical muscles. We have lumbrical muscles which will give you the presenting features. Lumbricals. Now, lumbricals, what is their action? Lumbricals, what is their action? Lumbricals, what is their action? The lumbrical works at two joints, MCP joint and IP joint. What is MCP? Metacarpophalangeal. What is IP? Interphalangeal. Okay. Now, lumbrical action can be remembered by those who know the action very well and good. For those who don't know the action, let me tell you, you remember there is a show, Kapil Sharma show. In the Kapil Sharma show, there is a term called as Baba Ji ka Thullu. You have seen Baba Ji ka Thullu. Very good. तुषार, आपने पहले से ही, you know that you have attended this class. Thullu formation. Now you see Babaji ka Thullu is like this. Now try to understand this Thullu anatomically. Try to understand this Thullu anatomically. What you are doing when you are trying to make the Thullu, you are flexing the metacarpophalangeal joint and you are extending the interphalangeal joint. Are you understanding? When you are making the Thullu, you are doing the flexion at MCP joint and you are doing the extension at the IP joint. So what is the normal action of lumbricals? Normal action is MCP flexion and IP extension. I want every one of you to remember this. Very good, Ashwathi. Lumbrical. Finally, shape becomes L-like. Very good. So remember Thullu और remember L, है ना, जो आपको ठीक लगती है, ठीक लगता है ना, उसी हिसाब से करो। जो भी न्यूमोनिक आपको सूट करता है वैसे याद कर लो, ठीक है। अब मान लो कि lumbricals काम नहीं कर रहे, flexion at MCP will not take place, extension at IP will also not take place. What will happen? The reverse. MCP will undergo extension, IP will undergo flexion. Are you understanding? Now, if I try to extend the MCP joint, hand will become straight. Yes. I try to make the IP flexion, it will become like claw. Are you understanding? That means if this happens, the patient is going to present to you with the claw hand. Also, T1 fibers are having sympathetic fibers in it. You remember we have been talking about sympathetics, thoracolumbar, T1 to L2, T1 to L2, है ना? So if T1 is gone, sympathetic fibers for eyeball is gone, for eye, है ना? For the ocular region, sympathetic fibers for ocular region are gone. It will lead to Horner's syndrome. It will lead to Horner's syndrome. What are the features of Horner syndrome? What are the features of Horner syndrome? Features of Horner syndrome are ptosis, drooping of eyelid, meiosis, constriction of the pupil, anhidrosis. This affected half of the face is drier. Anhidrosis means the loss of sweating. Okay, it will be drier. The affected half of the face will be drier. And enophthalmos, this eye looks like sunken. Enophthalmos, then loss of ciliospinal reflex. Loss of ciliospinal reflex. These are important features of Horner syndrome. Are you guys done up to this? Can we take the question? Yes? Okay, let me show you the question. Injury to upper trunk of brachial plexus results in. Injury to upper trunk of brachial plexus results in. This is PGI type question. Means multiple true is possible. Multiple true is possible. Is that okay? What is your answer? Supination is done or for pronation is done? Supination is not done. We have just seen. External rotation or the lateral rotation is possible? Not possible. Inability to initiate abduction, that is true. Abduction is not possible. Decreased sensation on the medial side of hand. Decreased sensation on the medial side of hand. No. That is C8 and T1. Paralysis of deltoid will be seen. So answer to this question is C and E. C and E. D नहीं होगा बेटा. Medial side of hand में C8 and T1 वाले fibers आएंगे ना. Because T1 is carrying mainly the sympathetics for the ocular region. That is why I have written. Okay, do not get confused there. T1 fibers which are carrying mainly the sympathetics for the ocular region, that will be involved, leading to the features of Horner syndrome. Okay. False regarding clump case palsy. Clump case palsy में क्या नहीं होगा इसमें? Clump case palsy में upper trunk is not involved. This is false. ये तो होता ही है इसमें, ये भी होता है, ये भी होता ही है. These are the features. Right answer is D. Now we are done with the axilla. We have seen the axilla boundaries. We have seen the contents, the axillary artery, important points, brachial plexus, important point, and the clinical application. Now we will be doing the regional study. In the regional study, we will be taking the pectoral region, deltoid region, and the scapular region. Very, very, very important. Okay. Now, one question which is asked by the students usually is, sir, muscles ke origin insertion. Do we need to remember all the muscles of origin insertion? I tell them, if you can remember all the muscles origin insertion, very well and good. But try to think rationally. Is it possible for you to remember all the muscles origin insertion from all points? Like sometimes you see in the book, sometimes you see in the book that 5 points are given for origin. All the points, all the fine details, that is not possible to remember for all the things. Kyun? Because when you are writing the exam, you will be writing for 19 subjects, not only for anatomy. Even for anatomy, it will be having other topics as well, like the neuroanatomy, embryology, histology, thorax, abdomen. It is not only about the limbs. Even in the limbs, it is not only about the muscles. Even in the muscles, it is not only about the origin insertion. Are you understanding? So look at the probability. How probable is this? The question will be asked. And always, whenever you are confused with some complex topic, I'm not talking about like all the topics, but when you are confused whether this topic we should go into so much of detail or just fine detail, then try to ask yourself the rationale, that how much input you are going to put to remember this or to understand this, and how much output will be there. Is there any chance of question being asked in your exam? Because now this is something scientifically or strategically you have to prepare for your exam. Are you understanding it? Because with our time is limited, resources are limited, है ना? So we should work hard in the right direction with the limited resources and limited time at hand. We should work hard in right direction. So I am not saying that you should not read any of the origin session, but the important ones are to be studied. Important ones are to be studied, which are frequently being asked in your exams. Okay, for others you must have a fair idea. When you have a fair idea, it is highly likely that you are going to mark the right answer even without knowing the fine detail. So you must have a gross idea from where the muscle is coming. Are you understanding? You may not remember all the fine details of the structures, all the bony parts. I hope the message is clear. The message is clear what is to be studied. Yes, if the message is clear, I am going to begin with the pectoral region, and I will be covering the important muscles or the important questions, previous questions which have already been asked from these parts. Okay, so don't worry about that. Okay, now let us begin with this. This is the muscle pectoralis major. Pectoralis major. Okay, one of the question is pectoralis major. Pectoralis major. Question is pectoralis major. What type of muscle is this? Okay. Which type of muscle? Choices are bipinnate, multipinnate, cruciate, and spiral. Tell me, what is your answer? Is it bipinnate? Is it multipinnate? Is it cruciate or spiral? Bipinnate, multipinnate, cruciate or spiral? What is your answer? Quickly answer. Answer to this question is spiral. Okay, spiral. Direct question from Gray's 41. Why spiral? Because see, when these fibers, upper fibers, are going for insertion, they spiral, and while inserting, they become the lowermost fiber. And these fibers, while inserting, become the upper fibers. Are you understanding? The fibers of pectoralis major, they spiral on themselves for the insertion. That is why they are taken in this category. If I remove the word spiral, then the next best answer can be taken as cruciate, although it is not true, but then yes, you can take it as an answer if the spiral is not there. But the pinnate, it's not multi-pinnate as such. Okay, in the pinnate the axis is oblique. Okay, are you understanding? Now answer to this question is spiral. Please remember, it is direct question from Gray's 41, so there is no confusion. Now let us talk about the origin insertion, an important point about the pectoralis major. See, in the first year, like those who are writing for the university exam, they have to understand for their viva and their exam, because they have to only write 3 subjects: anatomy, physio, biochemistry. So they need to remember in detail. But for those second year onward, only for the PG entrance exam, our syllabus, according to our syllabus, we need not remember all the fine detail. So how I am going to remember this? I will simply remember that it is coming from medial part of the clavicle and lateral part of the sternum. Are you understanding? If I remember this much, I will be able to solve the questions if it is asked. Okay, I may not remember all the fine detail, because that is anyway, if we try to mug up, it is not going to stay for long. Yes. And what about the insertion? Insertion is on the intertubercular sulcus. Intertubercular sulcus. Which lip? Lateral lip. Which lip? Lateral lip. Is that fine? Yes, is that fine? Have you understood? Have you understood? Yes. Now see these fibers. These are pectoralis major fibers, pectoralis major fibers, pectoralis major origin and insertion. Now, what about the action? Let me ask you, if you know that muscle is attached here and going to the arm like this. Now, if I contract the muscle, tell me, and you think yourself, will it do the flexion or will it do the extension? What it is going to do? Flexion or extension? Tell me quickly. Obviously, it is going to do flexion. Yes. Now, the muscle is pulling from anterior aspect. It will rotate internally or medially, or you can say it will rotate laterally. Which rotation will be there? Medial, inward, or lateral, outward? Obviously, it is pulling from anterior aspect. So there will be inward rotation or medial rotation. So there will be, one is flexion, second is medial rotation, and third is now again the muscle is pulling from the front. Will it abduct or will it help in adduction? Will it abduct or adduction? Obviously adduction. So do you need to mug up all these things? No. If you have a gross idea in your mind, clear, the muscle is attached from the medial clavicle, lateral sternum, fine. It is attached on the humerus, on the lateral lip, yes, fine. Then these actions can be easily reproduced in the exam, even if you forget, isn't it? You can think and you can answer. Are you understanding? So you must have a conceptual understanding. That's it. No need to mug up all the tables and all the things. That is not possible. है ना? Looks fancy कि आप सारी tables को याद कर रहे हो, पर possible नहीं हो पाएगा वो. Humanly not possible. क्योंकि आपको wisely सोचना है. 19 सब्जेक्ट हैं. Rational देना पड़ेगा ना हर एक सब्जेक्ट को. ठीक है? I hope this concept and I hope my message to you is clear. If it is clear, please tell. Is it clear, beta? Yes. Can we write the notes? Can we write the notes for pectoralis major? Can we write the notes for pectoralis major? Pectoralis major. It is spiral. It is spiral. It has been asked. Important question. Then we need to remember what is the origin. Origin is medial clavicle and lateral sternum. Lateral sternum. Medial clavicle and lateral sternum. Insertion is lateral lip of intertubercular sulcus. Intertubercular sulcus. Nerve supply is lateral and medial pectoral nerve. Lateral and medial pectoral nerve. Are you understanding this? Lateral and medial pectoral nerve. Is it clear? Yes. What is the action? What is the action? Action is flexion, medial rotation, and adduction. Is that fine? Please take the note. For muscles, we need to remember these points only: origin, insertion, nerve supply, and action. Yes, are we done up to this? Okay, now let us proceed and let us do all the important structures one by one. Now, see this. What is this muscle? Deep to the pectoralis major, we have pectoralis minor. It is coming from third, fourth, and fifth rib. It is coming from third, fourth, and fifth rib, and it is attached on the coracoid process. On the coracoid process. Fine. So we can write here pectoralis minor. Please take the notes here. Pectoralis minor origin. Origin is third, fourth, fifth rib. Insertion. Insertion is coracoid process. Coracoid process. Nerve supply. Nerve supply. Again, both lateral and medial pectoral nerve. Lateral and medial pectoral nerve. Lateral and medial pectoral nerve. What is the action? Action, it is not the major muscle for any action. It assists. Action is not that important. You may even not remember. That's fine. Okay. Assist serratus anterior. It helps in other actions. Okay. It is assisting type of a muscle, not major muscles. Right. Now the third component is of this particular area. This muscle is serratus anterior. But before serratus anterior, let me write one fascia for you. That is clavipectoral fascia. Some important detail is required here. Clavipectoral fascia. What is clavipectoral fascia? Clavipectoral fascia. See, if this is, suppose this is the clavicle, what is attached on the clavicle is pectoralis major. What is this muscle? Pectoralis major. And below the clavicle, we have subclavius. Below the clavicle, we have subclavius. What is this muscle? This is subclavius. Fine. And deep to the pectoralis major in the section, you will see there is pectoralis minor. Pectoralis minor. Now there is this fascia which is enclosing the subclavius and also enclosing the pectoralis minor, because it is enclosing the clavius muscle and the minor clavius muscle and the pectoral muscle. The name is clavipectoral fascia. Clavi from the subclavius, pectoral from the pectoralis minor. Is that okay? This fascia is called as clavipectoral fascia, CP fascia. Is that clear? Yes. Later, after enclosing the muscles, it will continue as what? It will continue as, this is important, it is suspensory ligament of axilla. It will continue as suspensory ligament of axilla. This is very important question which has been asked. Okay, which has been asked, right? Now see, suspensory ligament of axilla is the continuation, but one of the question is asked here that CP fascia is pierced by. It is pierced by which structure? This is again important question. It is pierced by Cole structure. Cole is a mnemonic. Cole is a mnemonic. What is that? Cephalic vein. Cephalic vein. Acromiothoracic artery. Acromiothoracic artery. Lateral pectoral nerve. Lateral pectoral nerve. And L for lymphatics. Lymphatics. And please understand, one is vein, one is artery, and one is nerve, and the other is lymphatic. So all four structures, they belong to different category. इसमें दो vein नहीं है ना? दो वेन नहीं है, दो आर्टरी नहीं है, लेटरल पेक्टोरल और नर्व है, तो दो नर्व भी नहीं है, और लिम्फेटिक भी दो नहीं है. इन आपके एग्जाम में अगर दो वेन दो आर्टरी कहीं लिखा है तो आपको पहले ही डाउट हो जाएगा कि भैया ये इनमें से कोई आंसर होना चाहिए, क्योंकि चारों स्ट्रक्चर डिफरेंट कैटेगरी को बिलोंग करते हैं. रिमेंबर, इट इज पियर्स्ड बाय कोल स्ट्रक्चर्स. कोल स्ट्रक्चर्स. ठीक है. सबक्लेवियस बेटा सबक्लेवियस जो है ना एक्सिला की तरफ नहीं है, वैसे सबक्लेवियस मीडियल एस्पेक्ट में है, यहां तक थोड़ी पहुंचता है वो, ये तो ऑन द वे है ना। और वैसे भी ये जो है ये बाउंड्री यहाँ की बाउंड्री यहां तक नहीं बनाएगा ना बेटा। सबक्लेवियस तो मीडियल एस्पेक्ट में प्रेजेंट है ना। इट यूजुअली इट्स नॉट इन द एक्सिलर रीजन, पेक्टोरलिस माइनर तो जाता है ना वहां तक, उसको कंफ्यूज मत करो वहां पे। And not very important, there is no important role of subclavius. It is having a separate nerve for it from the plexus. The nerve is called as important nerve for unimportant muscle. Okay, fine, डन हो गया यहां तक। यस, आगे बढ़ते हैं, सीरेटस एंटीरियर को समझते हैं। नाउ लेट मी एक्सप्लेन द सीरेटस एंटीरियर एंड प्लीज बी विद मी। ओके, सी, usually it is described like it is taking origin from 1 to 8th rib. It is taking origin from 1 to 8 rib, and then it is attached on the medial border of the scapula. It is attached on the medial border of the scapula. This is origin and insertion. But remembering this point of origin insertion does not give you the understanding of the muscle. For understanding of the fibers of the muscle, the direction of the fibers of the muscle, we must see this diagram. Now in this diagram, basically this is a section, we have taken a section here. In this diagram we can see the muscle is taking origin from the rib, yes, then it is going for the scapula, this is scapula, yes. Now when the muscle is going, it could have attached here, है ना, जा रही थी, lateral end तो पहले ही मिल रहा है, but it does not attach on the lateral end. It keeps on going and gets attached only on the medial end. Are you understanding? It is very important to understand the direction of the fiber. The muscle which started its journey from here, it could have attached here, but rather it goes all the way up to the medial border and gets attached on the medial border. Why this is so, and what is the benefit of having such arrangement? The benefit is this: if the muscle is contracting, it will bring the scapula forward. Are you understanding? The scapula will sweep forward around the chest wall. The scapula will sweep forward around the chest wall. If the scapula will be swept forward, it will bring the arm forward, because the humerus is attached on the scapula. Scapula खुद सामने की तरफ sweep होता हुआ आ रहा है, तो आर्म को भी सामने लाएगा. So there will be protraction. Yes, ठीक है. Clear now? Did you understand the action? Protraction. Yes, let me write the notes for you for the muscles. Serratus anterior. Now be with me. Try to understand. Okay. आप लोग जो मैं कंसेप्ट आपको क्लियर करने की कोशिश कर रहा हूँ, या आपको डायरेक्शंस या कुछ भी इंपॉर्टेंट विजुअलाइज करवा रहा हूँ, ट्राई टू बी विद मी, ओके, एंड ट्राई टू विजुअलाइज. एज आई हैव सेड इन द प्रीवियस क्लासेस ऑल्सो, ऑल डाउट्स आर वेलकम, ओके, बट कई बार आप अपने इमेजिनेशन में खो जाते हो और अपने डाउट्स लिखने में व्यस्त हो जाते हो, तो जो टॉपिक मैं पढ़ा रहा हूँ वो मिस हो जाता है इस चक्कर में, है ना. आप अपने डाउट्स को लिख लो ना कहीं पे, बाद में वी हैव द क्लब एंड वी हैव द ब्रेक्स, वी कैन यूटिलाइज, है ना बेटा. आप बीच में आपके डाउट्स पूछते हो, जो कि क्या होता है कि इट इज वेरी डिफिकल्ट फॉर मी टू आंसर देयर, आई विल नॉट बी एबल टू आंसर, बट the thing is you will also miss the ongoing topic. So please, this is an advice to all the dear students कि the topic के बीच में आप डाउट्स नहीं लिखो, इससे आपका नुकसान ज्यादा है. देखो मैंने तो एट द एंड ऑफ द डे टॉपिक फिनिश कर देना है, इसमें मेरा नुकसान होगा क्या? मैंने एट द एंड ऑफ द डे टॉपिक क्लियर करा देने हैं, टॉपिक अंडरस्टैंड करा के आपको नोट्स लिखवा देने हैं, ठीक है. माई जॉब विल बी डन, एंड मोस्ट ऑफ द स्टूडेंट्स हु आर पेइंग अटेंशन, हु आर फोकस्ड एंड नॉट राइटिंग their doubts and not focusing on other doubts as well, they will be learning most. आपका कोई डाउट है तो वो एक डाउट है ना, अगर आप उस डाउट के चक्कर में और आगे 2-3 डाउट क्रिएट कर रहे हो, उसका क्या फायदा होगा? ठीक है. और कभी कभी डाउट्स जो होते हैं वो इतने माइनर होते हैं कि उस पर क्वेश्चंस आने की संभावना नहीं है, बट ठीक है, वो आपका डाउट है, हमें क्लियर करना है, दैट इज फाइन. बट माय रिक्वेस्ट एंड एडवाइस टू यू गाइज इज, do not ask in between, it will break the flow of the class, and more importantly you will again be losing the ongoing concept. So please focus what I am talking, okay, and then ask your doubts in the club, okay, or whenever we take a break, okay. Now serratus anterior, what we have learned, origin is 1 to 8 ribs, 1 to 8 ribs. Insertion is medial border of scapula, medial border of scapula. What is the nerve supply? What is the nerve supply? Nerve supply is long thoracic nerve. We have already learned about that. And what is the action? Action is protraction, protraction. And because of such action, this is called as boxer's muscle. It is called as boxer's muscle. It is a one-liner question. It is a one-liner question. Is that fine? Yes. What else is the action? What else is the action here? The other action is overhead abduction, overhead abduction. But overhead abduction is done with the help of trapezius, means the serratus anterior plus trapezius together, they are going to do overhead abduction. Overhead abduction means more than 90 degree. Overhead abduction means more than 90 degree. Is that clear? Yes. And in case of any injury here, we have already discussed, it is going to do, it is going to produce winging of scapula. It is going to produce winging of scapula. Is that fine? This is what is called as winging. ये क्या है? विंगिंग है. इसमें क्या कर रहे हैं? पेशेंट आया आपके पास, आपने कहा कि पेशेंट को कि यू हैव टू पुश अगेंस्ट द वॉल. नाउ द पेशेंट स्टार्ट्स पुशिंग अगेंस्ट द वॉल. Pushing requires the serratus anterior. Pushing is not possible because the serratus anterior is not working. If it is not working, all the muscle will be seen prominent, making the origin points prominent, the attachment points prominent. Are you understanding? The attachment is the medial border and the inferior angle of the scapula. All this part will be prominent. The muscle will make this parts prominent while attempting the action. Is that okay? So इसको विंगिंग क्यों बोलते हैं? क्योंकि अगर हमारे विंग्स होते तो यहीं पे होते हैं ना, ऐसे ही तो विंग्स होते हैं हमारे. आर यू अंडरस्टैंडिंग? सो इट इज एज इफ द विंग्स हैव कम, एज इफ दिस इज, it is a wing. Are you understanding? As if it is a wing. It is called as winging of scapula. Fine. Now we are going to proceed to the next part here, that is deltoid. That is deltoid. Now before doing the deltoid, let me give you the conceptual overall understanding. Now Divya Bajaj, let me take your question. Why is the nerve called important? It's not very important. Actually it's not very important, but sometimes you see they write fancy things about the structures, and in the description of the text it is written that it is a special nerve coming from the plexus. Means one nerve is coming for one muscle from the plexus. It should have been important. It should have been important, but then it is observed subclavius is not that important muscle, so that has been described fancy in fancy words, important nerve, because it is special nerve coming from the plexus for unimportant muscles, because muscle is not doing any action. As such, it is not very important. Is that clear? Yes. Now let me come back to the topic, the deltoid. अब हम डेल्टोइड को समझेंगे एंड आप लोग मेरे साथ साथ इसको अपनी बॉडी में अंडरस्टैंड करेंगे. ओके, आई एम गोइंग टू शो यू द पिक्चर हेयर, बट आई यू गाइज हैव टू understand with me. What is this clavicle? Put your hand here, put your hand here and try to trace. Are you tracing this? Yes, are you tracing it? If you trace it, you will understand more, like in a better way, right? So you see this is clavicle. Yes, then we have, this is the acromion part here, this is the acromion part here, this is the acromion part here. Yes, clavicle, acromion. Posteriorly we have the spine of the scapula. Posteriorly we have the spine of the scapula. That means if you look at the lines here, this is anterior line, this is middle line, and this is posterior line. Are you understanding? Anterior line, middle line, and posterior line. This is the line of attachment for deltoid. So if the three lines of attachment are there for the deltoid, how many fibers will be there? Three set. Anterior set, middle fibers, and posterior fibers. Yes. Now tell me, if we talk about the action, we have learned about the origin. Where will be the insertion on the deltoid tuberosity of the humerus? All three set of fibers will make the contour of the shoulder. Anterior fiber, middle fiber, and the posterior fiber, they will make the contour of the shoulder just like this and are inserted here and are inserted here. Yes. But the question is, what will happen? What is the action of different fibers? Now, when the only anterior fibers are contracting, understand. Tell me, only anterior fibers will do flexion or extension? They will do flexion. Will they do medial rotation or lateral rotation? Because the pull is from anterior, they will do medial rotation. Only anterior fibers. Only posterior fibers, what are they going to do? Extension. Because now the pull is from behind, and because the pull is from behind, they are going to do the lateral rotation. They are going to do the lateral rotation. Is that okay? What about the middle fibers of the deltoid? When the middle fibers of the deltoid will contract, when the middle fibers of the deltoid will contract, this part of the humerus will go above. Are you understanding? This part of the humerus will go above, which is nothing but abduction, which is nothing but abduction. Now abduction is an anti-gravity action. Abduction is anti-gravity action. Anti-gravity मतलब आपको ज्यादा फोर्स चाहिए कि कम फोर्स चाहिए? ग्रेविटी के अगेंस्ट काम करना है तो आपको ज्यादा फोर्स चाहिए. यू नीड मोर फोर्स, मोर पावर. इफ मोर पावर इज रिक्वायर्ड, योर फाइबर्स विल बिकम मल्टीपिनेट. Multipinnate. What is the concept of pinnate? Let me give you the conceptual understanding. Suppose this is a muscle and these fibers are there in the muscle. These fibers are there in the muscle. Okay. Now there is another muscle, almost equal surface area. Look at the surface area is same, but the arrangement of muscle is different. Arrangement of fibers is like this now. Small muscles in different direction. Small muscles in different direction. You look at the fibers here. This, if you compare this condition A and B, look at A. We have long fibers. The range of contraction will be more. But look at the number of fibers. Number of fibers is more in B. Power of contraction will be more in B. Are you understanding? Now look at the direction of the fiber. The direction of the fibers of the muscle is oblique to the direction of the muscle action. जहां पे muscle का action हो रहा है उसके oblique है, जबकि इसमें A में it was parallel. Are you understanding the difference between pinnate and the parallel muscle? Pinnate में the arrangement of the fiber inside the muscle is oblique to the direction of the pull. जहां पे muscle का pull होना है उसके oblique होता है. That is fine. Now we have learned about the deltoid. I hope it is clear. I hope it is clear. Have you understood all the points about deltoid? Have you understood all the points about deltoid? है ना? Let us take the points, the notes. Anterior, middle, and posterior fibers. From where they are taking origin? They are taking origin from anterior is taking from the clavicle. This is taking from the acromion. And this is taking from the spine of scapula. Spine of scapula. What will be the insertion? Insertion will be all three muscles fibers are coming together onto the deltoid tuberosity. Deltoid tuberosity. Yes, you guys are understanding it? Yes. And action of the muscle. Action of the muscle will be again for anterior fiber flexion and medial rotation, for posterior fiber extension and lateral rotation, and for middle fiber it will be abduction. Which part of the abduction? From 15 to 90 degree. From 15 to 90 degree, because this is abduction is done by the middle fibers. That is why only middle fibers of deltoid are multipinnate. Only middle fibers of deltoid are multipinnate. Anterior and posterior are the parallel fibers. Please remember, only middle fibers of deltoid are multipinnate. Anterior और posterior को तो जरूरत नहीं है ज्यादा फोर्स की, है ना, तो वो क्या करेंगे, पैरेलल रहेंगे. इज दैट ओके? यस, यू गाइस आर अंडरस्टैंडिंग? हाँ, द मसल्स हैव यू लर्न इन कंसेप्चुअल वे? हाँ, मजा आया आपको? समझ आ रहा है? मजा आ रहा है ना? अगर आपको रियली कंसेप्ट्स में मजा आया है, देन गिव मी स्माइली और लाइक द लाइक बटन होता है ना, ऐसा लाइक वाला सिंबल. आई आइदर गिव यू लाइक और एनी स्माइली. आई विल अंडरस्टैंड दैट यस यू have understood in a conceptual manner and you are enjoying it. Okay, what is the nerve supply? Nerve supply is the axillary nerve. Axillary nerve, if it is gone, axillary nerve, there will be deltoid paralysis. Thank you guys, got your message clear? ठीक है. सो डेल्टोइड पैरालिसिस एक्सिलरी नर्व में होगा, बिल्कुल होगा. डेल्टोइड के साथ साथ टेरेस माइनर का भी होगा, बिल्कुल होगा. वो क्लिनिकली बहुत इंपॉर्टेंट नहीं है, बट यस देयर विल बी पैरालिसिस. यस, नाउ सी, along with this deltoid paralysis, there is one very important point here. Sensory loss will also be seen here. Now the sensory loss will be seen on this patch, this aspect of the shoulder, this aspect of the arm, where the military people, they bear the badge. So there will be sensory loss also. Sensory loss is it has got a name. What is the name? The name is badge sign, है ना? It's like badge sign, regiment badge sign. Yes, we are done up to the deltoid region. Is that okay? ठीक है, थैंक यू सो मच. हाँ जी, थक गए हो आप लोग? इसके बाद है हमारा वो भी इंपॉर्टेंट टॉपिक है. इसके बाद हमें स्कैपुलर रीजन करना है. स्कैपुलर रीजन. यस, वी आर डन. यस, वेरी गुड, वेरी गुड. कोई थके नहीं है, अच्छी बात है. तब कंटिन्यू करते हैं, है ना? स्कैपुलर रीजन. ऑल राइट. सो स्कैपुलर रीजन में क्या है कि हम व्हाट आर वी गोइंग टू स्टडी इन द स्कैपुलर रीजन. बट जस्ट बिफोर दैट, this let me tell you here, what is this is deltoid. What is this muscle is deltoid. What is this muscle is pectoral, है ना? Pectoral. Deltopectoral groove. This is called as deltopectoral groove, and there we can see one vein. What is this vein? This vein is cephalic vein. Okay, cephalic vein is seen in deltopectoral groove. Remember this. deltopectoral groove में कौन सी वेन प्रेजेंट होती है? cephalic vein. ठीक है. अब रेजिमेंट बैज का ये मैंने बताया है कि जो यहाँ पे इस पोर्शन में जब हमारा डेल्टोइड है ना, ओवर द डेल्टोइड देयर विल बी सेंसरी लॉस. The skin over the deltoid is supplied by the axillary nerve. If the axillary nerve is gone, motor loss will be there. Additionally, sensory loss will be there. Sensory loss is it's seen as regiment badge sign. मतलब रेजिमेंट का जो बैज होता है, मिलिट्री वाले पीपल यहाँ पे अपना बैज लगाते हैं ना, जो ऑफिसर्स होते हैं, है ना? तो यहाँ पे रेजिमेंट बैज पहनते हैं, तो उस एरिया में ही डेफिसिट हुआ है, इसलिए इसको बोलते हैं रेजिमेंट बैज साइन. ठीक है. नाउ वी आर प्रोसीडिंग टुवर्ड द स्कैपुला एंड लेट मी एक्सप्लेन. See quickly now, you have to answer with me. Okay, see, if I am talking about the scapula, I am talking about the scapula, है ना? Anterior to the scapula, which nerve is there? Anterior to the scapula, which nerve is there? Subscapular. Anterior to the scapula is subscapular. And posterior to the scapula, which nerve is there? Suprascapular. And medial to the scapula, which nerve is there? Dorsal scapular. Please remember these three nerves. Is that clear? Now in this diagram we can see what is this muscle? Levator scapulae. What is this muscle here? Levator scapulae. What is this muscle here? Rhomboideus minor. What is this muscle here? Rhomboideus major. Look at the deep dorsal scapular nerve. Dorsal scapular nerve is going in the medial aspect. Yes, it is going in the medial aspect. If it is going in the medial aspect, which muscle it is going to supply? Isn't it easy to remember this way? It is going to supply 1 levator scapulae, 2 rhomboideus minor, 3 rhomboideus major. है ना? याद तो करना है, लेकिन एक बार हमारे को क्लियर हो जाए कि कौन सी मसल है कहाँ पे, और तो ओरिएंटेशन आ गया नर्व्स का हमें, तो इट इज वेरी इजी फॉर अस. यस और नो? Did you understand? Yes? Okay, now let us talk about the scapular region. Let me show you. Like this. What we can see here, we can see a notch. Why this notch is important? Because through this notch the nerve will be entering into the suprascapular. अब suprascapular nerve को behind आना है. Suprascapular nerve wants to enter behind. Behind is what? We have a spine. Above the spine we have supraspinatus, below the spine we have infraspinatus. But the nerve, when it wants to enter into this region, it has to pass through some of the foramen, you can say. So we have a foramen here, because of the ligament present. So the arrow is showing the position of the suprascapular notch. This notch is converted into foramen. This notch is converted into foramen because of the ligament present here. Okay. Now I am showing you the other important foramen. You see the nerve which is present in this suprascapular fossa. The nerve which is present in the suprascapular fossa will have to in the supraspinous fossa, for the supraspinatus will have to reach here in the infraspinous fossa. So it will be using this spinoglenoid notch. It will be using the spinoglenoid notch. Wait. It will be using the spinoglenoid notch. Okay. So the muscle is here. The nerve is supplying the muscle. After that, the nerve will come like this. Are you understanding? The nerve will enter through the spinoglenoid notch. Why the name spinoglenoid? Because this is glenoid notch and this is the spine. Between the spine and glenoid, we have spinoglenoid notch. You understand this in 3D. Try to visualize this in 3D. Now you are looking at it in 3D. We can see the suprascapular notch and we can see the spinoglenoid notch. Are you visualizing this? That first the nerve comes via the suprascapular notch. It comes into the supraspinous fossa. After that it goes into the spinoglenoid notch. Yes, I hope it is clear. And we can see in the still, now you see the nerve is coming here, is passing through the notch here, and then via this spinoglenoid notch it is reaching the infraspinous region. Is the concept clear? Yes. Now we can see the rotator cuff muscle. These four muscles are making the rotator cuff muscles. Okay. Let us talk about them one by one. The supraspinatus muscle is taking origin from the supraspinous fossa and going to be inserted onto the greater tubercle of the humerus. From the infraspinatus fossa here, the infraspinatus muscle is going to be inserted onto the greater tubercle again. Is that fine? Similarly, we have from the lateral border of the scapula teres minor muscle, which is going to be inserted again to the greater tubercle of humerus. So three muscles are attached on the greater tubercle. Those can be remembered as sit. What is sit? Supraspinatus, infraspinatus, and teres minor. Supraspinatus, infraspinatus, and teres minor. Okay, these are the muscles attached on the greater tubercle of humerus, right? And from the subscapular fossa here, the muscle is attached onto the lesser tubercle. Only one muscle is attached on the lesser tubercle, that is subscapularis. That is subscapularis. Is that okay? Now look at this. We have to combine the information that we have learned. Let us quickly revise. Subscapularis muscle from the subscapular fossa onto the lesser tubercle. Fine. We have learned these three muscles individually. Now we have combined the muscles together. Supraspinatus, infraspinatus, and teres minor. Are you understanding? These three are attached onto the greater tubercle. Is it clear? Is it clear? Yes. Now see, let us understand these muscles together and why they are called as rotator cuff. See this muscle. We have these muscles. Yes. Now, if you look at this muscle subscapularis, the arrow is showing it is going to act. It is going to act on which part? It is going to act from the anterior or posterior? Anterior. If it is going to contract from anterior, which rotation it will produce? Medial rotation or lateral rotation? It is going to produce the medial rotation. I hope this is clear. Now let us talk about the other muscles action. When you talk about these two muscles, infraspinatus and teres minor, they are exerting the pull from behind or from front? Obviously from behind. If they are exerting the pull from behind, which rotation they are going to produce? They are going to produce lateral rotation. Are you guys understanding? So these muscles are producing medial rotation, lateral rotation. That is why altogether they have been given a name, rotator cuff. They are rotating it. Are you understanding? Yes. Now there is one muscle which is not rotating. Why? Because actually it is present in the midline, kind of a midline. Okay. So when it will contract the supraspinatus, it will bring about abduction, not the rotation, neither medial nor lateral rotation. It is going to bring the abduction from which degree to which degree? 0 to 15 degree. That is initiation of the abduction. Are you understanding? We have understood already that abduction 15 to 90 degree was done by deltoid, and more than 90 degree is called as overhead abduction, which was done by trapezius and serratus anterior. Is that fine? Have you understood this much? Yes. If you have understood this much, let me write the notes for you. Let me write the notes for you. Okay. Let me write the notes for you. See, what is this is greater tubercle and what is this is lesser tubercle. Greater tubercle and lesser tubercle. On the greater tubercle, we have sit muscle attached. On the lesser tubercle, we have subscapularis muscle attached. Okay. So I can write here sits muscle. What is this? Sit is supraspinatus. What is this? I is infraspinatus. What is this? T is teres minor. And what is this? S is subscapularis. Right? What was their action? Subscapularis was doing medial rotation. These two together were doing lateral rotation, and this was doing abduction. Which degree of abduction? 0 to 15 degree of abduction. Is that fine? Are you understanding this? Okay. Now this is about the action of these muscles. Let me take you back to this diagram. If these are two tubercles, greater tubercle and lesser tubercle, we can see there is this gap between the two tubercles. Between tubercles, we can say intertubercular. Yes, this gap is called as intertubercular sulcus. Intertubercular sulcus, and we can see intertubercular sulcus is presenting lateral lip. It is presenting lateral lip. It is also presenting medial lip, and it is also presenting medial lip, medial lip, and it is also presenting the floor. It is also presenting the floor. Now, can you tell me what is attached on the lateral lip? What is attached on the lateral lip is pectoralis major. What is attached on the medial lip is teres major. And what is attached on the floor? Latissimus dorsi, the lady between two majors. Every one of you, I'm sure you know the mnemonic lady between the two majors. Are you understanding this? Yes? You guys are understanding? We are not, we have to write the notes, but along with that, we have to try to make the things concise, crisp, and clear. Are you understanding? Yes? Is it clear? Intertubercular sulcus and the tubercles, are these clear? Yes. If this is clear, if this is the intertubercular sulcus region, if this is the intertubercular sulcus region, the a little above there will be the neck, head of the humerus. A little above there will be head of the humerus, and there will be the glenoid. There will be the glenoid. Yes. In the glenoid we have two tubercles, supraglenoid and infraglenoid. What are attached here? On the infraglenoid, long head of triceps is attached. On the infraglenoid, long head of triceps is attached. This is what? This is glenoid. In the infraglenoid, long head of triceps. On the supraglenoid, long head of biceps is attached. Long head of biceps is attached. Yes, you guys are understanding this? Now this tendon of long head of biceps will pass through the, it will pass through the sulcus. Now this is important. What is attached on the floor? Latissimus dorsi. What is passing through the sulcus, not attached, is long head of biceps. It is long head of biceps. What is the important point about long head of biceps? What is the long head of biceps important point? It is intracapsular but extra synovial. Extra synovial. What is the meaning of extra synovial? You see, we have a synovial sheath present here. The synovial sheath also present in the intertubercular sulcus. It comes for some of the, not through the sulcus, but some part of the sulcus we do have a content, the synovial sheath of the shoulder joint. But this synovial sheath, it is not encircling the tendon. It is present around it for some part, but when we say intrasynovial means encircling the tendon. It is not encircling the tendon. That is the meaning. Are you understanding? This is synovial sheath. It is present, but it is not encircling the tendon. Is that okay? And there is one more content here. There is one more content here. What is that? There is this artery. What is this artery? This artery is, what is this artery? This is the third content of the intertubercular sulcus. Three contents are passing through it. What are these? Synovial sheath, long head of biceps, and one artery. What is this artery? Ascending branch of Acha. Ascending branch of Acha. Very good देवांशी. Ascending branch of Acha. ठीक है, समझ आ गया आप लोगों को? ये पूरा रीजन क्लियर हो गया है कि हमने अभी तक with the rotator cuff we have learned this region, that this is the greater tubercle, this is the lesser tubercle, these are the glenoid notches, supraglenoid, infraglenoid. Okay, let me quickly revise this part. We started with the greater tubercle and we learned about the sit muscle. What is sit muscle? Supraspinatus, infraspinatus, and teres minor. Then we have written about the lesser tubercle, that is subscapularis muscle. Then we wrote about their action: medial rotation, lateral rotation, and abduction from 0 to 15 degree. Fine. After we are done with that, I told you if these two are tubercles, between them we have intertubercular sulcus, Intertubercular sulcus presents lateral lip where pectoralis major is attached. It also presents medial lip where teres major is attached. It also presents floor where latissimus dorsi is attached. This intertubercular sulcus has got a other name. What is the other name? Bicipital groove. Why bicipital groove? Because the biceps tendon passes through it. From where the bicep tendon is coming, I have drawn and explained that glenoid is there. Above glenoid, we have supraglenoid tubercle. From it, the long head of biceps is coming, which will simply pass through the groove. It will not be attached. Along with that, synovial sheath will also come for some portion, not all throughout the sulcus, but this synovial sheath is not encircling the tendon. So the tendon is intracapsular extrasynovial. This is very important. Question is asked. Okay. This is MCQ. Fine. And what about this artery? This is ascending branch of ascending branch of anterior circumflex humeral artery. Is that okay? Yes. Along with that, one point I have covered here. What was that? Regarding glenoid, above glenoid we have supraglenoid and below glenoid we have infraglenoid. Both these tubercles, supraglenoid and infraglenoid, they are giving attachment to long head. Remember, above, that is supraglenoid for the biceps, infraglenoid for the triceps. Remember this. Infraglenoid will give triceps long head, supraglenoid biceps long head. Is it clear now? Everything we have revised because lot many information was there, so I wanted to make this point more clear. So revision is also done. Is it clear now? Yes. Is it clear? Are we done? Okay. All right. Now let us take tea break. Okay. And we will resume at 11:20. Okay. After that, we are going to take a break. Okay. Now this tea break is till 11:20. Tea break till 11:20. Fine. Everyone? Okay. पलाश साहू, ये जरूरी नहीं है कि आपको ओरिजिन इंसर्शन याद करना है. ओरिजिन इंसर्शन इसलिए याद नहीं करना है क्योंकि ये एक्चुअली पुरानी टर्मिनोलॉजी है ओरिजिन इंसर्शन की. अब लेटेस्ट में इट हैज चेंज्ड. लेटेस्ट में वी हैव चेंज. वी यूजुअली टॉक अबाउट द अटैचमेंट्स. आप देखोगे जो अभी जो एक्सटर्नल्स आते हैं, कई जो मतलब अपडेटेड एक्सटर्नल्स हैं या अपडेटेड टीचर्स हैं, दे टॉक अबाउट द अटैचमेंट्स, है ना. बट पुराने वाले जो हैं वो सारे के सारे ओरिजिन सेशन में बात करते थे. तो याद करने की बहुत जरूरत नहीं है. इट इज, है ना. ओके. ये डायग्राम चाहिए आपको बेटा. उर्मी, इसमें पूछा इंट्रा कैप्सुलर एक्स्ट्रा सेनोवियल. इंट्रा कैप्सुलर बिकॉज इट इज पासिंग थ्रू द कैप्सूल ऑफ द शोल्डर ज्वाइंट. दैट इज वाई इंट्रा कैप्सुलर. वाई एक्स्ट्रा सेनोवियल कि सेनोवियल शीथ चारों तरफ से एनसर्कल नहीं कर रही है. ये अराउंड प्रेजेंट है बट नॉट ऑल अराउंड. थोड़ा सा साइड में प्रेजेंट है. मान लो कि 2-3 साइड कवर हो रही है, नॉट चारों तरफ से तो घेराव नहीं किया है ना, तो इंट्रासेनोवियल नहीं है. वो याद है वो कंसेप्ट मैंने बताया था आपको कि अगर हमारा फिस्ट बैलून में घुस जाए, it is extrasynovial. Remember, tendon of this question, this is already asked question. I have written Q. It was asked which tendon is intracapsular extrasynovial. Answer is long head of biceps. Do not get confused. I am repeating again. Okay. And you want to know about the suprascapular nerve. Anubhav, suprascapular nerve. Suprascapular nerve is present behind the scapula. Behind the scapula. Let me show you again. Suprascapular nerve. Suprascapular nerve का जो final picture था वो ये था. See this part. यहाँ पे देखो कि नर्व हमारी जो है ये पहले एंटर करेगी. इट विल एंटर फ्रॉम वेयर? इट विल एंटर थ्रू दिस नोच. इट विल एंटर द सुप्रास्पाइनस फोसा. यहाँ पे सुप्रास्पाइनेटस को सप्लाई करा देगा. यस. आफ्टर दैट इट विल come through this notch into the infraspinous fossa. And what was this notch? The notch name is spinoglenoid. Why? क्योंकि ये वाले पोर्शन को स्पाइन बोलते हैं, और जहां पे हेड ऑफ द ह्यूमरस अटैच्ड है इसको ग्लिनोइड बोलते हैं। तो बिटवीन स्पाइन एंड ग्लिनोइड द नेम ऑफ द नोच बिकम्स स्पाइनोग्लिनोइड। सिंपल थिंग है, इस नोच से पहले ये सुप्रास्पाइनस को सप्लाई कराएगा और बाद में यहां से घूम के आके इंफ्रास्पाइनेटस को सप्लाई कराएगा। और ट्राई टू कीप इट मोर सिंपल, it is behind the scapula. Behind the scapula two muscles are there, so it is going to supply two muscles, supraspinatus and infraspinatus. Is this clear now everyone? Yes. Okay, I will show you this slide. I'll keep the slide on as you said. Okay, ये स्लाइड है आपके पास अवेलेबल, आप इसको ड्रॉ करो फिर से अगर आपको चाहिए, है ना? ऑल राइट, what are we looking at? What are we looking at right now is the scapular spaces. We have upper triangular space, lower triangular space, and the quadrangular space. Okay, and what is this? Is the scapula. What is this? Is the scapula, right? And this is the humerus. This is humerus. This is shaft of the humerus. This is surgical neck of the humerus. This is head of the humerus, right? Now you see, what is this muscle? This muscle is on the, this is lateral aspect because the humerus is on the lateral aspect of the scapula. This is medial aspect. For our understanding, this is where we have the rhomboideus attached. On the medial side we have the rhomboideus muscles are attached. Rhomboideus minor, rhomboideus major are attached on the medial side. Okay, and on the lateral side we have teres minor and teres major. Is that okay? Are you understanding? On the lateral side of the scapula, teres minor, major. Medial side of the scapula, rhomboideus minor and major. Is that fine? Yes. Now coming to the topic. What we have learned is the spaces. How to remember these spaces? You have to do with me. Make this V and make this V and put these two V in this way, in this manner. Are you understanding? Put these two V's in this manner. When we make these two V's together, let me explain. This is scapula. When you are making it, this is scapula. And this is teres minor. This is teres major. Are you understanding? Scapula, lateral aspect of the scapula, teres minor and teres major. Fine. When you add these two, what is this middle finger? I am just separating to explain. You have to keep on making it. Okay, you keep on making it and understand with me. This is humerus. This is humerus. Is it clear? Yes. And the up, this is the long head of triceps. This is long head of triceps. Okay, now let me draw and explain the simple things what I have told you, that you need to make two V's. This is one V, this is one V, and this is the other V. Are you understanding? These two V's you are making and putting over each other. This is teres minor, this is teres minor, this is teres major. This one is long head of triceps. This is shaft, and this one is surgical neck. This one is surgical neck of humerus. Of humerus. Are you understanding? Now you have got two V's, है ना? ऐसे करके दो V हमने बना लिए, ऐसे करके, ठीक है? तो we have got now upper triangular space. This is upper triangular space. This is lower triangular space, and this is the quadrangular space. Upper triangular space, lower triangular space, and the quadrangular space. Is it fine? Is it fine? Now talking about the content. What content will be there? Now when you look, let me explain this in a conceptual manner. Remember like this. When you are talking about the shaft of the humerus, from behind when you're looking at the shaft of the humerus, there is a groove. What is the groove? Radial groove. What should pass through the radial groove is one artery. Which artery? Can you tell me which artery and which nerve? The name of the groove is radial groove. So what is the name of the nerve? Is radial nerve. And which artery is accompanying the radial nerve? Profunda brachii artery. profunda brachii artery. Yes, and there is this nerve which is passing, which is circling around the surgical neck. What is that? Axillary nerve. Axillary nerve. And which artery should be here? On the posterior aspect of the neck, it should be pacha. It should be pacha. Because acha will be circling on the anterior aspect of the humerus. Posterior aspect of the neck of the humerus will be encircled by the pacha. Acha means anterior, pacha means posterior. Are you understanding? Yes. So these are the contents. Now let me explain this content, third content here. We are done with the two spaces content. Now, if I ask you that there is this artery which is running anterior to the scapula, anterior to the scapula, because it is running anterior to the scapula, I have shown you in the dotted manner. Why in the dotted manner? Because we are looking from behind. Now if this artery is anterior to the scapula, will you call it as subscapular or suprascapular artery? Very good, it is subscapular artery. It is subscapular artery because it is anterior, isn't it? Now if subscapular artery wants to give a branch on the posterior aspect of the scapula, so this branch from the subscapular artery has to wind around the scapula in order to reach the dorsal surface. It will wind around the scapula. That is why what should be the name of the artery? The name of the artery is circumflex scapular artery. Now the circumflex scapular artery, we can see in the diagram, it is a content of which space? It is a content of upper triangular space. Is it clear to every one of you? Is it clear why is this content is present? Yes. So this is something which you can always remember because you have learned why these names are there, isn't it? So if the concept is clear, this is reproducible in the exam. Circumflex scapular artery. Yes, everyone, is it clear? The spaces are clear, beta? The spaces are clear? Yes. Let me show you the final picture. This is the final picture where we can see the boundaries and we can see the contents. We can see the contents. Is it done? See, this is a question, not a boundary of triangle of auscultation. What is triangle of auscultation? Triangle of auscultation. See, there we have the triangle of auscultation. This triangle is called as triangle of auscultation. This triangle is called as triangle of auscultation. What are the boundaries that we can see here? Trapezius is there, latissimus dorsi is there, and the scapula is there. Okay. In the floor, we can see the rhomboideus major is present. In the floor, rhomboideus major is present, but most of the triangle is empty or very minimal muscle fibers are there. Because very minimal muscle fibers are there, that's why from over this triangle we can auscultate. That is why it is called as auscultation triangle. Please remember, that is why we say auscultation triangle. Answer to this question is serratus anterior, because we have seen the boundary. What is the boundary of triangle of auscultation? Scapula, trapezius, and latissimus dorsi. Is that clear? Yes, is that clear? Very good, very good, very good. Now we are going to begin with the arm. Now we are done with the regional study. Now we'll do the arm, cubital fossa, forearm, and this is how we are going to proceed. Is that okay? Yes. Let us start. See, when you talk about the arm, we have anterior part of the arm and posterior compartment of arm. Let me write it for you. Let me write it for you. When you talk about arm, we have anterior compartment and posterior compartment. Anterior compartment, we have BBC muscle, and posterior compartment we have triceps muscle. Triceps muscle. Let us talk about biceps. Biceps and brachialis, they cross elbow joint. They cross elbow joint. Biceps and brachialis. They cross elbow joint. If two muscles are crossing the elbow joint, two bones are waiting for them. One is radius, the other is ulna. So where will be the biceps attached? It will be attached onto the radius. It will be attached onto the radial tuberosity. And where will be the brachialis attached? Brachialis will be attached onto the ulnar tuberosity. Are you understanding? So two muscles are going from, they are crossing the elbow, and one of them is going to attach on the radius, other will be attached on the ulna. This is how we can remember it. This is how we can remember it. Okay. Now all muscles of the anterior compartment of arm are supplied by musculocutaneous nerve. All muscles are supplied by musculocutaneous nerve. Additionally, brachialis is supplied by radial nerve. Additionally, it is supplied by radial nerve also. Are you understanding? What was C? C is coracobrachialis. C is coracobrachialis. So this is B, and C muscle. Biceps brachialis and coracobrachialis. Okay. This is the attachment of the biceps and brachialis, and these are the nerve supply. Okay. Yes. Let me talk a little bit about the musculocutaneous nerve, then I will show you the muscles. Musculocutaneous nerve. When you say musculocutaneous nerve, it is muscular and cutaneous. Why muscular? It is muscular in arm and it is cutaneous in forearm. When it is muscular in arm, it supplies BBC. When it is muscular in arm, first it pierces coracobrachialis. It pierces coracobrachialis and runs between biceps and brachialis. BB. It pierces coracobrachialis and runs between BB and finally supplies BBC muscle. Finally supplies BBC muscle. What about cutaneous in forearm? When it becomes cutaneous in forearm, it will continue as lateral cutaneous nerve of forearm. It will become lateral cutaneous nerve of forearm. Is that fine? Right? Have you taken the notes about the musculocutaneous nerve? Now let me show you the muscles. Let me show you the muscles. Right? See, what is this muscle? This muscle is taking origin from the coracoid process. The short head takes origin from the coracoid process, the long head from the supraglenoid tubercle. We have already learned that this is the glenoid, and above the glenoid we have supraglenoid tubercle, below the glenoid we have infraglenoid tubercle. You remember? Can you tell me which muscle is attached on the infraglenoid tubercle here? Can you tell me which long head is attached? Long head of triceps. Very good. Long head of triceps. Now the long head is coming through the intertubercular sulcus region. Short head is coming like this. Both of them are joining. And finally, where the muscle is going to attach? Muscle is finally going to attach onto the radial tuberosity. Finally, it is going to attach, crossing the elbow and attaching onto the radial tuberosity. Is that fine? Yes, biceps. Is it clear? Action of the biceps, we have already taken the notes. Flexion of the elbow, and it is also chief supinator. Yes. The next muscle here is the brachialis. Brachium literally means arm. Brachialis means arm muscle. It takes origin from the arm bone. What is the arm bone? Humerus. The brachialis takes the origin from the arm bone, and finally it is attached onto the ulna. It is attached onto the coronoid process of the ulna, also ulnar tuberosity. Okay. So to keep it simple, because we are remembering the radial tuberosity for radius, that is why we can remember ulnar tuberosity as well. But if you learn to if you want to learn specifically, it is the coronoid process of the ulna and also ulnar tuberosity. Clear? So in this diagram, we can see there is this nerve coming. You can follow the nerve. This is nerve coming and it is piercing through the muscle, then it is coming again, and then it is running between these two muscles. So it is piercing the coracobrachialis, running between the biceps and brachialis, and finally supplying the coracobrachialis, the biceps, and also brachialis. Are you understanding? After this arm portion is done, it will cross and will continue as lateral cutaneous nerve of arm. Are you understanding? It will finally become lateral cutaneous nerve of arm. Is the course clear? You can see the lateral cutaneous nerve of arm distribution. So anterior compartment of muscles, is it clear? Yes or no? Anterior compartment of muscles and the musculocutaneous nerve, is it clear? Yes or no? Yes, right. Now posterior compartment of arm, what we have in the posterior compartment of arm? Posterior compartment of arm, we have triceps muscle. Triceps means how many heads? Three heads. Three heads are there for the triceps. So we have, you see, uh, this is the groove, the radial groove. If I draw radial groove, what is this groove? Radial groove. Radial groove. Above the radial groove, the lateral head of triceps take origin. And below the radial groove, above the radial groove, lateral head is taking origin. Which head? Lateral head. Below the radial groove, medial head is taking origin. Right? So lateral head, medial head, fibers will be joined by the long head fibers. Long head is coming from where? It is coming from, long head is coming from where? Long head is coming from infraglenoid tubercle. Okay, this is glenoid cavity. This is glenoid cavity. This is glenoid cavity. So we have the long head coming from the infraglenoid tubercle, lateral head coming above the radial groove, medial head coming below the radial groove, and all the muscles together are going to attach. Where it is going to attach? Onto the olecranon process. Onto the olecranon process. Okay, and action, we know the action is nothing but extension of elbow. Extension of elbow. Yes. Are you understanding? This understanding is important, that above the radial groove, which head is there? Lateral head. Below the radial groove, which head is there? Medial head. Why this is important? Because when the radial nerve will pass through the groove, it will give one branch above. If it gives one branch above, which head it will be supplying? Lateral head. And it will also give one branch below. The one branch below will be supplying the medial head. This is why it is important. Is it clear now? Yes. All right. Now let us proceed towards the cubital fossa. Let us proceed towards the cubital fossa. Let us understand the cubital fossa, then we will enter into the forearm. Right? Here we can see the schematic diagram of triceps. Right? See, this is the part here. This is the part where we have the radial groove. Above we have the lateral head. This is lateral head. Below we have the medial head. है ना? and this is long head coming from the infraglenoid tubercle, right? Now, when you talk about the cubital fossa, let me show you these muscles. Cubital fossa is a triangular fossa bounded by this muscle here, that is brachioradialis. What is this muscle? Is brachioradialis muscle, and this muscle pronator teres, and this line, that line is imaginary line. So it is a triangular region, triangular fossa, which is called as cubital fossa. Let me give you the orientation about the brachioradialis. See, we have in front the flexor compartment, behind extensor compartment. But when we are looking at in this direction, that is semi-flex position, this muscle at the junction, between the flexion on this side and extension on this side, this muscle is nothing but brachioradialis. When you are doing the exercise in gym, if you do like this flexion is done by biceps. But if you do like this in the semi flexion, the forearm in the semi flexion, this is you are basically working on the brachioradialis. Are you understanding? So brachioradialis is at the junction of flexion muscle and the extension muscles. Is that clear? Is that clear? Yes. Now let me give you one very basic diagram for the cubital fossa. This is brachioradialis. This is pronator teres, and this is the imaginary line. This is imaginary line. And what are the content? Content from medial to lateral can be remembered as MBBS. From medial to lateral, the contents can be remembered as MBBS. Median nerve, brachial artery, biceps tendon, and superficial branch of radial nerve. Superficial branch of radial nerve. Is that fine? Is that fine? Now, before we take the notes for the cubital fossa, see, cubital fossa is present in front of the elbow. Yes. Now tell me, when we were discussing the front of the arm, I told you two muscles cross elbow. What were the two muscles? Biceps and brachialis. But right now, when we are looking at the elbow region, cubital fossa region, I am only marking one content, biceps. If the biceps is the content, where is the brachialis? Where is brachialis gone? Brachialis must be somewhere. Brachialis is not making the content because brachialis is present along the floor. Are you understanding? Brachialis is there. It has to cross the elbow, but it is making the floor. It is not the content. Where is the brachialis? This is the brachialis. Brachialis is making the floor along with supinator. So remember, floor is formed by brachialis and supinator. Is that clear? What about the roof? What is important about the roof? Importance of the roof is we have median cubital vein present. Median cubital vein is usually chosen for IV access. For whatever purpose IV access is required, maybe for diagnostic, prognostic, or therapeutic. But whenever you want to check, you want to go for the IV access, you usually choose the median cubital vein. It is preferred, right? All right. Okay. So this is about the cubital fossa. Let us make a schematic diagram. Let us make a schematic diagram for cubital fossa. Cubital fossa. See, simple schematic diagram for you. This is brachioradialis, brachioradialis, pronator teres, and line joining two epicondyles. What is this? Line joining two epicondyles. line joining two epicondyles. Is that clear? Now what are the contents present here? If you remember, we have one nerve, one artery, MBBR or MBBS. MBBS. What is the content here? This is the diagram. What are the content? Contents are from medial to lateral. From medial to lateral, MBBS is the mnemonic. What is that? Median nerve, brachial artery, biceps tendon, and superficial branch of radial nerve. Superficial branch of radial nerve. All right. What makes the floor? What makes the floor? Floor is made by two muscles. What are two muscles? Brachialis and supinator. Brachialis and supinator. And what is important point in the roof? Important point in the roof is median cubital vein. Median cubital vein. Median cubital vein or antecubital vein. Is that okay? Please take the notes. When you're done, please tell me. Then we will proceed. We will proceed with the forearm. Up to cubital fossa we are done. Now we need to write about the forearm, anterior compartment and the posterior compartment of forearm. Yes? When you're done, please tell me. क्यूबाइटल फोसा बहुत आसान था. हमने बाउंड्रीज, कंटेंट, फ्लोर, रूफ सब कुछ देख लिया इसका. अब हमें आगे प्रोसीड करना है और देखना है कि what are the muscles in the anterior compartment and posterior compartment of forearm. Are you guys done now? Yes? Very good, very good. So let me start with this. Posterior compartment of forearm. Posterior compartment of forearm and anterior compartment of forearm and anterior compartment of forearm. How many muscles are there? Muscles in the anterior and posterior compartment are arranged in both the compartment. They are arranged in superficial and deep. So we have deep muscle and superficial muscle in the anterior compartment, right? And deep muscle and superficial muscles in the posterior compartment. Thank you बेटा हिमांशु. समझ आ गया ना आपको? बेसिक आइडिया क्या है कि नोट्स लेने हैं कंसाइज वे में और लाइन डायग्राम ताकि आप बना भी सको और याद भी रख सको. तो बेसिक आइडिया ऑफ लाइन डायग्राम्स इज, यू सी, द एटलस डायग्राम्स आर रिक्वायर्ड फॉर अंडरस्टैंडिंग, है ना. वंस यू हैव अंडरस्टूड द सब्जेक्ट, for quick revision you must have like line diagrams with you so that you can also draw, and once you draw it becomes more clear. Only looking at the diagrams will give you a little bit of understanding. I'm not saying that will not help you. For first to understand you should look for the atlas, but line diagrams idea is you should draw yourself. Whenever there is confusion, draw the diagram. Okay, and anatomy will be learned after drawing the diagrams only, है ना. That's why. All right. So we have deep and superficial दोनों तरफ. And please remember the number. This number goes like 3, 5, 5, 7. So first number is 3, then 5 for this compartment, 5, 7. So remember like this: 3, 5, 5, 7. First number or the small number is number of deep muscles. So 3, 5 when I say means 3 are the deep, 5 are the superficial. 5, 7 when I say means 5 are the deep here and 7 are the superficial here. Is that okay? Very good. सिसोदिया मजा आ गई वो, हैं? मन्ने भी आई वो. Very good. হ্যাশট্যাগ গুলো ফ্র্যাকচার হইতে পারে আর প্যারালিসিস হইতে পারে. You see, these are used. This hashtag I'm using for the injuries. Okay, maybe for the paralysis, maybe for the fracture. If that you need to understand. If I'm writing after some bone, it's again bone injury is called as fracture. If I'm writing after nerve, so nerve injury is not called as you see fracture. So nerve injury means it will lead. It's an injury. It will lead to some clinical feature. বুঝতে পারছো? Okay, all right. All right, now let us begin. This is only the number, है ना, सारे odd number हैं. तो चलो, let us begin with the anterior compartment first, है ना. Anterior compartment we have 3 and 5. So if I draw the anterior compartment, if I take a section through the anterior compartment, let me give you again simple diagram. Section through anterior compartment. Anterior compartment. ठीक है? कैसा होगा? How the section will look like? Okay, please understand everyone. See, we have the superficial muscles from medial to lateral. First draw the diagram. I will explain everything. Don't worry, है ना? हाँ जी तुषार. All languages of India rock, Baba. All languages of India rock. है ना? This is the beauty of India. Nowhere in the world you see such unity in diversity. So many languages, so many cultures, but still we are one. We are united as Indians, right? So, and again, we are medicos, we are connected by the medical subjects. Right now, we are connected because of anatomy, isn't it? So let us enjoy the subject. Yes, very good. Now come here. See, so we have these four muscles are there. We can remember them as P, F, P, F. We are going from like medial to lateral like this way. Okay, so we are going from pronator teres is there. Okay, then the next muscle will come, the flexor carpi radialis. This is lateral aspect here. This is medial aspect here. Please understand the section meaning. And now I am drawing the deep muscles here. Now I am drawing the deep muscle here, but I am drawing deep muscle as 3. How many deep muscles? 3. If I am drawing deep muscles 3, that I have already told you number of deep muscles was 3. True. But then why I have drawn one muscle here? Because this muscle belongs to superficial group, but the location is not exactly superficial. The location is in between the superficial muscle and the deep muscle. It is called as intermediate. But then there is no defined intermediate muscle. If the question is asked, we have to take it as superficial muscle. Is it clear, beta? Is it clear? Yes. ठीक है. So PF, this is also F. What is the meaning of PF? Let us write down. This is pronator teres. This is pronator teres. This is flexor carpi radialis. This is palmaris longus, and this is flexor carpi ulnaris, right? And this is flexor digitorum superficialis. This is flexor digitorum superficialis. ठीक है. यहाँ पे क्या है हमारा जो 3 डीप मसल्स हमने ड्रॉ करे हैं वो कौन कौन से हैं? दिस इज फ्लेक्सर pollicis longus, flexor pollicis longus, flexor digitorum profundus, and pronator quadratus. Pronator, wait, let me write this way. This is flexor digitorum profundus. This is pronator quadratus. Okay. Is it clear? Now let us talk about their nerve supply. These are the muscles present, but from where they are taking the nerve supply? Remember this. Pronator teres is supplied by median nerve. Flexor carpi radialis is supplied by median nerve. Palmaris longus is supplied by median nerve. But flexor carpi ulnaris, U means ulnar. It will not be supplied by median nerve. it will be supplied by ulnar nerve. Are you understanding? So median nerve is supplying pronator teres, flexor carpi radialis and palmaris longus. Along with that, it is also supplying flexor digitorum superficialis, whereas flexor carpi ulnaris is supplied by you see this nerve, that is ulnar nerve. Are you understanding this? Ulnar nerve. Yes, correct. Okay. And you see, there is deep muscles are supplied by the deep branch of median nerve. What is the deep branch of median nerve? Deep branch of median nerve is anterior interosseous nerve. Anterior interosseous nerve is a branch from median nerve. And anterior interosseous nerve is going to supply flexor pollicis longus, pronator quadratus, and one half of flexor digitorum profundus. If one half of flexor digitorum profundus is supplied by this, what about the remaining half? Remaining half will be again taken care of by the ulnar nerve. So you can say ulnar nerve is supplying 1.5 muscle here. Are you understanding? Deep muscles are supplied by the anterior interosseous nerve. Remaining or the most of the superficial muscles are supplied by the median nerve. Is this clear to every one of you that how the compartment of forearm with all these muscles are supplied by different nerves? Will you remember all these nerves for different muscles? Is it clear beta? Yes. Is it clear? समझ आ गया? ठीक है, आगे बढ़े. See this muscle here. We have flexor digitorum superficialis here. Flexor digitorum superficialis. Thank you, Puneet. Thank you, everyone, for all your compliments. Okay, see. Medial half of flexor digitorum profundus will be supplied by the ulnar nerve beta. मीडियल साइड में मैंने ड्रॉ किया ना आस्था, मीडियल साइड में ड्रॉ कराया मैंने, आप प्लीज चेक करो, वहां पे मैंने लिखा हुआ है मीडियल है ना डायग्राम में. आई शो यू अगेन. नाउ सी what I am talking right now is flexor digitorum superficialis muscle. This flexor digitorum superficialis muscle is going to insert onto the base of, or you see the what is this part? Middle phalanx. These are middle phalanx of the fingers, right? And then deep to them we have flexor pollicis longus, and flexor digitorum profundus. ठीक है. अब यहाँ पे ये चीज आपको ध्यान करनी है बिफोर प्रोसीडिंग. द टर्मिनोलॉजी इज इंपॉर्टेंट हियर. Okay, let me talk a little bit about the terminology, then I can proceed. Okay, see, the term carpus means wrist. The term pollicis means thumb. Okay, the term digits means fingers. Okay, are you understanding? So when you say flexor carpi ulnaris, the muscle does the flexion. It is attached in the wrist region on the ulnar side. What is flexor carpi radialis? It is a flexor muscle on the wrist. It is attached on the carpal region or the wrist region on the radial side. Are you understanding? This is the meaning. So if you look at the name of the muscle, you will be able to understand that what is the muscle about. Whether the muscle is flexor, whether the muscle is extensor, on which aspect of the arm or forearm they are attached. Are you understanding? Are you understanding? ठीक है. All right. Now you see this point, coming to this point, flexor digitorum Profundus. What is the meaning of profundus? Profundus means deep. Profundus means deep. Superficialis means superficial. There is no hidden meaning. Profundus means deep. Superficialis means superficial. Now, when I say flexor digitorum profundus, what do you understand? I understand these are the muscles for the flexion of digits. For the flexion of digits, yes, we can say flexor digitorum. But then again, we have flexor digitorum superficialis, again the muscles which are for the flexion of digits. So you can say for the flexion of one digit, we have two muscles. One is deep, the other is superficial. Are you understanding? Yes. Now understand this way that from the forearm, this is the forearm region, this is the wrist region, and these are the digits. These are the digits. Are you understanding? These are the digits. Now the muscles are going into set. There is deep set and this is superficial set. This is superficial set. Are you understanding? Superficial muscles and the deep muscles are going like this. Okay? Yes. Are you understanding? Now, if this deep muscle has to insert here and the superficial muscle will be inserted into the middle phalanx. Understand this? This is the supposed middle phalanx, this is distal phalanx. Now the deep muscle wants to reach the superficial muscle is attached here on the middle phalanx. This is middle phalanx. This is distal phalanx, right? Superficial muscle is attached onto the deep middle phalanx. Deep muscle, how can it cross? It cannot cross. So in order to give way, the superficial muscle will actually make a tunnel, and through the tunnel the deep muscle will go and will attach to the distal phalanx. Is it clear now? If it simply blocks the way, the deep muscle cannot pass. So superficial muscle has to split. Because of the splitting, the deep will pass. Is it clear now? Is it clear? Have you understood the arrangement? This is how it happens. See this. See this. Do you appreciate now that superficial muscle is splitting and the deep muscle is passing through it? We can see the cut margin of the superficial. This is the deep muscles. Is it clear to everyone? Is it clear to everyone? Yes? All right. Now we have learned that for one finger, one deep muscle, one superficial muscle. So for 4 fingers, how many deep? 4 deep. And how many superficial? 4 superficial. Total 8 muscles for the digits. And 1 muscle for the thumb. What is 1 muscle for the thumb? Flexor pollicis longus. Pollicis means thumb. Is that okay? So 1 muscle for thumb and 8 muscles for the digits or the fingers. Total 9 muscles. They begin in the forearm and they have to reach the fingers. They begin in the forearm, they have to reach the fingers. But before reaching the fingers, they have to cross this wrist region. They have to cross this wrist region. Yes. So they will be content of wrist tunnel. Wrist means carpal. Carpal bones or the wrist bone, they make a concavity, and over the concavity of the wrist bone, which is also called as carpal bones, we have deep fascia making the roof. That makes the carpal tunnel. So how many tendons are passing through it? 9 tendons. What are the 9 tendons? Flexor pollicis longus, flexor digitorum superficialis, and flexor digitorum profundus. Is the concept clear to you guys? Concept is clear, yes or no, about carpal tunnel? Is it clear? Yes. Let me draw the carpal tunnel here. Let me draw the carpal tunnel. See, let me show you the first carpal tunnel, then I will give you the diagram. So this is the carpal convexity, and it is creating a concavity anteriorly, and this is the flexor retinaculum, the deep fascia, which presents superficial slip on the medial side and the deep slip on the lateral side. Now if I add the contents here, what will happen? If I add the contents, I will get a complete picture. This is the carpal bones and this is the carpal tunnel inside. How many tendons are there? See, 1 tendon, flexor pollicis longus, very good. 4 tendons, flexor digitorum superficialis. Four tendons, flexor digitorum profundus. Very good. Total 9 tendon. And the most important content is the median nerve. Is it clear? Yes. Very good. Now we have this tunnel through which the ulnar nerve and ulnar artery are passing. This is superficial to the flexor retinaculum. Yes, it is superficial to the flexor retinaculum. Very good. What is the name of this canal? This canal has got a name, Guyon's Canal. What is the name of the canal? Guyon's Canal. Are you understanding? Very good. This is one tendon, palmaris longus. This is also superficial to flexor retinaculum. Why I am telling superficial or deep? Because sometimes direct question is asked, which structures are superficial to flexor retinaculum and which structure is deep to the flexor retinaculum. And those first year students who are yet to write the university exam, this topic is very, very, very important. And you need to remember this for in detail, even for theory, also for viva. Okay, so remember this. Please pay attention. What I have told, I have described the deep structures. Now I am describing the superficial structures. Out of superficial structure, I have described ulnar nerve, ulnar artery, and the palmaris longus. Now please pay attention to these nerves. What are these nerves? These are called as palmar cutaneous branches. Palmar cutaneous branches, again, split the words. Look at the meaning of the words. Palmar means palm, cutaneous means the skin. So skin of the palm is supplied by the palmar cutaneous nerve. But palmar cutaneous branch of median nerve and palmar cutaneous branch of ulnar nerve. Are you understanding? Palmar cutaneous branch of median nerve, palmar cutaneous branch of ulnar nerve. Is it clear? Both of them are passing superficial to flexor retinaculum. Both of them are passing superficial to flexor retinaculum. And then there is an artery here, superficial palmar branch of radial artery. It is together, beta. बहुत ज़्यादा difference नहीं है. This is no big difference. This is in general we are writing ना. This is no big difference कि मतलब proximal है कि distal है. Are you understanding? Same picture you will get. इकट्ठे है ना, the means for description we divide like this is proximal row, distal, but otherwise the tunnel will be made by collective, है ना, इकट्ठे वो बनाते हैं. ठीक है. Now let me draw schematic diagram for you for the carpal tunnel and then we will proceed. See how we are going. Let me tell you so that you should not lose the track. We did the arm, front of the arm and back of the arm. Then we did the cubital fossa. Now how we are proceeding? We are going in the front of the arm. We have reached the carpal tunnel. Then we will go in this manner, the snuff box, and then we will come on the posterior compartment. So we are tracing one by one. Are you understanding? And then we will be left with the palm. Are you understanding? This is how we are proceeding. Yes, this is how we are proceeding. So you should not lose the track that where we have reached. We did the flexor compartment, now into the carpal tunnel. Next will be the snuff box, then will be the posterior compartment. Then this region will be done. Fine. Now carpal tunnel. Topic name is carpal tunnel. Now see. These are the carpal bones making the concavity, and this is what? This is flexor retinaculum, the deep fascia. It is presenting one superficial slip on the medial side. This is medial side. This is lateral side, and one deep slip on the lateral side. Are you understanding? The main mass is presenting superficial slip extra and deep slip extra on the lateral side and medial side. Are you understanding? Like this, like the diagram. Now as I told, we have tendons inside. Which tendon is present? There is this tendon present. What is this tendon? Flexor pollicis longus. And then 4 tendons of flexor digitorum superficialis and flexor digitorum profundus. Total 9 tendons are there. Now you see, when the tendons are going from the forearm, they are reaching the wrist region, they have to reach the palm, they have to reach the digits. इतनी लंबी जर्नी करनी है, they have to do very long journey. Yes, if they are going on a long journey and then we are doing so many movements, there is chances of wear and tear of the tendon. Yes, so to avoid wear and tear of the tendons are provided by a synovial sheath. Around the tendon, the synovial sheath is present. Are you understanding? So this synovial sheath around the flexor pollicis longus is called as radial bursa. So if I do the labeling here, what I will write? I will write this is flexor pollicis longus in radial bursa. The orange color is showing the radial bursa. I hope you are understanding it. I hope you are understanding it. Yes, flexor pollicis longus in radial bursa. Is that fine? And flexor digitorum superficialis and flexor digitorum profundus, they all are actually, surrounded together. They all are enclosed together in a single bursa, which is called as ulnar bursa. It is called as ulnar bursa. Now let me do the labeling again. These four tendons are flexor digitorum superficialis, and these four tendons are flexor digitorum profundus. Everything in ulnar bursa. In ulnar bursa. And here we have the most important content, that is median nerve. Median nerve, yes. This canal has got a name. What is this canal? This canal has got a name, Guyon's canal. Guyon's canal. This is Guyon's canal. And we have ulnar artery and ulnar nerve. Inside the Guyon's canal, we have ulnar artery and ulnar nerve. Right? Ulnar artery and ulnar nerve. ठीक है? Here we have palmaris longus. Here we have palmaris longus. And these are two nerves. If you remember, what were these nerves? This is palmar cutaneous branch of median nerve, this one, and of ulnar nerve, this one. Are you understanding? Palmar cutaneous branch of median nerve and palmar cutaneous branch of ulnar nerve. And there is this artery here, superficial. This is superficial palmar branch of radial artery. Superficial palmar branch of radial artery. Is it clear? Is it clear? Yes. If this we have learned, I will add one more tendon here. I will add one more tendon. This tendon is also surrounded by the synovial sheath. What is the name of the tendon? What is the name of the tendon? This is flexor carpi radialis. What is the name of the synovial sheath? No specific name. It is just synovial sheath. It has not been named specifically, just like the bursa. Okay, synovial sheath तो है, but इसका special नाम नहीं है. ठीक है? What is the name of the tendon? Flexor carpi radialis. And flexor carpi radialis is also present with the synovial sheath. Yes, it is present. Has to be, है ना? क्योंकि इसको भी तो protection चाहिए. Now question is whether flexor carpi radialis is a content of the carpal tunnel. No, it is outside the carpal tunnel. For practical purpose, this is considered as the content of the carpal tunnel. Are you understanding? Yes. But look at the location of palmar this. What is this? Palmar flexor retinaculum. What is this? Flexor retinaculum. What is the position of flexor retinaculum? With respect to flexor retinaculum, flexor carpi radialis is superficial or deep? Tell me, is it superficial or deep? It is deep. So this is very, very tricky. Please understand, flexor carpi radialis is deep to flexor retinaculum. True. It is content of carpal tunnel. No. Usually, most of the books, they do not write as a content of flexor retinaculum. Okay, it's not they don't write a content of carpal tunnel. Okay, I hope, is it clear? Is it clear? All the contents of carpal tunnel, are they clear? Yes or no? Yes or no? Is not clear? Contents are not clear, beta. Contents of carpal tunnel, tell me. Not clear? Clear हो गया? Very good. Let me repeat for those who are still confused. See, we have learned that flexor pollicis longus, flexor digitorum superficialis, flexor digitorum profundus, and the median nerve. These are the content. Yes, these are the contents. About flexor carpi radialis, usually not taken as a content of carpal tunnel, but it is deep to flexor retinaculum. Truly speaking, if you really want to learn what is flexor carpi radialis passing through, flexor carpi radialis is actually passing through, please pay attention, it is passing through the main mass and the deep sleep. Between the main mass and the deep sleep of flexor retinaculum. So exact language for this tendon is it is passing through the retinaculum. But in your exam, they don't write the option passing through the retinaculum. They either ask whether superficial to retinaculum or deep to retinaculum. So ideal answer or the best answer should have been कि it passes through the retinaculum. But वो तो choice में ही नहीं है. अगर choice में नहीं है तो हमारे पास क्या option बचा? Superficial के deep. So better to go with deep. Even if you take is a part deep to retinaculum, is it a content of tunnel? No, it is not a content of carpal tunnel. I hope it is clear now. Is it clear now, beta? The name all Ankit, all carpal bones together they make the tunnel. This is clear now. Yes. Now see, the next topic that I am going to take is anatomical snuff box. Anatomical snuff box. Now what is anatomical snuff box? What is anatomical snuff box? Anatomical snuff box is the one which is required to have a nice time, है ना? आपने देखा होगा ऐसे उड़ता पंजाब है और बहुत सारी मूवीज में दिखाया जाता है ना? कैसे स्निफिंग करते हैं, इस बॉक्स को यूज किया जाता है. सो वी नो व्हाट इज दिस बॉक्स यूज्ड फॉर, but right now we are going to study from anatomy point of view what are the tendons making the anatomical snuff box. Okay, so this is the anatomical snuff box. It is usually seen in the thin, जो thin people होते हैं, there it is clearly seen. In thick people the fat fills the gap, है ना? तो fat के कारण it is not usually observable in the thick in the fat people, है ना? Thin people में दिखता है, tendons clearly visible होते हैं. Now let me take you to the this part here. See, we can see this is anatomical snuff box and these two are the boundaries here. These two are the anterolateral boundary. This is posterior-medial boundary. So two tendons are together here and one tendon on this side. Two tendons on the lateral side, one tendon on the medial side. ठीक है, यहाँ पे क्लियर हो गया आपको? Which tendon is where? The question is which tendon is where? Let me give you one very simple schematic thing, that we have this tendon, two tendons making the lateral boundary. One of them is abductor pollicis longus. Abductor pollicis longus. Abductor means abductor, it does the abduction. Pollicis means thumb. Longus means it is a long tendon. If the term brevis is there, means short. Longus means long. ठीक है? What is this? What is this? This is extensor pollicis brevis, and the other boundary is made by extensor pollicis longus. Are you understanding? यहाँ पे हमें याद करना है थोड़ा सा, उसके बाद इंटरेस्टिंग हो जाएगा. याद क्या किया हमने? Abductor pollicis longus and extensor pollicis brevis, they are making the anterolateral boundary. Extensor pollicis longus is making the posterior-medial boundary. ठीक है? And the content is the radial artery. Content is the radial artery. ठीक है? Now let me give you the schematic diagram for anatomical snuff box. Anatomical snuff box. Understand with me. Understand with me. Anatomical snuff box. Okay? See what we are making, and this diagram will help you having a good understanding about the muscle attachment. This is radius, radial styloid. This is ulna, ulnar styloid. What is this? Radius, ulna, and the styloid. Okay, if this is radius and this is ulna, between them this membrane, what should be the name of the membrane? Interosseous membrane. Between the bones, interosseous membrane. What is the name of this membrane? Interosseous membrane. Interosseous membrane. Clear hai? Clear hai? Yes. Now see. This is carpal bones. After that we have the carpal bones present here. Yes. She looks too pretty. Try to catch her. Right? And then comes the metacarpal. And then comes the phalanges. Do you appreciate? Are you understanding the diagram? Then this is the other metacarpals, and these are phalanges. Fine. Now let me add the muscles here. So first muscle that I am going to draw is the muscle which is actually taking origin from the radius, taking origin from the ulna. Please understand, this is very, very important. It is taking origin from the ulna, it is taking origin from the radius, also from the interosseous membrane between them. Radius से भी, ulna से भी, उन दोनों के बीच की membrane से भी. From everywhere it is taking origin, and where it is coming to attach here on the base of first metacarpal. What is this? Base of first metacarpal. What is the name of the tendon? Can you tell what is the name of the tendon? It is abductor pollicis longus. Clear? Abductor pollicis longus. Now see, there is this muscle here which is taking origin from the radius and from the interosseous membrane, and there is this muscle which is coming from ulna and the interosseous membrane. Now with respect to thumb, which bone is nearer, radius or ulna? With respect to thumb, which bone is nearer, radius or ulna? Answer is radius. So the one which is coming from the radius will be shorter. The one which is coming from the ulna will be longer. Yes, both of them are reaching the phalanx of the thumb. But the one which is coming from radius should be termed as extensor pollicis brevis, and the one which is coming from the ulna should be termed as extensor pollicis longus. Is it clear? Have you learned the meaning of these tendons, from where they are coming? Abductor pollicis longus, extensor pollicis brevis, they are coming together on the medial side, the lateral side, anterolateral aspect. The posteromedial boundary is formed by extensor pollicis longus. Is it clear? If it is clear, please tell. Is it clear, beta? Yes, boundaries are clear. Now what makes the floor? Floor is made by the, we can see in the diagram, the radial styloid, scaphoid, trapezium, and the base of first metacarpal. This makes the floor. What makes the floor? The radial styloid, scaphoid, trapezium, base of first metacarpal. Let me write the notes for you. Okay? Boundaries, anterolateral boundaries are made by two muscles. What are these? Abductor pollicis longus, extensor pollicis brevis. Yes, very good. As I said, this batch is an excellent batch. Very good level of reception, है ना? बहुत ही रिसेप्टिव बैच है ये. जैसे कुछ बताते हैं इमीडिएटली रिसीव कर लेते हो, इमीडिएटली समझ लेते हो. वेरी गुड. You will do good in life, I am telling you. Okay. Posteromedial is extensor pollicis longus. ठीक है. Anterolateral abductor pollicis longus, extensor pollicis brevis, and posteromedial extensor pollicis longus. ठीक है. अब याद रखना तो आसान है ना. अगर आपसे कोई पूछ लिया अटैचमेंट, एक्सटेंसर पोलिसिस लॉन्गस का अटैचमेंट कहां पे है, तो थंब से दूर वाली बोन है ना, अल्ना. एक्सटेंसर पोलिसिस ब्रेविस मतलब शॉर्ट मतलब नजदीक वाली बोन. थंब के नजदीक वाली बोन कौन सी है? रेडियस, वहां से आएगी. ठीक है. और दोनों को मिला दें तो एब्डक्टर पोलिसिस लॉन्गस है, जो सबसे ले रही है. इसने अल्ना से भी ओरिजिन लिया है, रेडियस से भी ओरिजिन लिया है, इंटर मेम्ब्रेन से भी ओरिजिन लिया है ना? थैंक यू सो मच, थैंक यू सो मच। ठीक है, अब हमारा जो फ्लोर है, फ्लोर इज मेड बाय व्हाट? फ्लोर इज मेड बाय व्हाट? फ्लोर बनाएगा रेडियल स्टाइलॉइड, है ना? हमने देखा कि रेडियल स्टाइलॉइड हमारा फ्लोर बना रहा है, वेरी गुड। ठीक है, फिर हमने और क्या देखा? स्कैफोइड भी बना रहा है, वेरी गुड। फिर हमने देखा ट्रेपेजियम भी है ना? और बेस ऑफ फर्स्ट मेटाकार्पल, दिस इज ऑल मेकिंग द फ्लोर। बेस ऑफ फर्स्ट मेटाकार्पल, बेस ऑफ फर्स्ट मेटाकार्पल, फाइन। What is the content? Content is very important here, and the radial artery is the answer. Content is radial artery, radial artery. And then there are two structures in the roof. What are the structures in the roof? Structure in the roof are cephalic vein. It is cephalic vein, cephalic vein, and cephalic vein and superficial branch of radial nerve. Superficial branch of radial nerve, है ना? अब एक बात बताओ, हमारी जो एक सुपरफिशियल वेन्स है ना, वन वेन इज बेसिलिक वेन, द अदर वेन इज सेफेलिक वेन, ठीक है? अब कौन सी लेटरल साइड में होती है, कौन सी अल्नर साइड में होती है, मीडियल साइड में होती है? सो समटाइम आई सी स्टूडेंट्स आर क्लियर, समटाइम आई सी स्टूडेंट्स आर कंफ्यूज. फॉर दोज इट इज क्लियर, वेरी वेल एंड गुड. फॉर दोज इट इज स्टिल नॉट क्लियर, लेट मी गिव यू very easy thing to remember, very easy concept to remember. See, if I ask you put your you see the forearms on the table, you will put the forearm on the table like this or like this. हम तो ऐसे ही रखते हैं ना हाथ, हमारा हाथ तो ऐसे आएगा, सपोज ये टेबल है, हमारा हाथ तो ऐसे आएगा. अगर हाथ ऐसे आ रहा है तो आपका बेस कौन बना रहा है? बेस बना रहा है अल्ना, or head portion or the cephalic region with respect to the forearm, who is in the upper part. Upper part is called as cephalic region. Upper part is the radial region. When you are putting your hand like this, the base is made by the ulna. तो ulnar side में or the medial side or the ulnar side, the vein present should be called as basilic vein. It is around the base. And who is on the upper part? Upper part is always called as cephalic. So the radial side vein or the lateral side vein is called as cephalic vein. This is very easy to remember. Please remember like this. Cephalic vein is on the lateral side. Basilic vein is on the medial side. Is it clear? Yes or no? Yes, it is clear. ठीक है, याद आ गया, समझ आ गया बेटा? Very good. Now see, regarding cephalic vein, before we proceed, let me write 2-3 points about the cephalic vein. Cephalic vein हमने कहाँ कहाँ पे देखा है? Cephalic vein, where we have written the cephalic veins. What is the importance of the cephalic vein? Cephalic vein, what are the important points? We have seen in the roof of anatomical snuff box. In the roof of anatomical snuff box. Yes? This is just now we have done. इसके अलावा cephalic vein will be present in the deltopectoral groove. You remember? Deltopectoral groove. And also it pierces CP fascia. You remember we have already discussed this. The pierces CP fascia. Thank you बेटा सुशील. समझ आया? सेफेलिक वेन के पॉइंट नोट कर लिए आपने, वेरी गुड. अब कार्पल टनल के साथ carpal tunnel syndrome is very very important, but carpal tunnel syndrome we will do a little later. That's why I have not described it there. Okay, that's why I have not described it there. Okay, but just let feature I will tell later. Let me add only one thing here. Let me add only one thing here. See, usually what happens, carpal tunnel syndrome, I am just describing the etiology, है ना? Carpal tunnel syndrome, because of various etiologies, the medical causes are there for the carpal tunnel syndrome. What happens? The flexor retinaculum gets inflamed. If the flexor retinaculum gets inflamed, the overall volume of the tunnel will be compromised. Do you agree? Do you agree कि if the flexor retinaculum is inflamed, inside swelling is there, maybe fluid may or may not be there, but if the flexor retinaculum is inflamed inside, the volume will be compromised. If the volume is compromised, median nerve will be compressed. Yes, this is something which is very important to understand. Now I am adding one more point here. There is this bone, lunate bone. Now lunate has got a tendency to dislocate anteriorly. lunate has got tendency to dislocate anteriorly. Suppose there was a fall, and then suppose there was a fall, and then the lunate gets dislocated anteriorly. There is no problem with the flexor retinaculum. There is no medical cause, but volume of the carpal tunnel will still be compromised. Again, the feature will be as that of carpal tunnel syndrome. Did you understand? Carpal tunnel syndrome usually involves the flexor retinaculum. Yes, but if the lunate gets dislocated anteriorly, it is going to compromise the volume of carpal tunnel. Yes, that's true. If it happens, median nerve will be compressed. If the median nerve compressed, the feature of carpal tunnel syndrome will be developing. Is it clear? Thank you, Gaurav. As I have already told you guys, I am also enjoying taking classes for this batch. थैंक यू सो मच. ऑलराइट, समझ आ गया, कंसेप्ट क्लियर हो गया. बाकी कार्पल टनल सिंड्रोम के फीचर्स जो मतलब द इंपॉर्टेंट फीचर अबाउट द मीडियन कंप्रेशन, वी विल टॉक अबाउट दैट इन ए मोमेंट. ओके, first we are done up to this. Anatomical snuff box is done. Now let us come back to the posterior compartment of forearm. Let me first write the names, then I will show the muscles. First let me write the names, then I will show the muscles of posterior compartment of forearm. Posterior compartment of forearm. Again we have deep muscles and superficial muscles. Deep muscle and superficial muscles. Fine. अब डीप मसल्स कितने थे? 5 थे. सुपरफिशियल मसल कितने थे? 7. Let us write down the mnemonic to remember the names. What is the mnemonic? Mnemonic is suspend all 3 engineers. All 3 engineers. Instead of writing engineers, I am writing 3E. E means engineers, right? We are going to use only E. That's why I have written E. Suspend all 3 engineers is the mnemonic. On this side, we have boil all 5 eggs. Boil all 5 eggs. Again, for egg, I am using E. सपोज आप भूल गए कि कौन सा इंजीनियर था, कौन सा एग था, कोई फर्क नहीं पड़ता, आपको सिर्फ ई ही चाहिए. आप सपोज आपका न्यूमोनिक बन गया सस्पेंड ऑल 3 एग्स, दैट्स फाइन. आपको तो ई चाहिए. एंड बॉयल ऑल 5 इंजीनियर्स, दैट्स फाइन. मीन्स वी शुड नॉट बॉयल द इंजीनियर्स लिटरली, बट फॉर द न्यूमोनिक सेक कोई फर्क थोड़ी पड़ेगा कि हमने किसको बॉयल किया, किसको सस्पेंड किया है ना. आर यू अंडरस्टैंडिंग? यस, वेरी गुड. ठीक है, तो चलो हम आगे लिखते हैं मीनिंग क्या है इनका. लेट अस राइट डाउन. देखो, सस्पेंड से जो हमारी मसल है दैट इज सुपाइनेटर. सुपाइनेटर इज वन ऑफ द मसल. सुपाइनेटर इज वन ऑफ द मसल हेयर विच बिलोंग्स टू डीप ग्रुप. Then let me give you very important understanding. Now that we have learned the anatomical snuff box muscle, it will make very easy for us to understand the compartment. That's why I started with the anatomical snuff box, right? ये जो 3 muscles हैं, these are snuff box muscles. These are snuff box muscles. What are these? See, abductor pollicis longus, very good. Extensor pollicis brevis, very good. Extensor pollicis longus. ये 3 मसल तुमने याद की थी. इसका मतलब ये है, it means that the muscles of the anatomical snuff box, they actually belong to deep group of posterior compartment of forearm. Are you understanding? Very good. Only one muscle is there, extensor indicis, that you need to remember. Okay, extensor indicis. I hope if you are going in a flow with me, if you are with me the way we are proceeding, I hope most of the things you will remember in the first reading also only, in the first reading only. Okay, and if you keep on revising, these things will stay in between your ears, I mean in the brain. Are you understanding? It will definitely stay in your memory. Okay, so in the first reading just go in this same flow that we are proceeding and then keep on revising. That is the gist. Fine. Now coming to the superficial muscles, what is the meaning? Superficial muscles. See, B boil से क्या होता है? Brachioradialis. I will explain this part, है ना? Brachioradialis I have already explained. Other muscles I will show. What is A is anconius, anconius. Then we are left with 5E. 5E है ना. 5E में we have to first take care of the carpi muscles. You remember flexor carpi radialis, flexor carpi ulnaris were there in the flexor compartment. Similarly, extensor carpi radialis and extensor carpi ulnaris should be there in the posterior compartment. So we can write extensor carpi radialis, but then extensor carpi radialis is having two parts, extensor carpi radialis longus and extensor carpi radialis brevis, which was not seen in the flexor group, extensor carpi ulnaris. So three carpi muscles are there, three carpi muscles are there, है ना. ठीक है. कई बार होता है ना कि हम एक कान से सुन के दूसरे से निकाल देते हैं, लेकिन जो इंपॉर्टेंट होता है इधर से सुनो, इधर से निकालो मत, रख लो बीच में. ठीक है. Extensor carpi radialis longus brevis and ulnaris. Then we have extensor digiti minimi, extensor digiti minimi and extensor digitorum. For all the digits, we have extensor digitorum. These are the names of the muscles. We have just learned the names of the muscles. Is it clear? Names of the muscles. पहले name लिख लो, फिर I will show all the muscles. I will show. It will become clear to you. ठीक है बेटा, बना लिया. Right? Okay. Now let me show you the diagram. ईशान, एबडक्टर पोलिसिस ब्रेविस. ब्रेविस का मतलब होता है शॉर्ट. पोलिसिस ब्रेविस है ना, ये पाम की इंट्रिंसिक मसल है. लॉन्गेस्ट मसल इज नॉट द मसल ऑफ द पाम, इट इज कमिंग फ्रॉम समवेयर एल्स. दैट्स व्हाई इट इज लॉन्ग, बट इट इज एक्चुअली प्रेजेंट इन विद द डिजिट्स. दैट्स व्हाई. आर यू अंडरस्टैंडिंग? लॉन्गेस्ट मतलब है दूर से आई है, काम थंब पे ही कर रही है, इसलिए इसका नाम भी पोलिसिस कर दिया. लेकिन जिसको हमने पोलिसिस ब्रेविस कह रहे हैं ना, ब्रेविस मतलब शॉर्ट, तो विद इन द पाम मसल प्रेजेंट है. एबडक्टर पोलिसिस ब्रेविस इज ए पार्ट ऑफ थिनर ग्रुप ऑफ मसल. वो प्रेजेंट तो है, लेकिन अभी हमने पढ़ी नहीं है, अभी हमने पाम नहीं पढ़ा ना. नाउ सी दिस, देयर वाज नो मेंशन ऑफ फ्लेक्सर कार्पी अल्नरिस. बेटा फ्लेक्सर कार्पी अल्नरिस जो है वो मैंने आपको बताया था कि अल्नर नर्व से सप्लाई होती है. वी हैव ड्रॉन दैट in the section of the forearm. You go back to the diagram, see the section of the forearm where we have written the superficial muscles. The medial most muscle, there we have written flexor carpi ulnaris, and there you have drawn the ulnar nerve supplying it. Please check, it is there, है ना. Okay, now let me start with the muscles here. See, this muscle is brachioradialis. Can you see, if I draw this line, what is this line? There is this line. ये एल्बो है, एल्बो के नीचे फोर आर्म है, एल्बो के ऊपर आर्म है ना. बट वी कैन सी द ब्रैकियोरेडियलिस इज एक्चुअली टेकिंग origin, it is actually taking origin from this part. Yes, it is taking origin from above the elbow, मतलब arm से. That is why the name brachium is there. Are you understanding? That is why the name brachium is there. Brachium, it is coming from the arm region and it is attached on the radius. That is why the name is brachioradialis. Begins in the brachium, ends in the radius. That is why the name is brachioradialis. Is it clear, beta? Right? ठीक है. All right. See now. So this is brachioradialis. Now just beneath, just lower to brachioradialis, but still above the line. Brachioradialis के साथ एक और muscle. There is one more muscle which is also coming from above the elbow. What is from above the elbow? The other muscle is extensor carpi radialis longus. The longus is again from above the elbow. Longus is again from above the elbow, and just below it we have this. This is brachioradialis. This is extensor carpi radialis longus, and this muscle is extensor carpi radialis brevis. Is it clear? Is it clear? Yes. And you can see one triangular muscle here. The triangular muscle is anconeus. This is anconeus. Fine. Now see, we can see this muscle here, which is actually dividing into four tendons. So this mass of the tendon, which is further dividing into four parts, is nothing but extensor digitorum, because it is finally be supplying the four digits. So it is extensor digitorum. Yes. And this muscle here, this muscle here is extensor digiti minimi. Extensor digiti minimi. Extensor digiti minimi. What is digiti minimi? Minimum digit. Minimum means little, digits means finger. Minimum digit means little finger, which is also called in Punjabi as chichi. Okay, the chichi. Alright. So extensor digiti minimi is for extension of little finger. Extension of little finger. Is that fine? Yes. And what is this muscle? What is this muscle here? Is extensor carpi ulnaris. Extensor carpi ulnaris. Yes. All the muscles have you seen? Are you clear about these muscles? Yes. Now these are the superficial muscles. These are the superficial muscles. Now let me show you the deep muscles. Now let me show you the deep muscles. See, here in this diagram, we have cut the superficial muscles and we can see the deep muscles. See, look at this part. Now you have to answer quickly. Quickly you have to answer. This muscle coming from radius. This is radius. This is ulna. This is coming from radius and ulna and from the interosseous membrane. Do you appreciate here? This is coming from all three and finally going up to the base of first metacarpal. What is this? This must be abductor pollicis longus. Are you understanding? Yes. Now tell me about this muscle. It is coming only from the radius and the interosseous membrane. It is extensor pollicis brevis. This muscle is actually coming from the ulna and the interosseous membrane and finally going on to the thumb up to the distal phalanx. Are you understanding? So what should be this muscle? This muscle should be extensor pollicis longus. Are you guys understanding now? Are you guys understanding now? How is this happening? Yes. And finally, one muscle for the index is extensor indicis. This is extensor indicis. These are the deep muscles. Supinator is not here. Supinator was making the floor of the cubital fossa. There we have seen the supinator muscle. Is that okay? Are you guys done? Now you are understanding. Okay, you guys are understanding now all the muscles. Suppose this diagram is given you in an exam and then they mark one of the muscle. Will you be able to identify? Okay, so if you see any such diagram in your exam, don't get terrified. First try to understand from, first try to look at the exam from where you are understanding, then try to trace the structures. Okay, when you are trying to tracing the structures, then only you will be able to reach the answer in case of any diagram, maybe from neuroanatomy, maybe from gross anatomy, fine, or any other subjects for that matter, right? So let us proceed now, and now we are done up to this. I hope it is clear. I hope it is clear. Is it clear, beta? Now we are done with the compartments of the forearm. Compartments of the forearm. Now we are going to start the palm. Yes, indices means index. Very good, Gaurav. Indices, as the name suggests, looks like index. It goes to index. Okay, index finger, indices. Now we are going to start the palm. To understand the palm, let me give you the notes. I will tell movements of the thumb. Movements of the thumb. I don't know how big I am looking. Okay, I'll try to focus. My thumb should be visible. See, this is flexion. When the thumb goes within the plane of the digits is called as flexion. This is extension. Okay, this is abduction. Going in the actually perpendicular direction is abduction. In the this is abduction, adduction. Are you understanding? Going in the perpendicular direction, this is abduction and adduction, like this. This is flexion and extension, and this is circumduction. Okay, flexion extension in the plane, adduction, abduction, perpendicular, and all around is the circumduction. Fine. All right. Now see, now we are going to talk about the palm. Now we are going to talk about the palm. See, palm. After palm, we need to discuss the breast tissue in brief. Breast tissue from anatomy. When I say brief, some pre-foundation students may think I will not tell anything. I will tell the points which are important for anatomy, because rest of the breast tissue or the mammary gland will be taken in detail in surgery. It is a very important topic for surgery, and you will be doing really in details when you come to the surgery. Okay, and don't worry, before your exams all 19 subjects will be done, so don't worry. Okay, कोई थोड़ा पहले फाउंडेशन में है ना, आप बाद में फाउंडेशन में जाओगे, बट दैट डजंट मीन कि आपको कम पढ़ाया जाएगा, है ना। बट अभी धीरे धीरे जो सब्जेक्ट हो रहा है उसको पढ़ते चलो साथ के साथ। ओके, राइट। नाउ इन द पाम वी हैव ग्रुप्स. व्हाट आर द ग्रुप्स? थिनर ग्रुप एंड हाइपोथिनर ग्रुप. फर्स्ट वी आर टेकिंग थिनर ग्रुप, हाइपोथिनर ग्रुप. Total 5 groups are there in the palm, let me tell you. Thenar group, hypothenar group, lumbricals, dorsal introsei, palmar introsei. Total 5 groups are there. Fine. I will talk about the nerve supply. Nerve supply अनुभव मैंने पढ़ाया नहीं है अभी, क्योंकि ना मैं nerve supply को थोड़ा सा डिटेल में लूंगा. The nerve supply I will tell in the detail. That's why I have not taken. Okay, अनुभव, don't worry. I'll tell. That is very, very important. And in fact, that topic is actually, you see, in overlapping with the orthopedics. Again, Dr. Tushar will talk about the nerve injuries and all, then it will make it more clear. But from anatomy, I will tell the basic things, okay? So that's why the nerve I will take in detail. Okay, now thenar and hypothenar, remember like this. Thenar and hypothenar, remember like this. T for thumb, है ना? So thenar is on the thumb side. Just opposite will be the little finger. So hypothenar will be on the little finger side. Little finger side. So all the muscles on the thumb side will be termed as pollicis. They will have the word pollicis in them. And here the word digiti minimi will be there. Obviously, isn't it? Digiti minimi. ठीक है बेटा? Now what are the muscles present? What are the muscles present? Let us start. First muscle here is abductor pollicis brevis. On this side, abductor digiti minimi. Then we have here flexor pollicis brevis. On this side, flexor digiti minimi. Then if we cut these two muscles and go one level deep, we will see opponens pollicis. We will see opponens pollicis. On this side, we will see one deep muscle which is called as opponens digiti minimi. Opponens digiti minimi. Is that okay? Abductor pollicis brevis, abductor digiti minimi. Flexor pollicis brevis, flexor digiti minimi. Opponens pollicis, opponens digiti minimi. These three muscles are there in the group. Then I am making a line here. I am making a line here. Means the fourth muscle I am going to write here. It is not exactly in the group, but it is associated. Why? I will tell. There is this muscle which is very deep. It is called as adductor pollicis. So adductor pollicis is not responsible for the bulge. This bulge is because of the thinner muscles. But adductor pollicis, being a very deep muscle, is not responsible for the bulge. But why we are taking then it? Why we are saying it is associated muscle? Because it is working on the same digit. That is why it is included along with, it is studied along with the other pollicis muscle. That is why. Otherwise, strictly speaking, it is not a part of thinner muscles. And on this side, superficial muscle. Superficial muscle is palmaris brevis. Palmaris brevis is again not a part of hypothenar muscle. But then why we are studying this as a along with the other hypothenar? Because of the location. Palmaris brevis is a cutaneous muscle. It is cutaneous. Cutaneous means it is inserted in the skin, in the dermis part of the skin. So it is a cutaneous muscle, but on the hypothenar side. That is why it is so superficial that it is actually a cutaneous muscle. So if I summarize, we have abductor pollicis brevis on this side, abductor digiti minimi on this side, flexor pollicis brevis and flexor digiti minimi, opponens pollicis, opponens digiti minimi. These are three muscles. Fourth muscle is associated. On this side, we have deep muscle. What is the name? Adductor pollicis. On this side, we have superficial muscle. What is the name? Palmaris brevis. Is it clear now? Yes. Let me show you these muscles, then we will proceed. Okay. Let me show you these muscles, then we will proceed. See, you can make out now. There is this muscle here. This is abductor pollicis brevis. And on this side, you see, this is abductor digiti minimi. Abductor means on the sides, na? Abduction is to take away from the midline. Side की तरफ होगी. Just inner to it, this muscle is flexor pollicis brevis. Just inner to it is the flexor digiti minimi. Now, if we make a cut here, you have made a cut here, and we go one level deep on this side as well as on this side, we will see the opponents. See this muscle? We can see the cut portion. Do you appreciate the cut portion here? You appreciate the cut portion? We can approach this muscle. What is this muscle? Opponens pollicis. Similarly, we can see the cut margin here. We can see the opponens digiti minimi. Are you understanding? Abductor, flexor and opponens muscles are there. Yes. Along with that, we can see this muscle, which is actually very deep, but it is working on the same digit. That means it is inserted onto the thumb. It is deep muscle. But look at the depth of the muscle. It is deep to these muscles, these tendons. Are you understanding? So what is this muscle? Is adductor pollicis. This is adductor pollicis. And in these diagrams, we cannot see palmaris brevis. Why? Because palmaris brevis is inserted in the skin. When we started dissection, it is gone with the skin. Are you understanding? Palmaris brevis is not there now. Okay. We are done with the thinner and hypothinner group. Let me tell you about the next group. Yes. Now, do you appreciate these tendons? See, these tendons are bifurcating for these tendons to pass through. The bifurcating tendon are flexor digitorum superficialis. Bifurcating tendon are flexor digitorum superficialis, and the tendons which are passing through is the flexor digitorum profundus. Are you understanding? Yes. Let me trace the flexor digitorum profundus. These are the tendons of flexor digitorum profundus. Yes. When I look at the flexor digitorum profundus in the palm region, I observe that the flexor digitorum profundus is giving origin to a muscle. This muscle here. This muscle. Do you appreciate this muscle? What is this muscle? This is lumbricals. Lumbricals are the muscles which take origin from the flexor digitorum profundus. Flexor digitorum profundus. Is that fine? Profundus. So, and flexor digitorum profundus. Fine. Let us write down about the lumbrical muscles. Next group in the palm is lumbrical muscle. Lumbricals muscles. See, we have the tendons, flexor digitorum profundus tendon, flexor digitorum profundus tendon, and the muscles which are taking origin from here is this. This is lumbrical 1, this is lumbrical 2, this is lumbrical 3, this is lumbrical 4. Now, which lumbrical can be called as lumbrical 1? The one on the radial side. We always start the numbering from the radial side. The lumbrical towards the thumb will be called as first lumbrical. Now look at the diagram and tell me Which lumbrical is unipinnate? We can see in the diagram lumbrical 1 and 2 are unipinnate, whereas we have seen in the diagram lumbrical 3 and 4 are bipinnate. Do you agree? Why bipinnate? Because they take the origin from adjacent tendons. They take adjacent tendon, adjacent tendon. Okay. Okay, Shreya, I will show the diagram again and I will show the flexor digitorum profundus again. Is that okay? Lumbricals. This is about the lumbricals, where the lumbricals are taking origin from. Origin is flexor digitorum profundus tendon. And where is the lumbrical insertion? Insertion is DDE. What is DDE? It is nothing but dorsal digital expansion. Dorsal digital expansion. Dorsal digital expansion. And what is that dorsal digital expansion? It is a name of, it is the name of tendon, tendon of extensor digitorum. It is a tendon of extensor digitorum. Now see what is very funny thing here. See what is very funny thing here. What is the origin? Please everyone pay attention. I want your focus. Please everyone pay attention. Origin is FDP tendon. What is FDP? Flexor digitorum tendon. You can say the digit means the finger. Finger flexor tendon से origin लिया. Insertion एक्सटेंसर डिजिटोरम टेंडन मीन्स उसी डिजिटोरम के एक्सटेंसर टेंडन पे इसने इंसर्शन किया. मीन्स इफ आई शो यू फिंगर, its flexor tendon is giving the origin and its extensor tendon is giving the insertion. So it is very important and kind of a unique feature that it is taking origin from the flexor tendon and it is inserted onto the extensor tendon. Because of such unique arrangement, I am repeating, because of such unique arrangement, that taking origin from the flexor tendon inserting onto the extensor tendon, it has dual action at two different joint. What is the action? If you remember the thullu, in the beginning of the class we talk about the thullu. The action is at two joints, MCP joint and IP joint. You remember MCP joint, they do flexion, and IP joint, they do extension. Have you ever thought that why single muscle is doing flexion and also it is doing extension? It is because of its attachment. It is when it begins, it is attached to the long flexor tendon, and when this muscle ends, it is attached to the long extensor tendon. It is unique attachments give it the unique type of features, unique type of action. On one joint it is flexor, the other joint becomes extensor. Have you understood? Have you understood? Yes. Now let me show you the the flexor digitorum profundus that you have asked, the tendons, and then we will proceed with the next group of muscle. See what I have told here. You see the tendon which is splitting? I am showing you the two split. The two split is flexor digitorum superficialis, and that tendon, this one, which is I'm now showing with the straight arrows, is flexor digitorum profundus. So this tendon is also flexor digitorum profundus. This is also flexor digitorum profundus, right? And this one is also flexor digitorum profundus. From these tendons, this muscle is taking origin now. Are you understanding? These are lumbricals. These are lumbricals. So concept clear, beta? Are you understanding? Yes. Now let us proceed and write down about the palmar and dorsal interossei. Palmar and dorsal interossei. Okay. Next we have two groups, palmar interossei, palmar interossei. Interossei means in between the bones. Okay. Then dorsal interossei. Dorsal interossei. palmar interossei and dorsal interossei. ठीक है. इसके बाद देखो इनका मसल नंबर कितना, 4 each. इनमें से one muscle is unipinnate and the other is bipinnate. How to remember which one is bipinnate? Remember D4 double and D4 dorsal. means the dorsal is bipinnate, means the dorsal is bipinnate. Did you understand? This is how we can remember which one is bipinnate. D for double. Okay, so this is unipinnate. Gaurav, beta, don't worry, nerve supply will be done. Okay, everything. Nerve, three important nerves, median, ulnar, and radial. I will talk in details. And with that, all the important nerve supply will be covered. Don't worry. Okay, now see this. Now, what is the action? For action, remember pad and dab. Pad and dab. What is the meaning? Palmer does the adduction. Palmer does the adduction. Dorsal does the abduction. Dorsal does the abduction. Is that fine? Is that fine? Yes. But remember, when you talk about the action of these muscles, remember this is very important. When you talk about the action of these muscles, this is actually primary action. These muscles also have secondary action. These muscles also have secondary action. What is the secondary action? And you will be surprised or you will be amazed to know that the secondary action of these muscles is the action of lumbrical. The action of lumbrical, that is MCP flexion and IP extension, is the secondary action of both palmar and dorsal interossei का secondary action common है. क्या है? Action of lumbrical. क्योंकि they assist the lumbrical, because they assist the lumbrical in their action. So primary action of themselves, खुद का action क्या है? Adduction, abduction. But secondary action means it helps in the action of lumbrical. Are you understanding? Are you understanding? Yes. हाँ जी बेटा, हो गया. दिव्या, कर लिया आप लोगों ने? इसको नोट डाउन करो. देन आई विल एक्सप्लेन दिस मसल्स. देन आई विल एक्सप्लेन दिस मसल्स एंड दैट विल बी finishing our palm. But we will write about the blood supply. We will write about the blood supply later. Muscles of the palm will be done. Done? All right. Now see this. Do you appreciate? What is this muscle? This is lumbrical 1. What is this muscle? Lumbrical 2. What is this muscle? Lumbrical 3. And what is this muscle? Lumbrical 4. Lumbrical 4. Okay. Insertion of lumbricals you need to remember, beta. Where? I'll show. अच्छा, रेडियन अल्लर बेटा उसने दे दिया जवाब है ना. Okay. Now see. See this muscle. What is this muscle? Can you see the bones here? Can you see the bones? Bones. In between the bones, you see dipinnate muscle. You see the bipinnate muscle. Do you appreciate? These bipinnate muscles are what? These are dorsal or palmar interossei. These are dorsal interossei. Dorsal interossei. हाँ बेटा, do not use the chat box for the personal questions, है ना? This is not for personal chat. This is for doubts. If you have doubt, you talk to me. It's not for personal chat. You can help each other, that is fine, but do not ask personal details. Okay, that doesn't look good, है ना? आप क्लब पे या बाकी जगहों पे जो करते बात, आपके अपने प्रोफाइल पे जो करते, that is fine. Don't ask here, है ना? चलो, dorsal interossei. Now please pay attention, everyone. See, this is the axis. This is the axis for adduction and abduction. This is the axis for adduction and abduction. Now this is my middle finger where the axis is passing through. If I bring the other fingers towards the middle finger, it is coming towards the axis. Coming towards the axis means adduction. Add हो रहा है ना? Adduction. Going away from the axis means abduction. Are you understanding? Adduction coming towards the middle finger. Abduction going away from the middle finger. Is that clear? Yes? Now tell me, if I want to adduct thumb, I can do that. If I want to adduct the index finger, I can do that. I can adduct all the fingers. Can I adduct? Can I adduct the middle finger? No. Middle finger is already in the axis. Going towards the axis is called as adduction. जो पहले से ही axis में है उसको और कितना axis में लाओगे भैया, है ना? ये तो already axis में है ना, तो इसको तो हम नहीं कर सकते adduct. Are you understanding this? ठीक है? Now second thing is abduction. Going away from the axis is abductor. But can we abduct the middle finger? Can we abduct the middle finger? Yes, we can. क्योंकि अगर middle finger इधर move हो या इधर move हो, then both the cases middle finger will be going away from the axis. Because axis is static, axis is not middle finger. Only thing is axis is passing through the middle finger. Axis, yes, suppose my pen is the axis. I move the middle finger here, away, move here, away. Are you understanding? In both the sides, middle finger will move. It will be away from the axis. So it can be abducted both side, but it cannot be adducted. Now tell me, if the middle finger cannot be adducted, which muscle will be absent in the middle finger? Which muscle will be absent in the middle finger? The one who does the adduction. अगर हम इसको adduction कराते ही नहीं है, तो pad, palmar introsei must be absent. See, look at the diagram. Palmar introsei going to the thumb. Look at the diagram. Palmar introsei going to the thumb. Palmar introsei going to the index finger, ring finger, and the little finger, but not a single palmar introsei coming to the middle finger. Did you understand? So which muscle is absent in the middle finger? Palmar introsei is absent. Yes. With this logic, if palmar introsei is absent, how many dorsal introsei will be taken by the middle finger for the abduction? Now abduction of the middle finger can be in this direction and can be in this direction also. So two dorsal introsei will be used by the middle finger, one on this side and the other on this side. Do you appreciate? Total are how many? Total dorsal introsei are 4. Out of 4, 2 are taken by the thumb. Now how many are left? 2. The remaining 2, one will go to index and the last will go to ring finger. So which fingers are now devoid? Thumb is devoid and the little finger is devoid of the dorsal introsei. If thumb and little finger are devoid of dorsal introsei, who will do their abduction? They have got their own abduction. Abductor pollicis longus, abductor pollicis brevis, and abductor digiti minimi. You remember we started the discussion of the palmar muscles with these muscles only. You remember abductor palmaris, abductor pollicis brevis, and abductor digiti minimi. Did you understand? Every one of you, have you understood this? Have you understood? Is it clear? If it is clear, write something so that I will know that it is clear. Then I will write the notes. We will finish. We are already done with the notes. A little 1 or 2 points are there to be added. Is it done, beta? Yes. Is it clear? Tell me. Tell me quickly that it is clear. Yes. Okay. Okay. I will revise that part. I will repeat. Okay. See this part. Yeah. I will revise that part. Don't worry. Okay. Now let us come back to the table and write those who have understood. Please finish the notes, everyone. है ना? Palmar introsei will be absent where? Palmar introsei will be absent in middle finger. Whereas dorsal introsei will be it will be double in middle finger, double in middle finger. And it will be absent in which finger? This absent and double is very, very important. That's why I'm taking time and emphasizing why direct question was asked in your exam. Okay, so it is double in middle finger and absent in thumb, absent in thumb and little finger, absent in thumb and little finger. ठीक है? Okay, now I will do the revision. I will do the revision of both the palmar and dorsal interossei. एक बच्चे ने क्वेश्चन किया है कि अगर एबडक्शन होगा तो एडक्शन के लिए तो चाहिए, है ना बेटा? तो दूसरी साइड का एबडक्टर भी तो लगा हुआ है. आई शो. मैं रिपीट कर रहा हूं. नोट्स आर डन. लेट अस गो बैक टू दिस इमेज नाउ. वन बाय वन. ओके, स्टेप बाय स्टेप विल गो. See, remember one thing, that start from this part. Axis passes through middle finger. Middle finger itself is not the axis. Axis is passing through the middle finger. Start with this. Now, when it is already in the axis, I cannot adduct it. If I cannot adduct it. So, which muscle should be absent? Palmar interossei should be absent. So there is no confusion. Now coming to dorsal, where you are confused. Some of you are confused. See, I am saying this. If I bring the middle finger here, suppose it is away from the axis, yes. So I need one dorsal interossei on this side, yes. If I bring the middle finger here, it is again away from the axis, yes. I need another dorsal interossei here, yes. Are you understanding? So how many middle fingers, how many dorsal interossei are used by the middle fingers? 2. Is it clear? Yes. Now, third is used by the index and fourth is used by the ring finger. Total dorsal interossei. So palmar interossei absent in middle finger, dorsal interossei double in middle finger. So which fingers will be devoid now? Thumb does not have the dorsal interossei, little finger does not have the dorsal interossei. ठीक है? अब प्राची बेटा, आपका क्वेश्चन है कि अगर एक बार यहां पे इस साइड चला गया फिंगर, हमारा मिडिल फिंगर, तो वापस भी तो आना है. इधर साइड का डोर्सल इंट्रोसे तो अटैच्ड है ना बेटा, ये वाला डोर्सल इंट्रोसे इसको ले आएगा इस तरफ. इज इट क्लियर नाउ? दोनों तरफ डोर्सल इंट्रोसे लगा है ना, तो मूवमेंट इधर इधर दोनों तरफ हो जाएगी ना. ठीक है, क्लियर है अब आप लोगों को? इज इट क्लियर टू एवरीवन? इफ यू हैव अंडरस्टूड एंड इट इज क्लियर, give me smiley quickly or write that it is understood, because this is very, very important and direct question was asked where it is double and where it is absent. Okay, so you just don't have to write it down in the notes and keep thinking कि बाद में कर लेंगे. बाद में नहीं करना है, अभी क्लास हो रही है. It should be clear right now. Okay, thank you so much Parv. Clear everyone? ओके, ठीक है. इट शुड बी क्लियर. ऐसे नहीं कि नोट कर लिया, कुछ बच्चे लिख देते हैं बाद में देखेंगे. बाद कुछ नहीं है, अभी ये सब जो है वो अभी है. ठीक है, ऑलराइट. टोटल नहीं बेटा, नहीं. श्रेया, पामर भी 4 है ना, पामर भी 4 है और डोर्सल भी 4 है. मैंने दोनों की गिनती कराई है ना आपको. देखो पामर 4 कौन कौन से हैं? 1 2 3 एंड 4. दीज आर 4 पामर. डोर्सल 4 कौन कौन से हैं? लेट मी शो यू अगेन द डोर्सल. सी, दिस इज 1, दिस इज 2, दिस इज 3 एंड दिस इज 4. टोटल 4 डोर्सल एंड 4 पामर. नो, इट इज नॉट किशन. इट्स नॉट कि एडक्टर पॉलिसिस क्यों है. इट इज देयर, बट आई एम सेइंग हु मींस इफ एडक्टर पॉलिसिस इज देयर देन it is like a kind of add-on. Are you understanding? Look at it this way. You cannot have like a completely devoid of one movement. For one movement, if 2 muscles are there, it is like kind of add-on. But for each muscle, for each movement, minimum 1 muscle is required. That's what I am telling. For if one movement, 2 muscles are there, that is good, very well and good. But minimum 1 to required hai na? That was the question. Adduction is done by palmar of thumb. Yes, also adductor pollicis. That is correct, Arshad. I am saying for each movement, at least one muscle should be there. Is it clear now? It should not be there कि कोई movement नहीं हो पाएगा ना, otherwise abductor के लिए और muscles भी हैं. Abductor pollicis longus is also there. Abductor pollicis brevis is also there. Are you understanding now? Abductor pollicis longus भी तो है, abductor pollicis brevis भी है. ठीक है. आई हैव जस्ट टोल्ड कि डोर्सल नहीं है वहां पे, डोर्सल इंट्रोसियाई नहीं है. इवन इफ डोर्सल, द आइडिया ऑफ द क्वेश्चन वाज, even if dorsal interossei is not there, that does not mean there will be no abduction of the thumb. The abduction of thumb will be there by the other muscles. I hope it is clear now. Yes, everyone? All right. Now we are done up to the muscles of palm. Only one topic is there in the palm, that is the blood supply. Okay, I will write the palmar arches. Okay, I'll write the palmar arches and then it will be done. See, this is the palmar arch. This is the palmar arch. Superficial and deep palmar arch. These are made by the arteries. Ulnar artery is there and the radial artery is there. The ulnar artery and the radial artery, they both are making, ulnar artery and the radial artery both are making the arches together. Is that fine? ठीक है. Now again, this is the most important session of the day. Why this is most important session of the day? Because you see the post lunch session, and the post lunch session, you know, it is again something that you are kind of, है ना, थोड़ा सा sleepy भी feel करते हो, है ना. But let me tell you, with this particular topic, there's one small story which we have experienced in our colleges, right? So what happens here? See, normally what happens, like in our colleges, that day we were discussing ki first we start with the foreign books, then we start with the Indian author books, and then before exam we realize कि ये सब भी बहुत ज़्यादा है, ये भी हो नहीं रहा है ना. Then we go to our देवता स्वरूप seniors room, है ना. देवता के जैसे seniors के room में हम चले जाते हैं, और फिर वो सीनियर्स भी कुछ हमारी बुक्स पे टिक लगाते हैं, इधर उधर दो चार जगह टिक लगाएंगे, पूरा कॉन्फिडेंस से बोलेंगे बस इसमें से ही आएगा, और हम लोग बाहर ऐसे निकलते जिससे एग्जाम पास हो गया हो, एकदम बड़ा कंटेंटमेंट के साथ, एकदम बड़ा सेटिस्फेक्शन के साथ. यस, है ना. उसके बाद बड़ा लगता है कि अब तो हो गया बस, जैसे समझ लो कि सीनियर्स ने लगा दिया हमारा टिक मार्क. इंपॉर्टेंट. और सीनियर्स ऐसे बता रहे होते हैं जैसे उन्होंने बहुत महारत हासिल की है. वो ये नहीं बताते कि एग्जाम के टाइम उनकी क्या हालत थी, है ना. बट यो भी हो, सीनियर्स भी अपना टाइम का बड़ा एंजॉय करते हैं, बड़ी फील लेते हैं कि हाँ आ गए बच्चे, चलो, मतलब बड़ा ऐसे उनको गॉड फादर टाइप फीलिंग आती है ना. तो अब ऐसे ऐसे ही कॉलेजेस में, हॉस्टल्स में आपने देखा होगा कि देन देयर आर सर्टेन सीनियर्स कि जिनके जिनके पास ना जूनियर्स जाते नहीं है पूछने, बिकॉज दो सीनियर्स दे हैव एक्सपर्टीज इन सम अदर वर्क. यू आर अंडरस्टैंडिंग मे बी, है ना. ये थोड़े से प्रभावशाली लोग हैं, इन्फ्लुएंशियल सीनियर्स हैं, जिनके दूसरे एक्स्ट्रा करिकुलर मतलब जो एक्टिविटीज है वहां पे ज्यादा रोल होता है. करिकुलर जो पार्ट है, एकेडमिक पार्ट है, वहां पे थोड़े से इनका हाथ तंग होता है. तो लेकिन अब ये भी सीनियर हैं, इनके भी मन में भावना होती है कि नहीं भाई, हमसे ही पूछा जाए, हम भी सीनियर हैं, हम भी बताएंगे, है ना. व्हाई नॉट मी, आई विल ऑल्सो टेल, है ना. तो ऐसे ही लाइक आई एम जस्ट शेयरिंग कि व्हेन आई वाज फर्स्ट ईयर स्टूडेंट एंड आई हैड टू राइट एनाटॉमी एग्जाम, बिफोर दैट देयर वाज सच सीनियर इन माय हॉस्टल, एंड मतलब उनसे जरा खौफ ज्यादा था, है ना, डर ज्यादा लगता था उनसे. इज्जत तो थी सभी सीनियर्स की, वैसे भी रहती है मन में क्योंकि खौफ होता है. तो उन्होंने बुला लिया एग्जाम से पहले, कहते संदीप इधर आओ. मैंने कहा हाँ जी. कहते कल एनाटॉमी का एग्जाम है. मैंने कहा हाँ जी. कहते तुम्हें इतना तो पता चल ही जाएगा कि जो क्वेश्चन है वो अपर लिम्ब से पूछा गया है कि लोअर लिम्ब से पूछा गया है. अब मैं लगा सोचने कि कल जब क्वेश्चन आएगा तो क्वेश्चन में तो आंसर ही लगाएंगे ना, ये थोड़ी लिखेंगे क्वेश्चन में कि ये अपर लिम्ब से पूछा गया है, ये थोरेक्स से पूछा गया है, ये एब्डोमेन से, ऐसे थोड़ी टॉपिक थोड़ी लिख के आएंगे. हमें तो क्वेश्चन का आंसर लिखना है. बट अब ये बात मैं सीनियर को नहीं कह सकता था, और आई थिंक यू कैन कोरिलेट कि भैया क्यों नहीं कह सकते थे हम सीनियर्स को, है ना, और हमारे टाइम पे थोड़ा ज्यादा स्ट्रिक्टनेस भी थी। अब हमारे जो बॉस थे, उन बॉस को मैंने कहा हाँ जी उतना तो पता चल ही जाएगा कि कौन से टॉपिक से आएगा। अब वो बोल रहे हैं बस बन गई बात। मैंने कहा अरे बन गई बात, इतना ही करना था, पढ़ने की जरूरत नहीं है। कह रहा है कि अगर तो तुम्हें क्वेश्चन में आंसर आता है और डायग्राम आता है, तब तो तुम वही ड्रॉ करो जो प्रॉपर बनता है। बाय चांस तुम्हें डायग्राम नहीं आता तो कोई दिक्कत नहीं है। सपोज तुम्हें अपर लिम का क्वेश्चन आया है, अपना हाथ रखना पेपर पे और ड्रॉ कर देना। मैंने कहा यार सही है, बंदा मानना पड़ेगा ना, कंसेप्ट मतलब सॉलिड कंसेप्ट, कि मतलब अपर लिम से आया है तो हाथ रख के ड्रॉ कर दो और अपर लिम का कोई क्वेश्चन आंसर लग जाएगा। अब ये पूछने की हिम्मत नहीं थी कि भैया अगर लोअर लिम का क्वेश्चन आया हो तो जूते उते खोल के पैर रख के भी ड्रॉ करना है। बट ये समटाइम्स है ना कि आप मन ही मन में कुछ सोच रहे हो पर आपको कह नहीं पाते हो उस समय ना। बट अब क्या है कि ये हाँ, नहीं नहीं नहीं, मैंने बोस वर्ड तो बोला है, बट आई पास फ्रॉम असम। आई डिड माई ग्रेजुएशन इन असम, दैट्स व्हाई आई कैन स्पीक असमीज एंड बंगाली लैंग्वेज, है ना। वो एक बच्चे बंगाली में भी बात कर रहे थे। बट एनीवे, तो अ, अब ये जो डायग्राम, कमिंग डायग्राम है, इसमें हम लोग हैंड ड्रॉ करने वाले हैं। व्हेन आई ड्रॉ दिस डायग्राम आई ऑलवेज रिमेम्बर दैट सीनियर की, हाँ ऐसे उन्होंने बताया था कि भैया हाथ रख दो तो बात बन जाए, है ना। और दूसरी एक कॉमन बात होती है, अब भैया पेरिनियम और एब्डोमेन के लिए आप ड्रॉ थोड़ी करके आओगे, वो तो जनरल बात थी भैया। आप आप उसको लिटरली ले गए हैं। अरे बाबा, शांत शांत शांत, ठीक है, अब समझो इस बात पे। ऑल राइट, तो ये जैसे एक स्टोरी थी, है ना। एक्चुअल ये मतलब स्टोरी कोई मेड अप स्टोरी नहीं थी, ये सच की बात है। बट अब ये है कि कई बार है ना, हम हमारे साथ कुछ ऐसे छोटे छोटे इंसिडेंसेस, देयर आर सर्टेन स्मॉल स्मॉल इंसिडेंसेस इन आवर लाइफ दैट वी रिमेम्बर, है ना, कि यार ऐसे मतलब, एंड दे हैव द इम्पैक्ट। एंड ऑल्सो यू सी, नाउ लेट अस राइट डाउन कि हमारे जो आर्चेस ऑफ पाम है हमारे, कैसे वो बनते हैं, ठीक है, आर्टेरियल आर्चेस और द पामर आर्चेस। खूब दारुण, ठीक আছে, ভালো। लेट अस स्टार्ट। पामर आर्चेस कैसे हमारे बनते हैं, सी दिस इज द डायग्राम दैट आई वाज टॉकिंग अबाउट, कि अगर आपको नहीं आता हो तो ऐसे आप बना सकते हो। एक और भी कॉमन बात रहती है कि क्वेश्चन छोड़ना नहीं है ना। ऑलवेज द सीनियर टेल, क्वेश्चन आए या नहीं आए आंसर लिख के आना है, राइट। Right, on the radial side we have this radial artery, right? Radial side we have this radial artery, and on the ulnar side we have the ulnar artery. This is ulnar artery, and this is radial artery. Fine, this is radial artery. Okay, now understand, this is ulnar artery. It will continue as superficial palmar arch. It will continue as superficial palmar arch. Arch will be completed by the branch of radial artery, and the radial artery will continue as the deep palmar arch, which will be completed by the branch from ulnar artery. This is deep palmar arch. This is deep palmar arch, and this one is superficial palmar arch. Now look at the diagram and tell me, superficial palmar arch is a continuation of which artery? It is a continuation of ulnar artery. It is completed by which artery? Completed by radial artery. Whereas deep palmar arch is a continuation of which artery? It is a continuation of radial artery. It is completed by which artery? It is completed by a branch of ulnar artery. Is that fine? Yes. Second thing, now do this exercise. You have to outstretch your thumb. You have to outstretch your thumb. When you outstretch your thumb, you will see the two borders, proximal border and the distal border. Proximal border and the distal border. From the proximal border, if you draw a line, this gives you the position of deep palmar arch. And the distal border, if you draw a line, this gives you the position of superficial palmar arch. Remember, superficial and deep palmar arches are they are basically present at the deep, proximal and the distal border of outstretched thumb. Deep वाला proximal है, superficial वाला distal है. Is that okay? Is that okay? So now the surface marking is clear. Now the continuation of which artery is also clear. Let us write down about the branches. From the superficial palmar arch, this branch is given off, which will take care of this aspect of the little finger. Then it gives three common branches. These common branches will supply the adjacent surfaces, adjacent sides of the fingers, like this. So basically, if you look at the distribution, which part of the palm or fingers is not supplied? You see, complete thumb is not supplied. No part of the thumb has been supplied, and the index, the radial aspect of the index is not supplied. Radial aspect of the index is not supplied. To cover that part, from the radial artery, there is this branch coming, which is the principal artery of thumb. That is why it has got a name, that arteria. It is arteria princeps pollicis. Arteria princeps pollicis. Arteria princeps pollicis means the principal artery of thumb, the main artery of thumb. It is a branch of radial artery. It is a branch of radial artery. Also, we can say that another branch from radial artery comes and supplies the radial aspect of index. It is called as arteria radialis indicis. Arteria radialis indicis. Arteria radialis indicis. Fine. Clear? Superficial palmar arch, deep palmar arch, and these are the important branches, right? I hope it is clear now. Arteria radialis indicis, arteria princeps pollicis, these are the branches from the radial artery, and from the ulnar artery basically the arches are formed, which is taking care of the rest of the distribution. Okay, is that clear? Yes. Once you are done up to this, tell me, then we are going to write about the nerves. We are going to write about the nerves. Are you guys done up to this? Can we start the nerves? Yes. All right, let me start with the radial nerve. Let me start with the radial nerve. Okay, surface marking means the proximal border of the thumb and the distal border of the thumb. Surface marking of the arches means the proximal border of the thumb and the distal border. ये आपको करके देखना है बेटा, आप अपने हाथ में करके देखो, इसको स्ट्रेच करो थंब को, फिर दो लाइनें मिलेंगी ना, एक प्रॉक्सिमल लाइन जो पहले वाली है, एक डिस्टल जो बाद वाली है ना. All right, now let us write down the radial nerve. Fine. Now see, before drawing the diagram, let me tell you, muscles supplied by radial nerve muscles supplied directly by the radial nerve, not by its branch, can be remembered by the mnemonic beat. Please write down with me. What is beat? Is brachioradialis, ECRL. What is that? Extensor carpi radialis longus. And anconius. Along with that, triceps. Now we can understand that brachioradialis and ECRL are taking the supply directly from the radial nerve, because if you remember, they were above the elbow. You remember, brachioradialis and ECRL were above the elbow. I have shown you in the diagram. Yes, and triceps is also above the elbow. Triceps is here. So above elbow, the radial nerve has not divided. So radial nerve will directly supply these muscles. But why anconius? Because anconius is nothing but it is a detached part of medial head of triceps. Okay, during evolution, this has happened, that it is a detached part of medial head of triceps. Okay, and now it will maintain the nerve supply. That nerve supply will come from the radial nerve. Okay, please note down this. Then I am going to give you one schematic diagram that will help you understanding all aspect of the radial nerve. See, suppose this is humerus. Suppose this is humerus, right? Suppose this is humerus. What is this part? Medial epicondyle. What is this? This is medial epicondyle. What is this? This is lateral epicondyle. Are you understanding? Medial epicondyle and lateral epicondyle. And if you are looking at the humerus from front, you know that behind it, that means on the posterior surface, we have a groove. This groove is nothing but spiral groove or the radial groove. Do you appreciate? Yes. Now from the axilla, the nerve comes, it goes behind the humerus. It goes behind the humerus, passes into the spiral groove, then it is on the lateral aspect and it reaches in front of the lateral epicondyle. It reaches in front of the lateral epicondyle. Finally, at the level of it, lateral epicondyle, it will divide into two branches, superficial branch and the deep branch. The deep branch will pass between the two heads of supinator. It will pass between the two heads of supinator. And this nerve comes like this. This is deep branch. This is deep branch. And this one is superficial branch. Deep branch has got a name, posterior interosseous nerve. Posterior interosseous nerve. Remember two important points about superficial branch. Superficial branch lies under cover of, it lies under cover of brachioradialis. It lies under cover of brachioradialis. Okay, and it is a cutaneous branch. It is a cutaneous branch. Cutaneous branch. In case of its compression, injury sign. Now the hashtag is the injury sign. Okay. Now in case of its compression, there is condition called as chiralgia. There is a condition called as chiralgia parasthetica. Chiralgia parasthetica. Okay, are you understanding this? What I have told, that the superficial branch, important points, lies under cover of brachioradialis, first point. Second point, it is a cutaneous branch, so it is not going to supply any muscle, only skin. And if the nerve is compressed by the tight bands or something, then there will be condition called as chiralgia parasthetica. And the other branch here is the deep branch, which is also called as posterior interosseous nerve, where it is going to supply, this is going to supply all extensors. It is going to supply all extensors other than beat, but we are basically looking at ECRB. We are basically looking at ECRB, ECU and extensor digitorum. Why? I will tell you, but for time being, write down that all extensors are supplied by posterior interosseous nerve. If all extensors are supplied by posterior interosseous nerve, what is the beat muscle? How it gets the supply? See, in the axilla, please understand, in the axilla, it is going to supply the lateral head, also the medial head. Sorry, the long head, not the lateral head. Long head and the medial head. Long head and the medial head in the axilla. When it is passing above, when it is passing through the groove, it will give one branch above and below. Above will supply which head? Lateral head. We have seen already, you remember, lateral head lies above the groove. I have shown you in the diagram. And medial head lies below the groove. You remember? The branch which is coming to medial head will supply the medial head of triceps. After it has supplied the medial head, it will not end. It will continue to supply anconeus, because anconeus is nothing but the detached part of medial head. Are you understanding? The branch will be given to lateral head and the medial head. Branch to medial head will continue further up to anconeus. And here in this part, it is going to supply these muscles. One of them is brachialis. Now I am writing brachialis in bracket. Why? Brachialis will get the supply from the radial nerve, but it does not belong to extensor group. That's why I have put it in the bracket. And some authors believe that it is not the motor nerve supply, it is only proprioceptive. So some authors believe that it is only proprioceptive supply. So that is why I have kept in the bracket, because brachialis belong to flexor compartment, not the extensor compartment. Other muscles which take the supply from here is brachioradialis and ECRL and ECRL. Is that fine? Are you understanding this? So this is the complete story of radial nerve, that it comes from the axilla. Okay, it comes from the axilla, passes through the spiral groove, gives branches to lateral head and the medial head. Okay, yes, Ishan, that is true. It takes the supply from the axilla as well as from the spiral groove, है ना? रेडियल ब्रांचेस जो है एक्सिला में भी सप्लाई कर रही हैं और स्पाइरल ग्रूव में भी सप्लाई कर रही हैं. दैट इज ट्रू. Okay, then it also supplies the brachioradialis, ECRL, and then it divides. After division, जो भी एक्सटेंसर ग्रुप की मसल हैं इनको इंक्लूड करते हुए जितनी भी हमने एक्सटेंसर ग्रुप में पढ़ी है, पोस्टीरियर कंपार्टमेंट में पढ़ी हैं, all muscles are supplied by posterior introosseous nerve. Other than beat, remember simply, other than beat, all extensors are supplied by posterior introosseous nerve. Okay, regarding superficial branch we have taken, these are important points about the superficial branch of radial nerve. No बेटा no. ट्राइसेप्स में अगर मसल्स किसी भी मसल के लिए, फॉर एनी मसल्स टू बी कॉल्ड, फॉर एनी मसल टू बी कॉल्ड एज हाइब्रिड, टू डिफरेंट नर्व सप्लाई शुड बी कम. Brachialis can be called, not the triceps. Brachialis, look at the brachialis, it has got two nerve supply, radial nerve and the musculocutaneous nerve. Triceps is having same nerves, different branches from the same nerve only. Yes, beta, is there should not be any confusion. I have written now. I'll tell you the clinical importance also. Please note down. Done. Now see where the injury can take place. See, injury can take place in the axilla. I'm writing A here. A. Injury can take place in the spiral groove. I'm writing B here. B. Injury can take place here at the level of lateral epicondyle. I'm writing C. Or injury can occur only to the deep branch. It is called as posterior introosseous nerve injury. Posterior introosseous nerve injury. ठीक है? D. A B C D. Ishan, I remember you from Tiwari House. Ishan, I remember you from Tiwari House class. Are you in regular batch now or in foundation batch, Ishan? Study well. You are going to do really well in exam. I know. Okay. All my dear students, you have to keep working hard. I know you are going to excel. Okay. When you excel, at least give me a message that, sir, I have got this rank or maybe this seat. Okay. All right. Regular, na? I do remember you. All right. Final year. Very good. ठीक है. यहाँ तक हो गया आपका? Okay. See now, why I have written A, B, C, D. See what will happen at different sites. Sometimes question is asked. Question is asked in this manner. That's why I have given A, B, C, D. Let me write A. When there is injury at A, what will happen? We are going to see three joints basically: elbow, wrist, and finger. Finger means MCP joint. Finger means MCP joint. See, I don't ignore any message, but you see sometimes WhatsApp or personal messengers show so many number of messages, hai na? And then sometimes it is difficult to retrieve. So that is why we ask students to write on the club, because in the club we get the notification and we can go back to the same post again. Okay, suppose we are busy, we have seen some post, but then later when we are free we can go back to the post. That is the difference, right? Otherwise I try my level best to answer on WhatsApp, on personal messenger always, but sometimes chances are there because of so many messages that doubts may remain है ना unsolved. Okay. हाँ हाँ आई अंडरस्टैंड. डाउट्स ही पूछोगे तुमने और क्या क्या बातें करनी है व्हाट्सएप पे मेरे साथ. दैट्स फाइन. ऑलराइट. So elbow, wrist, and finger. See, why I'm taking these three joints, because the radial nerve supplies the muscles which are responsible for extension on the elbow, extension on the wrist, and the extension of the fingers. We will see ki if there is injury at A level. Now tell me quickly, be with me. If the injury is at A level, no muscle is going to get the nerve supply. No muscle is going to get the nerve supply. Yes, this is the diagram. Are you understanding? No muscle is going to get the nerve supply. If the muscle is not getting the nerve supply, then there will be no extension possible at elbow. There will be no extension possible at wrist. There will be no extension possible at finger. I am showing you the down arrow means no extension possible. What we are testing extension. Is that okay? Did you understand? Now B. Okay, just follow, go with me, and you will understand it in a better manner. Okay, B. What will happen when there is injury at B level? See, come here. If there is injury at B level, now one part of triceps is getting the supply, whereas this part of triceps is not getting the supply. Are you understanding? One part of triceps is getting the supply. So by triceps is weak, not paralyzed. Are you understanding? Extension of tricep, extension of elbow is weak, not absent. That is the important point here. So what we can say, in case of B injury, there will be weak extension possible, right? But extension of wrist absent, extension of finger absent. Now this condition is very, very important. Why? In exam they don't mention weak thing, they simply mention the absent thing. Means a patient has come to you with the wrist drop and the finger drop. The classical language of the question, patient has come to you with the wrist drop and finger drop. Where is the lesion? Lesion is in the spiral groove. Okay, it is also here in the axilla, but in axilla again elbow extension is also not possible. Are you understanding? So if the wrist drop and the finger drop patient has come to you, which is called as spiral groove injury or Saturday night palsy. It is also called as Saturday night palsy. Fine, Saturday night palsy. Now what happens in C level? In C level C, let us go back to the diagram and understand. At C level, triceps, all heads are taking the supply, triceps taking the supply, and one of the carpi is also taking the supply. Okay, carpi means wrist. For the wrist extensor, we have three wrist extensor. What are the wrist extensor? For the elbow, which muscle we are testing? For elbow, we are testing the triceps. For the wrist, which muscle we are testing? We are testing ECRL, ECRB, and ECU. And for finger, we are testing extensor digitorum mainly. Extensor digitorum mainly. Are you understanding now? Okay. Now see, what will happen at C level? C level, this is completely normal. This is completely normal. Elbow extension will be all right. But out of three extensors, one extensor is getting the supply. ECRL is all right. So there will be weak extension possible. It is not absent. Are you understanding? Because one of the extensor is there, but there will be wrist drop. So, but there will be finger drop. That means no extension possible at finger. Now compare B and C. What is happening at B level? Wrist drop with finger drop. What is happening at C level? Only finger drop, no wrist drop. Are you understanding? This is the language of the question. If they change one word, answer will be different. That is why I am focusing here. I hope you are understanding it. I hope you are understanding it. Now D is the D is examiner's favorite. I don't know why, but this has been asked. D. What will happen at D level? There will be normal triceps, there will be weak wrist, and there will be see the finger drop only. Now you see what is the difference between C and D. Compare C and D. C and D is same. Yes. There must be one difference. Yes. What is the difference? Look at it. See, D is pure motor loss. Understand this. डी की इंजरी होने से पहले सुपरफिशियल ब्रांच सेपरेट हो गया. बिफोर डी द सुपरफिशियल ब्रांच इज सेपरेट. इफ द सुपरफिशियल ब्रांच इज सेपरेट, नाउ there will be, I mean, cutaneous, no cutaneous involvement. Are you understanding? But in case of A, B, and C, motor loss plus cutaneous loss will be there. Where will be the lesion at C? C means lateral epicondyle fracture. One of the possibilities, lateral epicondyle fracture. Is that fine now? So let us write down one information here. In case of A, B, and C, cutaneous loss present. In case of D, only motor loss. There is no cutaneous loss. Is that okay? Did you understand? Right? Have you understood the radial nerve means? Basically what we have done, we have reduced the radial nerve in one diagram and one table. Are you understanding? When you are revising at later date, it will be very easy for you to look at the diagram and compare with the table, and you have to remember only the important points A, B, C, D, what is happening and why these features we are getting. And I have already marked the important points. I have already told where the questions are asked. I hope it is clear now. I hope it is going to help you later when you are going for revision and just before the exam, right? So it will save a lot of your time and you will get good marks. Let us come to the new next nerve, that is median nerve. Median nerve, right? Median nerve. Median nerve. See, again the same bone. We have the humerus, medial epicondyle, lateral epicondyle. Fine. D is posterior interosseous nerve injury. It is directly given in exam like that. That in case of posterior interosseous nerve injury. I'll show one question which was asked in the exam. Now see this. We have two roots, lateral root and the medial root of the median nerve. Then median nerve will pass through the arm region, does not give any branch. And here when it enters into the forearm, it is passing through the two heads of pronator teres. It passes between two heads of pronator teres. Then in the forearm this nerve is having its territory. In the forearm it is going to supply all the muscles. What are the muscles it is going to supply? Pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, right? Along with this, it will give one deep branch. Deep branch is anterior interosseous nerve, which is going to take care of flexor pollicis longus, pronator quadratus, flexor digitorum profundus, lateral half. Basically, this portion we have discussed while discussing the forearm. You remember? While discussing the forearm, this information we have already taken. You remember? The only thing is now we are looking at the diagrammatic representation. Now comes the very important part here, the carpal tunnel. Now this is something very important here to understand, that the nerve passes deep to the flexor retinaculum. So I am going to use the dotted lines. It passes deep to flexor retinaculum. Okay, and once it has reached the palm, it is going to supply some muscles. Which muscles it is going to supply now? It is going to supply the abductor pollicis brevis. It is going to supply flexor pollicis brevis, only superficial head. Deep head is supplied by the ulnar nerve, and then it is also going to supply the opponens pollicis. opponent's policies. Also, it is going to supply lumbrical 1 and 2. These are the motor branches. These are the motor branches. Now, one very important concept coming. I want every one of you, please focus. Please focus. There is this branch of the median nerve which is coming above the flexor retinaculum. What is the name of this branch? This branch is palmar cutaneous branch. This branch is palmar cutaneous nerve. Okay, and there is this branch given from the main trunk. There is this branch given from the main trunk. What is the name of this branch? This is digital cutaneous branch, digital cutaneous nerve. Is that fine? Now, what is the meaning of it? Let me explain the meaning. Let me explain the meaning. See, we are looking at hand. ठीक है? We have the palm region, we have the digits. Now, palm is going to supply in the palmar cutaneous branch is going to supply in the palm, and the digital cutaneous nerve is going to supply in the digits. Are you understanding how many digits? 1, 2, 3 and half. This is the territory. This is the territory of the median nerve. Are you understanding? Palmar cutaneous branch and the digital cutaneous branch. If you have understood this, now, my dear students, you were talking about the carpal tunnel syndrome. What will happen in the carpal tunnel syndrome? If carpal tunnel syndrome occurs, there is a compression of this part. This part. Tell me which sensation will be intact. Palmar sensation will be intact or the digital sensation will be intact? Which sensation will be intact? When there is carpal tunnel syndrome, patient will present to you with palmar sensation intact because palmar cutaneous nerve is coming above the flexor retinaculum. Whatever is happening deep to it, it has nothing to do with that. Are you understanding? This is very important anatomy here because palmar cutaneous nerve is coming above the flexor retinaculum. तो जो भी कार्पल टनल सिंड्रोम में नीचे हो रहा है उससे कुछ लेना देना नहीं है. Palmar sensations will be intact. Yes, and the digital sensations will be lost. Are you understanding this? Yes. Now, regarding the injuries for the median nerve, we can call it as like if the injury takes place here, we can call it as A, or if the injury takes place here, we can call it as B. Now let us write down what is A and B. What is A and B? A is called as high median nerve injury. A is called as high median nerve injury. हाई मीडियन नर्व को प्रॉक्सिमल मीडियन नर्व भी बोलते हैं. हाई मीडियन नर्व इंजरी और सम बुक्स राइट प्रॉक्सिमल मीडियन नर्व इंजरी, सेम थिंग. Okay, what will be gone? See, in this case, what will be the effect here? See, both the pronators are gone, pronator teres and pronator quadratus. So one of the feature will be loss of pronation because both the pronators are gone, so the patient won't be able to pronate. Loss of pronation. Is that fine? Pronator teres and pronator quadratus both are gone, so there will be loss of pronation. Is that clear? Yes. Now, when you ask the patient to make the fist, making the fist means ऐसे fist बनाने के लिए बोलोगे, this requires the flexion of the fingers. Now, these two fingers, the lateral two fingers are supplied by flexor digitorum profundus, which are supplied by the median nerve. Whether these are supplied by ulnar nerve. So medial 2 will be flexed, lateral 2 will not be flexed. Lateral 2 will not be flexed. It is called as Pope's blessing, as if Pope is blessing. Are you understanding? Pope blessing. Pope blessing is also called as benediction hand. Pope blessing or benediction hand. Or sometimes in Indian author books, it is written as pointing index. What is the meaning of pointing index? Meaning is when you are flexing these two fingers, a little bit middle finger is also flexed. It is not flexed because it muscle is acting. It's not flexed because the muscle is working. It is flexed because of the tendon attachment with the ring finger. Okay, are you understanding? Let me repeat. What is I am describing that because of flexor digitorum profundus, lateral half gone, because of lateral half gone, All right, beta. Thank you. If you have understood and you are appreciating, very good. What I have told, that flexor digitorum profundus lateral half is gone, and what will happen here? You ask the patient to flex, so there will be sign which is called as Pope blessing. There will be sign which is called as Pope blessing, which is also called as benediction hand, which is also called as benediction hand. Okay, Pope blessing or benediction hand. Fine. Now see the next part here. It is also called as pointing index. Why pointing index? Because you see, why pointing index? देखो क्या होता है कि when you are flexing this, a little bit middle finger is also flexing because of the attachment of the tendon. Okay. Now this is about the tendons which are getting affected here. Lower down, if the nerve is gone here, everything will be gone here. In the palm, there will be loss of opposition because of opponent's policies. So because of opponent's policies, it will lead to loss of opposition. It will lead to loss of opposition. Now, loss of opposition means apes thumb deformity. Why? You see, we have some evolutionary point are there, है ना? The opposition thumb is the thumb of man. Ape thumb does not have the capability of opposition. When you lose the capability of opposition because of opponent's policies, paralysis, it is equivalent to ape thumb. Because अब आपका भी thumb opposition में जाएगा ही नहीं. This movement, opposition movement, which is required for counting, that is not possible. So it is called as ape thumb deformity. It is called as ape thumb deformity because now the opposition is lost. Are you understanding? Because the opposition is lost. Yes, loss of opposition moment, ape thumb deformity. Yes, is it clear? Is it clear? Now what will happen injury at B level? What will happen injury at B level? Injury at B level is low median nerve injury. Low median nerve injury. Low median nerve injury means, you see, whether there will be loss of pronation. If B, low median nerve injury means carpal tunnel. Low median nerve injury means carpal tunnel. Carpal tunnel. ठीक है, carpal tunnel syndrome. Carpal tunnel syndrome. इसका मतलब इसमें no loss of pronation, वो तो intact रहेंगे. No loss of pronation and no pointing index. No pointing index. Okay, but ape thumb deformity तो होगा. Ape thumb deformity will be the only feature. Ape thumb deformity. Along with that, very important finding that we have discussed already here in the A, high injury, palmar and digital sensations lost. Palmar and digital sensation lost. On this side, palmar sensation intact. On this side, palmar sensation intact. I hope it is clear now. I have given you the diagram and this comparable table, A and B, high median nerve injury, low median nerve injury. Yes, if it is done, we can proceed with the last nerve. Okay, we can proceed with the last nerve, that is ulnar nerve. Ulnar nerve. Okay, let us write down next nerve, ulnar nerve. In the same way, we will trace the fibers. Ulnar nerve. So we have this bone, the humerus, and with the medial and lateral epicondyles are there. Medial and lateral epicondyles are there. Now ulnar nerve coming from the axilla, it will pass behind the medial epicondyle. This is something very important. It is behind the medial epicondyle. It is behind the medial epicondyle. You remember, in the medial epicondyle, if you ऐसे करो, यहाँ पे छुओ अपने मीडियल एपिकोंडाइल के पीछे, you touch, you will see some current coming, निकले करंट तेरे एल्बो तो, है ना? तो ये व्हाट इज दिस न्यूक्लियर करंट इज बिकॉज ऑफ द अल्नर नर्व, है ना? इट इज प्रेजेंट बिहाइंड द मीडियल एपिकोंडाइल. आफ्टर दैट when it enters the forearm, it will pass between the two heads of flexor carpi ulnaris, and while passing through it, it will supply this muscle. And after that, it is also going to supply one more muscle. What is that? Flexor digitorum, flexor digitorum profundus, flexor digitorum profundus. Which half? Medial half. Flexor digitorum profundus. Which half? Medial half. Now see, then comes the flexor retinaculum, and now the nerve wants to enter into the palm. It will be passing superficial to the flexor retinaculum. It will be passing superficial to the flexor retinaculum, and it will keep on supplying in the palm. Palm is the territory of ulnar nerve. Forearm is the territory of the median nerve, right? In the palm, it is going to supply almost all the muscles. Which muscles? See, it is going to supply hypothenar muscles. It is going to supply hypothenar muscles. It is going to supply palmar interossei muscles. It is going to supply dorsal interossei muscle. It is also going to supply hypothenar, palmar interossei, dorsal interossei, and there is lumbrical third and lumbrical four. It is also going to supply flexor pollicis brevis, deep head, and last it is going to supply adductor pollicis. Now you have understood that so many muscles are supplied by the ulnar nerve in the palm region. So palm is the territory. Palm is the territory. ठीक है? Palm is the territory. Clear? Right? Now you have written down these points. Let us talk about the injuries. Now for ulnar nerve, we are going to write A here. A. Why I am taking A? Because most of the territory is in the palm region. So most of the feature will be seen here. And this is B. So what is A now? What is A? Is low ulnar nerve injury. Everyone please be with me. Very important concept coming. In case of low ulnar nerve injury, what will happen? Because of adductor pollicis gone, there will be loss of adduction of thumb. Thumb will lose adduction, है ना? Loss of adduction of thumb. Loss of adduction of thumb. Then we have palmar interossei and dorsal interossei. Because of these gone, there will be loss of adduction and abduction of fingers. Are you understanding? Fingers will not be able to adduct, fingers will not be able to abduct also, because palmar and dorsal interossei both are gone. Fine? ठीक है, यहां तक समझ आ गया आपको? And what else will be seen here? Because of lumbrical 3 and lumbrical 4 affected. You remember lumbricals, what do? They act on the MCP joint and the IP joint. MCP flexion, IP extension. But if they are not working, MCP will undergo extension and IP will undergo flexion. Right? So this is called as claw. But claw will only be seen in third and fourth finger, not all lumbricals. So this is specifically called as ulnar claw. This is called as ulnar claw. Are you understanding? Ulnar claw. Yes? Clear hai? This part should be clear. Right? But now let me add one very important and one little detail here. What is that? When I say flexion not possible, so it will undergo extension. Why? Because it will undergo extension because the long extensors are working. Long extensors are working, na? because of the long extensors, because of the long extensor muscle, because of the long extensor muscle, it will undergo extension. And when I say IP will undergo flexion, why? Because of the long flexor muscle. What is long extensor? Extensor digitorum. What is long flexor? Flexor digitorum superficialis, flexor digitorum profundus. Are you understanding? Flexor pollicis brevis, deep head. Flexor pollicis brevis, beta, it has got two heads, superficial head and the deep head. Okay, deep head is supplied by ulnar nerve. Ulnar nerve is very deep. It supplies deep muscles. Fine. Have you understood this much? Is it clear to every one of you? Is it clear to every one of you? Yes. Now come to B, high ulnar nerve. Quickly you have to answer. Okay. High ulnar nerve. You have to tell me whether it is clear or not clear. Okay. Now I am going to write high ulnar nerve. High ulnar nerve. High ulnar nerve injury. High ulnar nerve injury. See, these all will be present here. These all will be present here. That's fine. But these are the loss of action. When you check for the clinical picture, okay, you check for the clinical picture, okay, loss of reduction is there, loss of reduction is there, that is fine. But this claw is not what you are checking. It is the patient coming with it. Are you understanding? It is a feature. Did you understand? It is a feature. Patient will come with it. But what about this? Now look here. When the high ulnar nerve injury is there, then FDP, which is a cause of claw, when high ulnar nerve injury is there, see, whatever was going here will be gone. But additionally, FDP will be gone. Do you agree? This will also be gone. FDP was a reason for the claw. I have explained why the claw develops, because the long flexors are working. Now I am telling one of the muscle is not working. One of the important muscle for the claw not working. Tell me, if the claw cause of the claw is gone, the claw will be more severe or less severe? FDP, which is the cause of claw, one of the cause of claw, it is also gone. Now the clawing will be there, but the clawing will be more severe or less severe? Tell me. Clawing will be more severe or less severe? So there will be less severe claw. Less severe claw. Why? Because one of the cause is also gone. Now if you look at the number of muscles, when we are going above, more number of muscles are paralyzed. But when we are talking about the clinical feature the patient is presenting with, then you look at the severity, it is less severe. So normally we do not expect this. Normally we expect when more number of muscles are paralyzed, higher is the lesion, more severe should be the clinical feature. What is happening? Higher is the lesion, more number of muscles paralyzed, but less severe is the presentation. So it is not normal. It is called as paradox. It is called as paradox. What is ulnar paradox? It is very, very important. Ulnar paradox. Ulnar paradox means high ulnar nerve injury. High ulnar nerve injury leading to less severe clawing. Less severe clawing. Is that clear? Yes. All right, beta. Now we are done up with the nerves also. Okay, so by and large we have finished the upper limb part. The next topic, the last topic for the day, is breast tissue or the mammary gland. Breast tissue or the mammary gland from the anatomy point of view. Breast tissue or the mammary gland. Now see, we have what is the extent from lateral sternal border, lateral sternal border to mid axillary line. This is the horizontal extent, but what is the vertical extent? Vertical extent is from second to sixth rib. Second to sixth rib. Are you understanding? So vertical extent is second to sixth rib, and the horizontal extent is lateral sternal border to mid axillary line. Yes, is that okay? Okay. Now let me draw about the blood supply for the breast tissue or the mammary gland. What is important for us to understand? The arterial supply and the lymphatic drainage. These two are important topics. Why? Because now the cases of breast carcinoma are like increasing in number, and let me tell you, it is not only anatomy that you are reading, you are again going to read in surgery, and it is not only that you are going to read in surgery, in your clinical life also. You choose whatever stream, you will definitely come across the breast carcinoma patient. Okay. All right. Superficial injury of ulna involved in which it can be involved in case of like you see if there is a in case of like kind of fracture. Clawing will be less severe. FDS is still working. Shreya, FDS is still working. Na? FDP is gone. FDS is still working. Okay. Now let us talk about the arterial supply, blood supply. See, this is breast tissue, and this is the sternum. This is sternum, and this is the breast tissue, and this is the axillary artery. Try to understand this part. This is axillary artery. Axillary artery. Now, if you remember, we have learned the axillary artery gives three parts, and from three parts, different branches are given off. You remember that? From first part, there is this artery, which is called as superior thoracic artery. From second part, acromiothoracic and lateral thoracic. You remember? Acromiothoracic, lateral thoracic, and from the third part it gives subscapular artery. So basically axillary artery will give the branches to breast other than Acha and Pacha. Acha and Pacha to humeral arteries hai na. The Acha and Pacha are the humeral arteries. Other than these two, remaining all are going to supply the breast. Is that clear? All right. Now let me give you one artery here in the parasternal position. We have discussed about this artery. You have to tell me what is this artery which is going to divide in the sixth intercostal space into two branches. Tell me what is the name of this artery? Very good. It is internal thoracic artery. Very good. The internal thoracic artery was giving anterior intercostal arteries. You remember that? Along with that, it is also going to take care of the medial aspect of the breast. That is why these are called as medial mammary branches. These are called as medial mammary branches. Medial mammary branches. And the axillary artery branches are called as lateral mammary branches. Lateral mammary branches. Okay. I will talk about the sensations. I have not given that diagram. I will show. First, let me finish this. That is not done, beta. Sensory, I will tell. Okay. And now please focus. See, where is the breast tissue present? Understand this part. Breast tissue is present in the cutaneous tissue, and the fatty tissue it is present. Deep to it is the chest wall. Deep is the chest wall. Chest wall is consisting of the ribs. In the ribs, we have intercostal arteries. Are you understanding? Suppose this is the chest wall. I am showing the ribs. In between the ribs, we have the arteries, and over it we have the breast tissue. So if the breast tissue is above it, the arteries will be supplying from the deeper aspect also. Are you understanding? The intercostal arteries will be supplying from the deeper aspect of the breast. So if I show you in the dotted manner like this, what are these arteries? These are posterior intercostal arteries which will be supplying in the deeper aspect. Although it is not a very significant type of, the blood supply. The most important blood supply is the axillary. Next is the medial mammary branches from the internal thoracic, but still it is there. What are these branches? These branches are deep branches, है ना? You can say the deep arteries. From where they are coming? They are supplied by posterior intercostal arteries. They are supplied by posterior intercostal artery. Are you understanding this? Okay, of course you have to remember, and of course you have to draw, but at the same time you must have a picture that okay, from where the arteries are coming and how it is supplying, like that. Yes. Are we done up to this? Are we done up to this? Yes. Next topic is the lymphatic drainage. Next topic is the lymphatic drainage. Lymphatic drainage. Lymphatic drainage of the breast. Now, before writing the lymphatic drainage of the breast, let me give you one general point about the lymphatic drainage. Suppose in your exam there is a question on the lymphatic drainage, and you just somehow forgot what was the lymphatic drainage for what. But at the same time, you have to remember, if you remember the arterial supply, but you forgot the lymphatic drainage, then do not worry, do not lose hope, because if you remember the arterial supply, you are most likely to go, you are going to write the right answer, the correct answer. Okay, what is your question? Why not anterior intercostal arteries? From where the position of anterior intercostal artery में तो यहाँ से direct supply आ रही है ना बेटा, medial mammary branches में. ये medial mammary branches दे रही है ना, they are giving in second to fourth intercostal space, in second to fourth intercostal space. ये कंटिन्यूअस नहीं है, ओनली सेकंड टू फोर्थ इंटरकोस्टल स्पेस है. ये डीप ब्रांचेस भी सेकंड टू फोर्थ इंटरकोस्टल स्पेस है. दे ऑल्सो सप्लाई इन दिस स्पेसेस. ओके, क्लियर नाउ? एंटीरियर वाली लोकेशन पे तो मिडिल मेमोरी डायरेक्ट ब्रांच दे रही है ना वहां से. ऑलराइट, now understand what I have told you, that if in case you forgot that what was the lymphatic drainage, but you remember that the arterial supply, then you will be able to take the calculated guess. This is the breast tissue and this is the sternum. Now please pay attention everyone carefully. If you remember, now we forgot which lymph node is supplying, draining it, but we remember the most important blood supply was axillary artery. If the most important blood supply was axillary artery, so the most lymph will be drained into the axillary lymph node. Are you understanding? Into the axillary lymph node. In the axillary lymph node, we further have groups like anterior, posterior, central, apical, but the majority of the lymph will be draining into the axillary lymph node. Okay, and see this part here. Now the next artery was seen in the parasternal position. If you remember, what was the name of the artery? Internal thoracic. Now we can say that the lymph will also be draining into the parasternal position. Lymph will also be draining into the parasternal position, parasternal lymph node. Are you understanding? Yes. The lymph from the parasternal lymph nodes, if suppose the malignancy is there, the malignant cells, they can cross the midline and the unilateral breast carcinoma will become bilateral breast carcinoma. Are you understanding? The lymphatics which are going to the parasternal lymph nodes, if the malignant cells are there, they can metastasize to the opposite side. Are you understanding? So unilateral breast carcinoma will become bilateral breast carcinoma. Yes. And then at the same time, you must remember this quadrant. This quadrant of the breast is important. Why? This quadrant of the breast, the lower and inner quadrant will be drained into, it will make subperitoneal plexus here. It is going to drain into subperitoneal plexus. Subperitoneal plexus, and from the subperitoneal plexus, it will spread to the peritoneal tissue. That means abdominal organs. Peritoneal is present in the abdominal wall cavity, isn't it? So the secondaries will be seen in the other organs. Usually secondary is seen in the ovary. Yes, tell me what is the name of the tumor if it involves ovary, and the secondary deposits in the ovary are called as Krukenberg tumor. Krukenberg tumor. Yes, is that okay? Did you understand? Yes. All right. Very good. Very good. Now see, sometime question is asked that if the malignant cells infiltrate, if the malignant cell infiltrate, where? Now it will depend on the which anatomical structure they are infiltrating. Suppose the malignant cells infiltrate the Cooper's ligament or the ligament of Cooper, what will happen? And if the malignant cells infiltrate the lactiferous duct, what will happen? Or if they infiltrate the subdermal lymphatic, then what is going to happen? Now you have to tell me. If the ligament of Cooper is gone, see, remember, normally what happens, the breast tissue is mobile in all the direction, okay, because we have the retromammary space. But if the ligament of Cooper is involved, those will be kind of adhered, and then the mobility of the breast tissue will be lost. You can say the tissue will become fixed, okay, the tissue will become fixed, the mobility will be lost because of the ligament of the Cooper is infiltrated. If the lactiferous duct is infiltrated, lactiferous duct open below the areola in the nipple region. If the lactiferous duct contracts because of the infiltration by the malignant cells, if the lactiferous duct contracts because of the malignant cells infiltration, the nipple will be inverted. Are you understanding? The nipple will be inverted. There will be inverted nipple or retracted nipple, you can say. Retracted or inverted, retracted nipple. And if the subdermal lymphatics are blocked, suppose subdermal lymphatics are blocked, there will be, generalized swelling of the breast tissue, right? But at the position of the ligament of Cooper, the swelling will not be seen, leading to what will happen now? Leading to peau d'orange arrangement. Peau d'orange. This appearance is because of involvement of subdermal lymphatics. Yes, guys, are you done up to this? Yes, now the last part. We are done with the breast part here. The cutaneous distribution in the palm, in the palmar aspect and in the dorsal aspect. Let me show you that picture and then I will give you the schematic diagram. Okay, let me show you the picture, then I will give you the schematic diagram. See this. Classically, what we used to tell, that lateral 3.5 on the palmar aspect supplied by median and medial 1.5 supplied by ulnar. And classically, we were telling that lateral 3.5 on the dorsal aspect by the radial, and ulnar, classically we were telling that 1.5 on the dorsal aspect. Why I'm using the word classically? Because this has been updated. So what is the updated? Please understand, those who have already taken the update, very well and good. Those who have not updated themselves, please understand like this. So this is the distribution. Now on the dorsal aspect, we don't say 3.5, we say 2, and this is 2.5. So 2.5 is the distribution of the radial nerve, and 1 and 2.5 is the distribution of the ulnar nerve. So on the dorsal aspect, now 2.5. It's not 3.5 and 1.5. Okay, so this is the picture in nutshell that you need to draw. Okay, that lateral 3.5 by the median, medial 1.5 by the ulnar. Okay, on the dorsal side 2.5 and 2.5, except distal phalanx. Except distal phalanx. Distal phalanx is 3.5 by median. Distal phalanx except 3.5 by the median nerve. ठीक है, ओके चलो मैं एक काम करता हूँ, आपको ये डायग्राम ड्रॉ कर देता हूँ यहाँ पे स्कीमेटिक. यू रिमेंबर माय सीनियर? Now this diagram will help us understanding. This is palmar aspect, this is dorsal aspect. In the palmar aspect 1, 2, 3 and half, it is supplied by median, and this is supplied by ulnar. Medial is supplying lateral 3.5. Ulnar is supplying medial 1.5. Okay. On the dorsal side, 1, 2.5. 1, 2.5 is supplied by radial, and this is supplied by ulnar. Okay, lateral 2.5, medial 2.5, right? But distal phalanx are still supplied. Distal phalanx in lateral 3.5 by median. It is because of the Soumya, it is because of the understanding, है ना? As I told कि updated information का मतलब है कि हमारी understanding change हो गई है subject की, है ना? It is updated in Grace 41 and also updated in BDC and other textbooks, okay, in the recent editions. You see, when you keep on like studying, na, at the gross level, also at the micro level, है ना? Now, if you are done, please tell me. We will take few questions are there. We will take the questions. We are done with this part. Yes. Please tell me when you are done. I'll start the question. Done? Everyone's done? Okay. Take this question now. Now understand. Finger drop with no wrist drop. Finger drop with no wrist drop is due to the lesion of. What is your answer? Finger drop only. Now finger drop only means B. B is the answer here. Posterior interosseous nerve. But see, as I was telling, if there is a little change in the language of the question, answer will be different. If I remove the word no, finger drop with wrist drop, then answer will be A. Then answer will be A. Are you understanding? This was the meaning when I was describing. Okay, now that I have given you the diagrams of the nerves also with the tables, है ना? I hope that this part is clear to you and you will not make any mistake. For some, this may be a little difficult topic, but for my students, I believe you have a good command on such topics. Okay? You have this command? Yes or no? Tell me, is it clear? Ulnar paradox means, tell me, ulnar paradox. It's a straightforward question. There should be no doubt. At high level injury, we were expecting more severe claw hand, but the patient presented to you with the less severe. Yes, the answer is high level injury, less severe claw hand. Okay. Now this question, intracapsular but extrasynovial. Intracapsular but extrasynovial. Straightforward again, long head of biceps brachii. I have explained, I have given you the line diagram also. Yes? नहीं बेटा, ये this class is for foundation and pre-foundation, and few regular batch students are attending. Otherwise, this class is for foundation and pre-foundation. Pody orange appearance occurs due to, yes, blockade of subdermal lymphatics. Blockade of subdermal lymphatics. Flexion of MCP and extension of IP is the major action of. Flexion of MCP and the extension of IP is the major action of lumbricals. Lumbricals. Fine, lumbricals. Okay. Now, if I change this question, look at the language. Flexion of MCP and extension of IP is the action of all except. Now, what is your answer? Now, what is your answer? Now, answer is FDS, because lumbricals will do primarily and these two will do secondarily, means they help the lumbricals. FDS will not help in this. FDS is only doing the flexion. It will not do extension part, right? So, answer to this question will be D in this case. Okay. All right. Very good. So, you have learned. Very well and good. Very good, beta. Okay. So now today's topic is complete. Okay. In the next class, we will begin. In the next class, we will do the general embryology. We have not done the general embryology, and that general embryology will be followed by the lower limb. Okay. General embryology, initial segment, and then that will be followed by the lower limb. Is that fine? Yes. Up for the story. This is the story of legend. Everyone knows this story. It's a kind of reminder, है ना? And take home message from this story, right? See, when Sachin Tendulkar was like in his debut match against Pakistan, okay, so there was this pacer from Pakistan who was doing the, you see, kind of very fast bowling, and one of the ball hit the nose of Sachin Tendulkar, है ना? तो उस बार में क्या हुआ है कि जब सचिन का nose started bleeding and non-striking and Sidhu was playing, and Sidhu came to Sachin and he told कि देखो आपको चोट लग गई है, if you want to take rest, you want to get like retired hurt, that's fine, we will understand, क्योंकि आपको चोट लगी है, natural सी बात है, we will understand, है ना? तो that moment Sachin decided and told मैं खेलेगा, and then Sachin played and rest is the history. We know कि उसके बाद से वो legend बन गया, ठीक है? The question is, the take home message is कि हमारी लाइफ में भी, प्लीज अंडरस्टैंड एवरीवन, हमारी लाइफ में भी ऐसे बहुत सारे मौके आते हैं. देयर आर वेरियस इंस्टेंसेस इन आवर लाइफ व्हेन वी हैव टू टेल आवरसेल्फ नो, मैं खेलेगा, ठीक है? कब? अब इसके बाद आपकी लाइफ में जब भी कोई डिफिकल्ट मोमेंट आए तो रिमेंबर दिस लेजेंड एंड टेल टू योरसेल्फ मैं खेलेगा, ठीक है? स्टार्टिंग में यू मे फील दैट यू आर फेकिंग, दैट यू आर लाइंग टू योरसेल्फ, बट you have to somehow gather the, you see, all the strength that is required. चाहे शुरू में उधार ले लो, शुरू में फेक करो, but somehow अपने आप को keep on telling मैं खेलेगा, I will do it, I will do it, and really you will do it, I'm telling you. Okay, all right, thank you so much everyone, thank you so much, and remember this message for those who understand Hindi. ठुकरा दिया जिन्होंने मुझे मेरा वक्त देखकर कसम खाता हूं ऐसा वक्त लाऊंगा कि मिलना पड़ेगा मुझसे वक्त लेकर। ओके, ऑल राइट, ऑल द वेरी बेस्ट, है ना। दिस इज योर इंस्पिरेशन, दिस इज योर मोटिवेशन। और आराम से अपने आप को इतना प्रिपेयर कर देना है। ऑल राइट, थैंक यू सो मच। ठीक है।